बुक लेके ये वाला बुक ठीक है इसके सपोर्ट में रहेगा। इसको खोलिए, उसको खोलिए, नहीं गिर जाएगा, उधर रहेगा तो गिरेगा हवा से। इसको सामने रहने तो पड़ गया, हवा वो गिर रहा है। ऐसे था ना? हाँ कैसे था? हाँ थोड़ा सा उधर पर उन्होंने सन लगा के हो गया। ये तो उठा दूंगा यहाँ से, उठा लेके आइए, लेके आइए, लेके आइए, खोल के लाए कैसे? सेट तो क्या है? ये वहां रख दो सर। हाँ वहां इसको ले क्या लगा क्या लगा?
इसको शेयर भी करना होगा आपको, तब नहीं इसमें दिखेगा।
चलो
आगे आगे शेयर हो गया। शेयर में पीपीटी शेयर करके आपको शेयर करना है। तो यहाँ से आप क्लिक करेंगे तो
we begin, please try to keep your phone in silent or vibration mode. Let's not try to interrupt the speakers during their deliberation. The speaking time for the speakers will be about 25 minutes. At 20 minutes, there will be a beeper, and I request the chairpersons to kindly ensure a smooth flow of the sessions because we have a tight schedule. And all felicitations of the chairpersons and the speakers will happen at the end of each sessions in the selfie point, which is constructed just outside the conference hall. Washrooms are there on the right hand side and the left hand side of this hall. There are 3 emergency exits, 2 on the left, 1 on the right. Kindly locate your emergency exit in case it is necessary for safety sake. And lastly, we are feeling really blessed to have been gathered here on the auspicious days of Holy Mahashivratri. And I wish and I hope that Lord Shiva will bestow his blessings on each and every one of us. And once again, welcome to the holy city of Varanasi. And without further ado, let's begin the sessions. I now call Dr. Lovely to introduce the chairpersons.
Good morning, everyone. With the spirit of innovation and academic rigor, we now commence the scientific proceedings of the day. Starting with session 1 of today's scientific program, it is my distinct honor to invite our esteemed chairpersons for this session. I respectfully invite Professor Anil Parihar, for Professor, Head of Department of Radiology, KGMC, Professor Pradyut Prakash, Professor, Department of Microbiology, IMS BHU, Professor Vivek Srivastav, Professor, Department of General Surgery, IMS BHU, to kindly grace the dais and preside over this session. I request the chairpersons to kindly introduce the first speaker for this session.
So, a very good morning to all of you. On behalf of the organizing committee, we welcome all of you on this auspicious day of Mahashivratri to Kashi and to Banaras Hindu University. So, to start with the first session, we have our first speaker, Dr. Rajul Rastogi, who is a professor in Tirthankar Mahavir Medical College and Research Center, Moradabad. He is a radiologist, and his keen areas of interest are clinical radiology research and training in advanced imaging, including ultrasonography, computed tomography, MRI, and AI in healthcare. So he will be a very apt speaker for this kickstart of this session. He has published multiple publications, around 215 in national and international journals, with 821 Google Scholar citations. He has guided a multiple around 100 theses in MD and PhD and more than 50 chapters in textbooks of radiology, anesthesia, and endocrinology. He has been conferred with the Dr. VP Lakhanpal Gold Medal 2004 by the Indian College of Radiology and Imaging and KM Rai Memorial Oration in 2010. So a multiple of fellowships he has been conferred and various awards have been given to him. So we'll be delighted to hear about the deliberations by Dr. Rajul Rastogi. So please welcome.
So, good morning, respected chairpersons, and thank you for the nice introduction. And at the outset, I would like to thank the organizers for having me at this auspicious place on this auspicious day. So, I wish all of you a happy Mahashivratri. And in the next 20-25 minutes, we'll be talking about the role of the artificial intelligence in the Indian healthcare scenario, what all we can do, and what all we have been doing, and what the future has for healthcare through AI. So I'll be taking you through a little bit few slides about the foundation, how the AI works in diagnostics and medical imaging, the precision treatment and personalized medicine, how it can accelerate the drug discovery and clinical trials, how it helps us in operational efficiency of the healthcare system and the virtual care. And of course, no technology comes without our responsibility. So we'll be discussing a little bit about the ethical imperative, challenges and risks, and we'll take some take-home messages. Sorry. So first of all, it's not just a hype. Now we are actually entering into the reality of artificial intelligence. So just to complete those who are not still into AI, to understand how the AI works. So it actually tries to mimic a human cognitive functions to solve various complex problems, just like the humans are doing it. And it involves the learning, problem solving, and decision making. So it is basically a prediction. Then what is machine learning? The core technology is creating algorithms which are trained on a large amount of data sets that comes from electronic health records. It may be the various images like radiology, pathology, and of course the genomics, to find the different patterns, and these are the subvisual characteristics within the image. And the goal, that I will repeat again and again, it is not to replace the doctors, but it will act as a powerful co-pilot, enhancing the speed, accuracy, and the time efficiency of our work. There are certain terminologies, so just a little bit about this. So artificial intelligence basically has been there in engineering for a very, very long time, almost 50 years since it has started in the engineering domain. Then machine learning is creating algorithms that the machine learns from the data to make specific predictions. So if you are giving a specific data, the machine will perform a given task. Deep learning refers to neural networks that analyze the image-based patterns. So there are certain patterns that we all recognize during radiology, pathology, and similarly, the AI algorithms are also trained to understand those patterns. But when it comes to convolutional neural networks, so we all know that the neural networks are there in the human brain and it performs a very complex task. So the purpose of CNN is to look at those patterns which are not visible to the human eye. So we are talking of subvisual information. Then there is generative adversarial networks. It is primarily used for enhancing the images and synthesis. For example, it is being used in ultrasound machines, MRs, at the time of acquisition of the data. And then there are recurrent neural network, which helps in handling the temporal or the sequential temporal data. So it's not displaying. Yes. So recurrent neural networks helps in handling the sequential or a temporal data. So if we have a patient and he has got a data over a period of 30 days of hospitalization, 15 days, so it can assess this and give analysis. So now, why the AI has been there for diagnosis in the healthcare? Because we are coming from lagging to the leading time. So we just want to reduce the time of diagnosis. So the key point is the AI can process any type of medical data, maybe the images, it may be the genetic sequences, it may be the EHR data, and it is performing this hundreds of times faster than the humans. So it enables early diagnosis, and we all know that early diagnosis is translated into early management and a good prognosis. The impact will be there will be a reduction in significant reduction in the time between the symptom onset and the confirmed diagnosis. So it is very important in critical care as well as the cancer patients. So first of all, coming to the computer vision. So we have all been seeing that the computers can visualize. So, but when it comes to the medical imaging, it is a subvisual data. So whatever we can understand, the machine do not learn in that manner. It tries to identify certain other patterns which are not visible to the human eye. And it is based on millions of scans. So if we are trying to use 100 scans or maybe 200 scans, so it might not be always correct in a different data set. So this is very useful and it has been there for almost a decade, specifically in screening of cancers. For example, mammograms and the lung cancer detection on a low dose CT on the in the chest. So this has been for almost a decade. Recently, or maybe in the last 5-7 years, the stroke is again identified. So here the algorithm identifies the hemorrhage versus ischemia immediately, while at the time the scan is complete. So it gives a uh, flag to the radiologist, and he can immediately look at those scans and can deliver the information to the clinician. It can also automatically prioritize the scans with urgent findings which he has to report. So if you have a task list of 10 cases, so it can flag that this patient particularly refers to a critical care. So we can look at those scans first rather than the other ones. So microscopic and ocular insight. So it's not just radiology. AI can analyze the digital biopsy slides also. It can again identify the different type of data. It can identify the tumor cells. It can grade the tumor cells and can even predict the response with high precision. So there has been a tool like this by the name of Path AI. And the basic purpose is not to replace the humans. Humans will always be in the loop. But we all know that when we come at 9 o'clock in the morning to a duty, and during the day if we are going back with the last biopsy reading at 4 p.m, so our accuracies may not be same during the entire day of work. Similarly, in ophthalmology, the experts may not be available everywhere. So the retinal diseases like diabetic retinopathy and glaucoma, which are the major causes of loss of the vision, so they can be diagnosed based on good clinical fundus photographs at a distance. So this is very useful when we are looking at mass screening of the population. AI is capable of predicting the diagnostics and risk forecasting. So how does it do this? So it actually takes the data from the electronic health records, which we can feed. It can take the vital signs, and it is very useful when we are talking of the sepsis management. So there are a lot of scores that we are commonly using in critical care, like the SOFA score is there in pediatrics, P SOFA is there, then there is NEWS2 and the speed. The purpose of all these scores is basically to identify those patients which may go into early organ failure, not at the, they were not in the organ failure at the time of the admission, but maybe 10 hours or 20 hours later, they may enter into an organ failure. So we all do manually, but imagine if a critical care specialist is looking after the ICU, he has got 5 or 10 patients to look after. So will he get enough time, and can he do justice to all the patients? So it may not be possible always. So we can train an algorithm based on certain scores, and this AI will definitely give the score, and it will also chart it with the time. It can also predict the readmission risk based on the data that has been provided from the past in the from the electronic health record. So it can predict whether this patient will be needing readmission. So it helps in telling the prognosis to the patient as well. And specifically in chronic diseases like diabetes and cardiovascular cases, so if a person has got a specific genetic trait, or there are clinical symptoms, or there may be a lifestyle changes, so the AI can use it for personalized medicine. So we all know that one size will not fit all the patients. So for diagnosis in radiology, already one of the Indian company has already, that is Cure.ai, has created a lot of algorithms which can actually predict the MRI, the CT and X-rays, but for specific characteristics. For example, in MRI, they can do volumetric analysis, it can identify the stroke. Similarly for CT also, and in X-rays, emergencies like pneumothorax, gross pleural effusion, something like this, which really requires our attention at the earliest. The impact is basically the emergency rooms and the remote clinics to instantly screen those head injuries, lung pathologies, which are there, and they immediately require our attention. So we all know we are targeting the early diagnosis and early management. So the metrics is basically the reduced interpretation time from hours to minutes. Now we can use this AI to the precision for adding value to every individual as a person, because we know that one size will not fit. all of us. So it may be based on demography. So the European or the Western data may not be actually suiting our Indian data. And even if it suits, we are 100 and more than 140 billion. So we need actually those data sets which can help us interpret in our domain. So it can analyze vast multimodal data sets going from genomics, lifestyle, and clinical history, and it can truly create an individualized treatment protocols. So as a doctor also we do this, but it takes more time. It can analyze certain data which is not available with us, but when it takes data from the electronic health records from all the domains, so it can be better than what a training or an inexperienced person can do. The goal is to maximize the efficacy and minimize the harmful side effects. So we can use these interpretations for a personalized medicine. Genomics. So we all know that the genomic intelligence can be enhanced by using the artificial intelligence. So AI can rapidly interpret and the sequences and genomes, and it can identify certain mutations and variations within lessest point of time. So if we want to create a genomic data set of our population, it will require high efficiency. So if you know that Scotland is one country where the every citizen from tomb to womb is covered by all the medical data, including the genomics. So this helps in actually giving the personalized medicine. Such information can help in predicting the whether this uh, drug will be well metabolized by the patient or it will lead to certain side effects. So when we combine those genetic data with the drug response, we call it pharmacogenomics. This is very important in case of oncology because the most effective combination of chemotherapy and immunotherapy can be actually based on a tumor specific and a genetic profile of the patient. So this will lead to better outcomes. It will not also leave the surgical domain because we all know that there are a lot of robots that are coming nowadays. So it will get integrated into the robotic systems, and there are certain systems like from Da Vinci and an Indian global company like Merrill. It helps in creating a 3D model which helps in optimizing the surgical paths, and it gives a real-time guidance which is subvisual information that is guiding between the healthy and the unhealthy tissue. So the surgeon is better placed because there are certain things that I cannot see. And it can even assist in automating certain tasks which are repetitive and thereby reducing the fatigue of a surgeon. He can utilize that energy and time to do certain things which actually require his real skill. Then AI can actually change the digital therapeutics and mental health. So there can be software programs or algorithms that deliver clinical interventions to prevent, manage, or treat a particular medical disorder. So AI powers the personalization of these programs. So an example for this is a mental health. So AI chatbots, that is virtual health assistants, are there which provide immediate support. Is maintained about the patient, and the doctors cannot monitor 24 into 7. So the patient knows about himself. The patient data can be transferred critically to expert clinician at the time when the AI gives a alarm. So remote patient monitoring, as I have already said, there can be multiple wearables which can be FDA or CE or maybe are CDSCO approved. And these devices include smartwatches, continuous glucose monitoring, and they will create a large amount of data which cannot be actually analyzed by any human. And it is very difficult to do it. So we can use the artificial intelligence to monitor all this. And these machine learning models will actually detect subtle changes in vital parameters and may signal the deterioration. So it will tell the patient, and if the patient is connected critically to any expert radiologist or maybe a cardiologist for any purpose, so they can be easily utilized for the early intervention. This enables us proactive intervention. This will help in reducing the readmissions, and it will reduce the load of the hospitals as well, so that we can look after all the large population of India, and it allows patients having more independence. So the patient's anxiety and apprehension is not there because he understands that a continuous monitoring of the data is there. So AI can also help in drug discovery. So we all know that the drug discovery takes a very large duration of time, and it costs billions of rupees. So, and it has got a high risk that these molecules that have been developed for a certain purpose may not actually work or may fail in the clinical phase 3 trial. So it has been estimated by some papers say that an average cost of a successful drug is around $2.5. So this fact is very important because developing nations like India does not have spare money to do all this. So if we see in the last 75 years of our independence, not even a single molecule has been developed by the in the Indian subcontinent. Although recently, if we look at the Covaxin, which was developed partly in India, so that is how this AI can help us in the developing nation development of drugs. It will not only help in creating development of the drug, but it will also help in testing. So how it does it do it? It helps in virtual screening. Instead of the physical lab test, it can predict the efficacy, safety, and toxicity of thousands of chemical compounds virtually against a target protein. The generative AI can produce a new molecule actually which has been optimized in all sorts of drug characteristics, and ultimate aim is to reduce the time of development of a drug, and the purpose is more accurate, so there are less failures. So the AI can actually help in all these aspects. It will not only help in developing these drug molecules, virtually testing them, but it will also further streamline our clinical research. So when we are developing any clinical trial, we can also use AI to determine clinical data from the electronic health records that ideally matches the need of the project. So it helps us in accelerating the recruitment of patients and improving the demographic diversity. So the increase in the diversity actually increases the success of AI algorithm. The trial design, so adaptive trial design using AI allows continuous data analysis. So it's not that we will collect all the data and then we will go for to analyze it whether this is really good for us or not, but continuous monitoring can be done with AI as well, and dynamic adjustments can be done to the protocols, maximizing the chances of success. And data analysis can be done in a better manner because the natural language processing tools can be used to extract the relevant information from unstructured medical data. Otherwise, nowadays, when we put the things into the Excel sheet, we have to actually code them numerically so that the softwares can actually analyze this. So NLP helps us in actually analyzing the unstructured medical data as well. So there is one case study where the drug was developed totally with the use of AI, generative AI and reinforcement learning. So this was by In Silico Medicine Company, and they have developed true drugs till date just on the basis of AI, and it is undergoing the phase 3 and phase 4 trials. And the one of the drugs is for idiopathic pulmonary fibrosis, and the other drug is for treating the solid tumors. The achievement by this is we have transitioned from target identification to a clinical trial candidate in a fraction of a traditional time. So this is very important if we want to give more and more treatment and we want to improve the prognosis. So this proves that the AI can deliver novel therapeutic breakthroughs faster and in a cost-effective manner. The AI can also be used for target identification. So digital biopsy, that means the AI analyzes all the omics data sets, that is right from radiomics, that is the subvisual information in the radiology images, then radiogenomics, that is corroborating the genomic data with the radiology images, proteomics when it comes to the RNA, metabolomics when it comes to the biochemistry test, and pharmacogenomics, that is when we are dealing with a personalized medicine or the response to the drugs. So when everything is integrated, we call it integrated diagnostics, and this will actually help us in detecting the biological pathways which are new to us, which have never been uncovered or never thought of in the previous years. And it opens the new possibilities for treating the disease in a different form, or those diseases specifically where still we do not have any known treatment. Now, we all think that the artificial intelligence is working more for diagnosis, right? Or predictions, but it's not like this. It is really working well for health administration. So it has been said that AI can be used to automate the back office of the clinician, because every clinician utilizes one third of his time in administrative tasks, that is paperwork which is related to billing or maybe data entries or maybe the insurance. So whatever notes we are putting, it is going to the electronic health records, and then ultimately it is going to be billed or giving the insurance. So the goal of AI is to automate these tedious and repetitive tasks so that the clinician gets more time to focus on the patient care rather on these uh, tasks. So then natural language processing of the health records and billing can be done. So the electronic health record management can be done. They can be from the unstructured clinical notes, they can be transcribed dictations, and it can extract meaningful data. Then coding and billing can be done automated, and virtual subscribes can be there. So AI can even listen to the patient doctor conversation and can automatically generate clinical summaries where the final summary can be actually validated by the consultant. Then we have already talked about health assistant and chatbots. They can be used for patient engagement, specifically when it comes to the routine FAQs, and it can be there 24/7 into 365 days. It can help in the preliminary symptom assessment and triage in cases of critical care, so that the patient can go to the appropriate level of care. And of course, it can also help in reminding the consultation and in determining the drug reaction that the patient may be facing at home. And it also gives alarms that there is minimization of the missed doses and improved compliance. Then when we are using the previous data of many years, it can even predict certain things as a resource, hospital planning. So it can forecast based on what is the previous data, the real-time data, what is the incapacity, what is the bed availability. So on that basis, it can actually predict how much staff will be needed. And when it is applied to certain epidemics like malaria or plague or maybe the dengue, so it can actually predict by using the vision AI and the global positioning system, that is the GPS. No technology comes without a responsibility. So we have to understand the ethical imperative. So it is the four things that we always talk of: autonomy, beneficence, non-maleficence, and justice. So these has to be targeted, and the core challenges that will be there with AI is the data bias while development, privacy, transparency, and accountability of whatever we are doing with the patient's data. So these challenges are overcome through a strict regulation. So the Europe has got GDPR, the US has got HIPAA, and recently in India, DPDP Act, which suggests the digital patient data protection. So it was given in 2023, and now there is a further amendment for this. So all the patients should be informed that their data may be used for research purposes, and we will not be sharing their private data in terms of their demography or something like this, which is very critical. So it may actually deter the overall social impact may be there with these data, and it should not be given to any developers without this. Then bias has to be removed so that there is an algorithmic fairness. So we have to use a wider diversity in terms of the gender, the demography, or the different states. So it is always good to have multi-centric data and then validate it at a different centers. So we have three stages. First is training, then testing, and then validation. So validation should always be done on a data which is doesn't belong to us. So it should be on a outside data. So it gives the real purpose of the algorithm. Then transparency of the data should be there. So why the AI has not been adopted by the doctors? Because they don't know why the AI algorithm is giving a certain type of conclusion. So it's like a black box. So we have to develop that transparency, and this is known as explainable AI. So our next esteemed speaker will be talking about this. So in short, it gives a human readable, understandable explanations, algorithms, AI outputs, and scores confidence. So it is something that a clinician can understand why the AI algorithm is giving that type of output, and it creates that confidence for treatment. Then accountability of liability. So again, the accountability and liability, whether the developer, the hospital, the prescribing physician, or the AI itself, who is at fault if the something goes wrong. So that is why there are clear legal and regulatory frameworks which says, irrespective of whatever AI has been adopted, whether by the physician or by the institution, ultimate responsibility is for the treating physician. So that is why all AI algorithms has to come with a human in loop tool.
Dr.
That
Rajat,
is
can we just
one
sum up?
minute, sir. So the long-term benefits are, in the next 5 years, we might see integration of everything, that is integrated diagnostics, and we can even see the patient digital avatars, digital twins, where everything can be tested on the patient digitally, and many of the repetitive systems may become autonomous. So the take-home messages is, the main proposition is a triple win situation, that is high speed and accuracy of our work, the personalization, that is the personalized medicine that we deliver to the patient, and the high efficiency, so low cost and low administrative burden, freeing humans for humans. So in the last, I would like to say that AI won't replace doctors, but it will replace doctors who use AI. But AI won't replace doctors, but doctors who use AI will replace those who don't. Thus, AI in the Indian healthcare can serve as a super engine for the VIKSIT Bharat. So I'm very thankful to my mentor and who is a living legend, Professor Satish Kumar Bhargav, sir. Thank you very much for patient hearing.
Uh, Thank you, sir. It was a very nice deliberation. The house is open for few comments and questions or clarifications, if any. So I think this AI conference is unique in one sense that the chairpersons are not so apt and not so versed with the topic what the presenters are presenting. So just as a common person, I would like to ask that AI in terms of development, like data collection, then the algorithm setting, then checking the algorithms whether they are matching the clinical, acumen or not, and the problems of the AI. So in India, where do you find that the AI is in terms of healthcare is standing as of now?
Sir, as of now, what I feel is all the doctors need to understand that it is not a replacement for humans.
That's sure.
We all need to learn like any technology. One part. Second part, all of us has to contribute because we all belong to different specialities, different domains, different demographies. So India is a very big country. So we have got a wide range of data. So for every project, the leader is a doctor. Then there is a biomedical engineer who will be developing, who will be understanding what you need. So you have to find out a problem, give that problem to the biomedical engineer. He will solve your problem by creating an algorithm, and then you test it. But for that, we need to understand the basics of AI. One thing, you don't need to learn coding. Second very important thing is you need to participate in creating a structured data. So that is called supervised learning. You know that this patient has got this. So that then only you can train the machine. This particular patient will died and this patient survived. So if these are the two parameters, you should have this data. And who can do this? The experts. Once the experts are convinced and then this algorithm is formed, then you test it or validate it in a data which is outside your center. So whenever we are talking of the algorithms that work well, they will be available or they should be successful everywhere. So India is a big country. So if two different institutes are located in two different parts of the country, if it gives a good result, so it is good. We all have to understand that it is very useful. It's just a super assistant. Then the third part is the legality and the biases. So we are the right person. We have been doing research for a long time. We understand what are the biases. AI can help us. We create a good data. We could create a good training model. We validate that model and we give it to everyone. But in that process, we should tell the patient that this data is being used for research. This will not be a divergence of his private information, because for example, just we look at HIV, we say it's a confidential data, right? We don't divulge this information. So such information may be used for research, but it is not known to the developer. So the role of the doctor is very critical. He is at the top of the pyramid. He is guiding the engineers, and finally it will be delivered and deployed in the day-to-day life. So in next 5 years, we will see a good deployment.
Okay, sir. Thank you. I think we are running short of time, so thank you very much for your talk. I think I would like my co-chairperson to introduce the second speaker.
I'd like to invite Professor S.N. Sarvadhikari. He is Chief Medical Information Officer, HITTech Optimus. His area of interest is digital health and education and neuroinformatics. He is fellow of multiple scientific organization. He is co-chair Task Force of AI in Healthcare, National Academy of Medical Sciences. He is expert member of roster for Digital Health World Health Organization. He is IMA honorary professor between 17 and 20. He is founder member of HL7 FHIR Foundation and HL7 ambassador. He is former project director, Center for Health Informatics, National Health Portal. Sir, I request you to kindly go for your presentation on explainable artificial intelligence for predictive modeling in healthcare. Thank you.
Thank you very much. Thanks to the organizers for inviting me. Yesterday, we had an excellent interactive session in the workshop session yesterday afternoon. We had nice learning and unlearning with a hands-on session. Today also, my job has been made easier by Dr. Rajul Rastogi. He started right from the basics of AI and talked about predictive analytics and XAI. So I'll continue from where he left. Before going into the details, just a short background, which is not evident from the slide. I actually started work on AI in this very campus. I did, after MBBS, I did PhD in biomedical engineering from IIT BHU. And this was a publication from that lab, from the School of Biomedical Engineering in IIT BHU in 1995. So I had been using an artificial neural network for differentiating the depressed rats from the non-depressed rats using exercise. Then been working on this, in fact, trying to develop a clinical decision support system. This was when I was working with the Amrita group. And this was a master's thesis of a student in Bharatiya University, where we developed some system for easily differentiating some inborn errors of metabolism or inborn metabolic disorders, where clinically it's very difficult to distinguish between the 30 or so diseases. But with this automated learning system, we could bring it down to about 3 enzymes so that you don't go for the battery of tests. Now we have been working on digital twins and digital triplets, but that's about the background. So in this lecture, what I'll try to cover is what is XAI, what is predictive modeling. Actually, Dr. Rastogi has already covered a bit of it. So that saves some time. Then I'll give some examples of how can this XAI help in healthcare in developing these predictive models. And of course, ethical legal issues also he has touched upon. So I think we'll definitely save time. I think all of you are aware that the World Health Organization now has a health division of digital health, but that's not very old. That was started only in 2019. And one of the first documents that they brought out is this Global Strategy on Digital Health 2020 to 2025, where digital health is defined as a field of knowledge and practice associated with the development and use of digital technologies to improve health. Earlier, we used to call it ICT, Information and Communications Technologies. Now, the term is digital technologies. And whenever we are using digital technologies to improve health, that is digital health. So everything comes under it, whether it's e-health, telehealth, mobile health, everything would be covered under this umbrella definition. A few terms which you may have heard, but not very clear. Digitization is the simplest, of course, converting from analog to digital. When we were kids, we used to see analog televisions. Now you don't see it anywhere. Everything is digital. Even the wall clocks are becoming digital. Digitalization, for those in medicine or cardiology may think of it as a different thing, but here we are talking in terms of digital health. So digitalization is the process of using digital data to simplify the work. That means organization culture. But what we are really aiming at is a digital transformation. That's a complex, multifaceted, and disruptive way of changing the way business gets done. And obviously, it's centered on the public health needs. When we talk about biomedical and health informatics, it's inherently not just multidisciplinary or interdisciplinary, but it's really a transdisciplinary discipline where different people from different domains come and try to work together on the common goal. So what exactly is XAI? That is where the decision-making process of the AI system is made transparent and understandable to the humans. And what is predictive modeling? That is where we are using statistical techniques and historical data to forecast future outcomes. That could be through building models, often using machine learning algorithms to identify patterns and trends that can be used to make predictions about future events or behavior. Here, I'd like to stress upon one very important thing in computer parlance. A very well-known term is GIGO, garbage in, garbage out. And a very good example we got when we saw in this predictive modeling when the COVID-19 pandemic struck. In the initial part, there were lots of predictive modeling all over the world predicting doom. But the world survived. The world didn't have those very scary situations. Why? Because the model is based on the data. And if the data is garbage, that means the data quality is bad, poor, then the outcomes have to be poor. There's no way out of it. So initially, we didn't have enough of data. We didn't know anything at all. So whatever modeling we were doing were based on assumptions. And about assumptions, Fermi had made actually a very nice thing for mathematical modeling. He said, if you give me 4 assumptions, I can make an elephant. And if you allow me 5 assumptions, I can make it wag its tail. So when we have only assumptions instead of real data, models can really do nonsense. So in healthcare, what is predictive modeling? Using data analytics and machine learning for forecasting future health outcomes and trends so that we can have proactive interventions and thereby improve the health outcomes, patient outcomes. So what can be predicted like disease onset, treatment response, hospital readmissions, all these things Dr. Rastogi talked about. So we can get this by analyzing the patient data and historical trends. Models can identify the risk factors, guide the precision medicine. Personalized treatment is precision medicine. And of course, optimize resource allocation. So what are the scopes in predictive modeling? We actually talked about all these. I won't go into the details. Data-driven predictions, statistical algorithms, forecasting future events, personalized interventions, and optimizing the resource allocation. I don't have to go through the slide, but this slide is just to show that each and every department, starting with Dr. Rastogi's radiology, pathology, cardiology, oncology, neurology, genomics, everywhere, drug discovery, each and every discipline of healthcare or medicine, XAI is actually helping in multiple ways. So there are various techniques. I won't go into those details. And for anything, there's a pro and a con. So while there are benefits, but there are also certain challenges. So if you look at this, how can XAI really help? This is actually a picture is slightly big, so maybe it's not very clear, especially those who are sitting behind. But if you look at it, essentially what happens traditionally in automated systems, clinical decision support systems, AI systems, we have been getting some results without knowing why, how. Why was that inference reached? In fact, when I was doing PhD here, I was writing codes in C++. I worked on neural networks way back 3 decades back. Then after submitting my thesis, I did my postdoctoral fellowship in the Indian Statistical Institute, Kolkata, where the first computer in India was actually established. So there also, when I was working on this, we were working on inferencing and rule generation. That means trying to find out exactly how are the artificial neural networks or AI systems, they're trying to reach the results, whatever, recognizing the patterns. So that is what XAI is about. It's not a black box, but we try to explain why are we thinking this. I'll give a simpler picture. This one. This looks the dialogues between the XAI system and the user. So you can actually ask these questions to the system. Why not? What if? How to be? How to still be this? And so on. And these publications are available. I've given the reference also. You can, I think these presentations can be shared easily, or you can simply do a Google search. These are all open access papers. The references that I have given, the full papers are available online in public domain. You can go through it and get into the details. So knowing exactly how is the machine doing this, we also learn a lot. In fact, that is what KDDM or knowledge discovery through data mining is about. So benefits, we have already talked about: improved patient outcomes, reduced healthcare costs, enhanced efficiency, proactive care, and of course, addressing healthcare disparities. Examples, readmission. And in fact, this is one area where the health insurance companies abroad are working a lot. So if there's less readmission following the discharge of a patient, then there's an incentive from the insurance company. So that's a important parameter. In fact, they now have incentives based on this readmissions. Then identifying high-risk patients. So predicting the likelihood of a patient developing a specific condition like heart failure or diabetes, so that you can have early interventions and improved management. Optimizing resource allocation. Again, this is more of a management problem, but an important one. Improving treatment outcomes. And here again, personalized precision medicine is being used. Personalized care plans are also being used. So this is another paper where it is actually showing how this acute critical illness can actually be predicted. So here they're done a scoring system, and based on the data from the EHR, from the, say, ECG and imaging techniques, then feeding through the neural network and getting the predictions. Why is it critical? Why is XAI so important? Because the very first thing that it does is it increases the trust. So AI-driven diagnoses are interpretable and accountable. It's emerging to assist in the communication of internal decisions, behavior, and actions for the healthcare professionals. Then through explaining the prediction outcomes, XAI gains the trust of the clinicians so that they can learn how to apply the predictive model in practical situations instead of blindly following the predictions. Of course, there are still many scenarios to explore how to make XAI effective in clinical settings, because medical knowledge, as you know, is inherently complex. And those of you who are not aware, as of now, the medical knowledge is doubling every 2 months. In about 60 days or so, the medical knowledge is doubling. So it is humanly impossible for any individual to remain up to date. That's a reality that should sink in. We may not like to listen to it or agree to it, but it's a reality. And there's no way that we can do without the help of these systems. So, of course, as I said, anything good will also have bad. So if there's a pros, there would be cons, and there are lots of gaps. So the gaps are in the scope of the model, in the modeling approach, in the technology, in the implementation. And for each of these gaps, various solutions are being tried. Maybe one is better than the other for a particular purpose, may not be all. A lot of, like any experiment, a lot of hit and trial is involved. So it's going on, and I won't go into the details of this, but this is just to stress that there are gaps and there are solutions being tried to fill the gaps. Dr. Rastogi also touched upon the wearables, the Fitbits, the Apple Watches, and the Google Watches, and whatnot. Again, for that, XAI is very important because it is actually saying why is this happening rather than just giving a observation. So for all sorts of implants, we also have this cardiovascular implants, neurostimulators, then the dental implants, orthopedic surgery. For each and every sort of implant of prosthetics, we can have this XAI embedded in that. Now, what are the challenges of this XAI and smart implants? Of course, autonomy and security, there are issues. Then regulatory hurdles, AI is still unregulated, more or less. And like mobile technology happened before people could know, they found it useful and started using. Regulations came much later. AI, it's happening right now. If you know, in the our national capital, the AI Global Impact Summit is going on, and lots of things are there. And unfortunately, again, healthcare is not really truly represented there. Maybe we need to be more proactive. Bias mitigation, Dr. Rastogi talked about the bias and how we need to mitigate and why we need to mitigate them. Of course, patient acceptance, that's something we need not forget. We have to always keep in mind. So many may be apprehensive about having a health monitoring device implanted. But if we have this XAI embedded in that, then the trust part comes in, because the machine will actually tell you why is this scary or why is this important and what needs to be done. So vast amounts of data are being collected through these wearables. And of course, that can be analyzed for wellness tracking to diagnosing serious conditions. And for clinical applications, obviously for accuracy and building trust, XAI is important. So it can be used for remote patient monitoring, sleep monitoring, fitness and mental health. What are the challenges? Most important is, of course, the user understanding. So the explanations that a doctor will require and the patient will require may be different. And it has to be a proper, simple, user-friendly reports. So there would also be hardware constraints. That means you can have the battery could be limited. Then you need optimization for various purposes. Data handling, this is very important. How do you really deal with the data? And of course, the DPDP Act 2023 and the DPDP regulations, which came out in November 2025, these become very, very important in the Indian context, and we need to be aware. We actually need to have a proper consent under this DPDP Act for any data that we are using for research. Explicit consent that data will be used for research on this purpose, this condition, whatever it is. And if and only if, when we are using the pool data, if the data is anonymized, that means there's no way of re-identifying the patient, then the anonymized data are outside the ambit of this DPDP Act and DPDP rules. But if it's identifiable or even if it's a de-identified data, they come under the ambit of the DPDP Act, like the GDPR or the HIPAA in USA and the European Union. So privacy and security, these are very important and these have to be looked at carefully. We have been writing on this safety issues, not just for workforce training. So you need to know how to develop these things safely, then train them how to evaluate safety, and of course, use them safely. I mean, AI is nothing but a tool, just like a stethoscope, nothing different. Like a knife, whether you use it for cutting vegetables or cutting human beings, it's not the fault of the knife, but the user. So we need to know exactly how to use AI or any other technology for that purpose. So we really need technology-enabled, safe and ethical workforce. Regulatory progress. So the National Health Policy third edition, which came out in 2017, talked about setting up the National Digital Health Authority. But for that, this bill was framed, the DISHA Act, that is the Digital Information Security and Healthcare Act in 2018, which was put in public domain for comments, but then it was withdrawn in favor of what is now the DPDP Act 2023. And as I said, the rules have been notified more than 2 years later in November 2025. And those of you who are aware of the things, just a few days back, there has been a litigation filed in the Supreme Court challenging the constitutionality of the DPDP Act. Certain groups have gone for it. So anyway, as of now, it's a valid act. So we need to be aware of it. The other important relevant act is the Medical Devices Rules 2017 Act, which was amended in 2020. That includes software as medical device. And here we were actually ahead of other countries. In US or UK, actually, they came in later after 2019, but they have given a lot more approvals for software as medical device or SMD. But we have the law since 2017. So software as medical device, and most of these AI-enabled applications will also fall under that. Again, there are two categories. One is software in medical device and software as medical device. I won't go into the details of those, but it's important. So DPDP Act, as well as the medical devices regulations, both these acts are very important, something we need to be careful about, something we need to be aware about and act judiciously. There have been some ethical guidelines ICMR brought out in 2023. In 2023, the National Academy of Medical Sciences also brought out some guidelines. I was the co-chair of the task force for the National Academy of Medical Sciences AI in healthcare. And this also, Dr. Aslugi said that AI will not replace a healthcare professional, but healthcare professionals not using AI will definitely replace healthcare professionals using AI. Why? Because brain and computer together is much greater than either alone. That's the thing you have to remember. The brain has limitations, the computer has limitations, but when they work together, it actually amplifies the actions. That brings to the end of my talk. Thank you very much.
Thank you, Professor Sarvadikari, for a nice presentation. The house is open for discussion.
Yeah, I want to request the chairpersons. Having started late, please don't first session itself. We are running out of time. I have an important question to the previous speaker. So, Madam Sir, you told no need to write coding. Who else will write coding? Out of curiosity, I want to ask whether the engineers will write or doctors will write.
So nowadays, even the engineers do not need to do coding because the generative AI does that. So if it is really developing something new, so they might need to do this. So even engineers are using the generative AI like ChatGPT to create the codes.
Okay. So please give some 3 minutes. You should give warning to the speaker. 5 minutes. We are all come from different parts of the country. I have come from the north, and if you say time running out of the time at the first session, it is not correct. Please, my humble request. Give time to delegates.
Sir, thank you for your.
Thank you, sir.
Thank you, sir, for your wonderful presentation. Sir, your specialty is something in neuroinformatics. Can you please put some light on neuroinformatics? Or some light.
ये तो नया topic छोड़ दिया.
Although it is not your today's topic, but yet.
Yeah, actually, I've been working on brain, as I said, I've been working on animal model of depression. Subsequently, also, I've been doing some, with the help of a biomathematician, I've been doing mathematical modeling. So, my publication that was published in a journal, in a Biomed Central journal, Theoretical Biology and Medical Modeling, T-Biomed. So that was published in 2006, and that has got more than 100 citations so far. It's still cited very regularly. So there, I tried to actually model how do the different quadrants of the brain interact. So there are within the receptor subtypes, the neurotransmitter, any neurotransmitter has got multiple receptor subtypes. And the same neurotransmitter, when it acts on the different types of receptor subtypes of the neurotransmitter receptors, the action is actually opposite. So how do they interact? So when the same neurotransmitter is stimulated, it may both facilitate or inhibit the same action depending on which portion of the brain or which portion of the body it is acting upon. So that is what we have done the modeling and shown the dynamics. So that I've been working, but that's a long time back. I mean, right now I'm not working anymore in that.
Thank you, sir.
Thank you.
Okay, sir. Thank you, sir. And
So, it was a pleasant surprise to see that you were working on neural networks in 1995 on the rats, of course. So, sir, with your vast repertoire of work engagements, I have just simple question. I am a doctor. So why we haven't adopted AI or explainable AI in our day-to-day operational frequencies, like in hospital administration or workflows? Because most of the time our work is taken up by those kinds of work. And I think it could have been easily done. So what has prevented this application of AI in operational?
No, actually, Dr. Rastogi, I think answered that very well. See, for most of the repetitive tasks, which brings us fatigue in human beings, at the same time, the computer is much faster. Like, if I give the example of my previous paper, that was also in 2006 on that inborn metabolic disorders. So there are deficiencies of about 30 enzymes. For that, there's a battery of tests which can be done, which is very costly. But when we use that artificial system, just from the clinical features, it could bring it down to it's the cause of this particular patient is the deficiency of these 3 enzymes, not 30. And you do the confirmatory test. It was done in the lab, and you'll see, yes, one of those 3 enzymes are deficient. That the clinician cannot differentiate because the features are the same. I mean, stunted growth, nausea, vomiting, and so on, those typical things. But when you do those permutation combinations, which the human brain can't do, but machines can do easily. So many of the things where it is possible, where it is repetitive, boring job, they do it quickly, and especially if you think, say, oncology, the diagnosis can be reached much faster, and you can take preventive measures and actually, I mean, halt the progress of the disease. So that there's, in any case of late, I mean, not just cancer, whether it's stroke or heart attack, whatever it is, golden hour we talk about. So time is very important. So quickly, even for emergency conditions, you'll see in emergency what happens. Unfortunately, the most senior people should have been there, but most of the times they're not there anywhere in the world. The junior people who are less experienced have to face emergency where they don't even know exactly what is to be done. There, if you have such systems where you can have checklists, this sort of decision support systems are of various levels. So these checklists are very, very useful. I mean, you can, they won't miss anything. I mean, humans do miss, and especially if a person is doing emergency duty for 36 hours, 48 hours, 72 hours at a stretch, fatigue is inevitable, but machine won't be fatigued.
thank you, sir. We are getting late. So thanks once again for the nice presentation. Right.
Thank you, speakers. It's our privilege to experience such an engaging session. As we conclude this session, I sincerely thank our respected chairpersons. I also request them to kindly proceed to the selfie point for the felicitation. I also request the speakers to move to the selfie point for the felicitation.
We now proceed to the session 2 of this scientific program. It is my privilege to invite the distinguished chairpersons for this session. I respectfully request Dr. V. Satya Suresh Attili, consultant, hemato-oncologist, stem cell transplant, Continental Hospitals, Hyderabad. Professor R.N. Chaurasia, Department of Neurology, IMS BHU. Dr. Abhishek Pandey, Department of General Medicine, IMS BHU, to grace the dais. I now request the chairpersons to kindly commence the session and introduce the speakers for this session.
So, ladies and gentlemen, distinguished experts, guests, researchers, students, good morning. And it is my privilege and honor to welcome our next speaker, Mr. Girish Raghavan, who is an expert in the field of AI in the healthcare. Currently, he is working as a Vice President of Engineering and Chief Technology Officer at GE Healthcare. Mr. Girish Raghavan has a special interest in medical imaging, medical physics, and AI for the healthcare. And I think with no wasting of time, let's welcome with a big round of applause for Mr. Girish Raghavan. So, Mr. Girish, the floor is yours.
Good morning, and sorry for some logistical issues. My laptop. Go next speaker so we get it right. Yeah.
While the logistics are getting set, let's move on to the next topic, which will be delivered by Dr. Kishore Kumar, who is a senior consultant hemato-oncologist and BMT physician at Miyot International Hospitals, Chennai. His areas of interest are myeloma autografts, haploidentical transplants, and CAR T-cell therapies. With almost 32 peer-reviewed international publications and 5 book chapters, we welcome you here, sir. Please proceed.
Sorry.
While the other PPT is being played, I know, Girish, I think we met you somewhere in the Bangalore in one of those meetings, and we're very eager to hear your lesson as well, immediately after Dr. Kishore's. Right? Kishore, over to you, sir, please.
Yeah. Good morning, everyone, and all protocols observed. First of all, thank you for this great initiative. I'm happy to be and deeply grateful to be a part of this initiative by BHU. That's kind of ahead of times, I should say, to be more frank. And a special thanks to Professor K.K. Gupta for that excellent BMT unit. That's a legacy that is standing out there. And special thanks to Nilesh, Shruti, and Abhishek for having me here. So I think, yeah,
When I was asked to talk about AI in hemato-oncology, I want to go back to 2023. I carry the regards and greetings from the state of Tamil Nadu. I'm the secretary of the Tamil Nadu hemato-oncology team, and we had a conference. We had an annual conference that comes up in March, where Professor Pranthar Chakravarti, I gave him a Lifetime Achievement Award and asked him to give a plenary talk, and the talk topic was AI in hematology. That was in 2023. And fast forward 26, when I was looking at his talk and where we are now, in Ramayana, one yuga is called as 12 years, if I'm right. That's the reason Rama was sent for 14 years, so that people just forget him. But in AI technologies, I was just mentioning in 2 months, things are changing. I think 12 days or even 12 hours is something, things are like that fast paced. But a lot of things have been talked about AI. Where are we exactly? Are we the specialist in all those things? I don't think so. My full disclaimer is I was exposed to internet way back as a boomer, maybe for the adult content during my school days. I'm very openly saying that to you. And if you ask me for AI, how I was introduced into AI was I work in a corporate setup. And unfortunately, I don't have academic interns or academic registers who can do the appropriate medical recording or whatever, even summaries, discharge notes, and things like that. So that is the first point. We all of us would have done that, I suppose. Even the SMSs and emails, what you're sending now is all AI drafted. So that is how most of us as doctors who are not directly into technology get exposed to AI, and suddenly an unrealistic over expectation starts setting in. Anything, any technology, any drug, there is an unrealistic over expectation, and slowly the graph drops down and we all come back to niche aa jata hai. So that is where we are, I suppose. So what I try to do here is a lot of has been talked. So I'm not, as I said, I'm not an engineer going into the depth of how things are done, etc., etc. I'm a hemato-oncologist. Sir is also here, a senior faculty. So what we do, how we have tried to do something with this artificial intelligence technology in a very, very naive infant kind of a stage. That is what I will discuss, and I'm very happy to learn from all the people who are sitting out here. Hope this mic I can give it. Let's go, Dedu. Thank you. Yeah. So this is what I'll be doing for today. Some fundamentals of AI in healthcare, very, very basic, that has been extensively covered, I suppose. My specialty, hematology, BMTs, and CAR T-cell therapies, where I'm using it. And how are we trying to go ahead as a faculty of hematology into all these integration on a national level platforms? And what are the real ethical and challenges that are we should be considering, and what is the road ahead? So people have been talking about the different names, machine learning, deep learning, and NLPs and things like that. But more than that, I will say that I'll put it in a different way. These are all for the backend people. To be more frank, we are not going to be greatly involved in all these things. But just few, maybe I invest a lot into stocks, I should say. And I just made the fortune was totally lost last 2 weeks back when the Claude came up with the Claude workspace, which is an agentic AI. Rather than drafting and typing and giving out things, it started thinking on its own. So I think we have gone to that level, a kind of an assistant intern who can actually read our messy notes that has been written up there. So that is the stage where we are. How are we going to use that intern entirely depends upon our personal experience and things like that. When I talk about hematology, why hematology is very special is there is each and every one of you here, for that matter, would have got some blood test some point in. Let it be a sugar or even entering into the hospital, let it be a hepatitis B, viral serology or whatever. So blood is a very unique organ, easily accessible. And that is the reason it has got like the cells. I mean, to be more frank, doing hematology is like doing your MBBS or medicine again. Preclinical stuff to the lab side, look at the microscope, because I used to think that the only way to diagnose cancers or hematological leukemias, etc., were to look at where the slide was broken. Right upper hand broken means it is AML, left upper hand broken means it is AL. That's what I used to do. But entering into the field, I was kind of getting to know that these are all real. The cells do exist and the cells do respond, and we give some nonsense treatment and the patient gets better or worse, can be seen on the microscope level also. But as a clinician, that is something which I'm. So that is out. It's a very data-rich specialty. Billions and billions of cells, billions and billions of genomics, genes, etc., etc. And more than that, there is something called as pattern recognition. That is great. So somebody looks into the microscope and says that there is a starry sky appearance and I got a diagnosis of Burkitt's lymphoma. I look into the microscope, it's all a no moon day, only black appearance is shown up. So those are all the places I personally believe that these kind of technologies can pitch in, and at least like poor students like me, they can be helping me out in making a diagnosis and kind of treating. When it comes to treatment part, again, treatment has become quite complex because hematology is one field. I don't know how many of you remember 2000, year of 2000, the Times Magazine carried a front page saying that the magic bullet of cancer treatment here is here, that is imatinib. Every new innovation, every new drug many times starts with the field of hematology because the cells are very easily accessible, and any research, because doing a research on depression in rats is something which is great, sir has done, but doing a research on a simple blast is very simple because I can repetitively get the samples and this is easily maneuverable. So that way, the technology is expanding, not only the AI technology, the medical technology is expanding that at this point. I still remember when I diagnosed a patient with acute myeloid leukemia 10 years back, the only thing I used to say, if they're more than 50, 60 years, I asked them to write a will first of all, see an advocate, write a will, and then book a ticket to either Kashi or Rameshwaram on my side. So that's the maximum I was doing. Now things have entirely changed, that very personalized medicine has started coming in, and we are also in a setting of a medical legal issue that if I'm not going to discuss those things to the patient may not be affording, that's a different issue. On a legal aspect, it's my duty to at least discuss, give out a precision kind of a personalized medicine. After that, what happens to him, it is his own will or wish. But at least to do that, these technologies are greatly helping me. And the other thing is when I'm doing bone marrow transplants and cellular therapy, unfortunately, things are so critical that the patient works on zero immunity, and hardly if you see within a few hours, sometimes in febrile neutropenic sepsis, you'll be just losing the patient totally. So in those cases, those are all the technologies where small places AI has started pitching in, and I personally feel that is really kind of started helping us to at least make some sense out of this technology toward hemato-oncology. So coming to this fear, yes, will this is a boomer fear, naturally all have. Indeed, I wanted to ask a question to the radiology faculty who started this lecture in the morning. I heard that the NEET PG exams, after the NEET PG exams, when students are selecting out the branches, radiology has been a top branch at one point in time, still today is. Anybody who doesn't want to, not allergic to patients, go to radiology. Sorry to, I'm not demeaning anybody here, but still. But I heard that because of the AI fear, we are all boomers with the AI fear, the number of people kind of who really wanted to take in radiology now getting a second thought, thinking that their jobs are going to be taken over with AI later. This is just again an unrealistic over expectation, maybe unnecessary fear factor, but at least somewhere here it is pitching in. Truth to be told, this has been talked a lot of times. At this point, there are a lot of regulatory things going on. So a doctor remains as a doctor. He is a final decision maker for sure. But anyway, the simple, boring tasks. Sir was mentioning about writing the notes. We have got a healthcare app called as My Healthcare app, which kind of integrates AI into the regular EMR records, but with a kind of a data privacy still maintained, so that some kind of a data input is given of what's happening. So the repetitive task of counting the cells, pattern recognizing, data analysis can all be done in the background, so that talking to those irritating patients, you can spend some more time to the patients. To be more frank, the last chairperson, that was a very logical way of looking at it. Doing all this back and unnecessary, what to say, like administrative job, we kind of miss out on really talking to the patients. I personally believe that talking more to the patients, especially in a corporate setup, reduces the medical legal litigations that come up later. So at least it makes some time for me to do that rather than doing those unnecessary paperwork of checking and rechecking and things like that. That way, AI has really helped me to save time so that I can spend more time with my patients. So where we are exactly now in the field of hemato-oncology, I'm restricting myself to the field. We are in diagnostics. We have started developing some predictive models and even some response assessment models also. Diagnostics, how I was introduced into this is because we as a hospital, we provide services to at least 6 island nations, starting from Fiji, Seychelles, Mauritius, and things like that. And very interestingly, a good number of doctors from Mauritius who practice in Mauritius oncology, they're all trained in this very own institution. They very proudly talk about BHU when I go to Mauritius, when they talk about radiation oncology. So when they started doing this overseas patients and following up these overseas patients, we do transplants, CAR Ts and things like that. But it is not that the patient is going to be stuck with us for the next 1 year in India. So they have to sometime go back. So that's the time we want to kind of literally monitor them very closely, like how we do right now if they're going to be in our own institution. That's the time we started with this digital eye, or setting up a small laboratory where with the data access, with the high-speed internet Wi-Fi enabled access, we had this digital pathology. Digital pathology is okay, fine. So this is like somebody doing a WhatsApp call and showing us a patient. That is very simple part of AI. But what this AI was able to do was literally it was looking at the cells and kind of at least doing my job a bit easier even before I look into the slide or I look into the patient. It was able to give me a gross idea. But the thing is, anybody who is in the laboratory can understand many times this data, earlier days, it never looks at the patient. It will just randomly say that this may be that, this may be that. There will be 10 options that will be given. But at the invent of AI, I can see that it is a continuous data integration that is happening, and this AI can, it looks like it is thinking on its own to some extent, saying that what is happening to the patient on a day-to-day basis, so that any red marks or red flags which I want to immediately look into or say to the doctor locally out there, that's kind of happening with this integration of AI in digital pathology. Next thing is, Suresh sir will be knowing, looking at this cytogenetics and the boring black and white picture of genes, the chromosomes, which we all used to think they are imaginary stuff. No, they're not imaginary stuff. They are there within our body. But looking at them and reporting them was again very subjective. I was in PGI Chandigarh, trained in PGI Chandigarh. One person will say there is a deletion at one point, the other person would have got a new pair of glasses and he will say that there is a deletion on the other point. So this confusion almost always used to happen. Initial days, it was not a botheration for us. Whatever deletion, maybe what's going to happen to the patient, it is very theoretical. But now I started getting drugs which are specific for specific mutations and things like that. So now I want to be very specific. Why not give the benefit of that particular drug to the patient if I can do a diagnosis properly? So these kind of stuff where humans can kind of miss, openly saying we can miss, there are something easily getting picked up by integration of artificial intelligence into our diagnostics. So this is what it is. So at every stage, right from AI to machine learning to deep learning, there is a one-site integration of all the patient data, starting from a simple peripheral smear up to high-end genomics and next-generation sequencing data, and literally kind of building up something called as a digital twin. This concept was talked by the earlier speakers. Digital twin is basically a kind of a replica on a digital space of the patient whom I have got. And this very beautifully happens in hematology because I got all the data which I can form a digital twin. And this digital twin can be a comparator for what is happening across the world and what I am doing to my patient, whether it is right or wrong or whatever. So this is a publication of the American Society of Hematology, where they already started talking about digital twins and having virtual tumor boards with the digital twins of the patients. So next, these are all diagnostic part. I have diagnosed a patient. Patient is going to ask only two questions to me. How are you going to treat me? Am I going to be alive or am I going to be dead and buried? So to say that, at least to talk to the patient in a sensible way, to get a proper informed consent from the patient, some kind of a fortune telling or prediction is also done by the AI. This is totally based on the data we have fed. And this has got a bias because the data can be Western data, the data can be from America where they are having access to clinical trials, where in India even having an access to treatment is a problem. But we are also looking into it, slowly getting our data, our own localized data, so that the predictive model becomes a bit more less biased compared to what is happening in the rest of the world. But it just predicts survival, it just predicts treatment responses, relapse and toxicity prediction also happens. So this is where we are. Early days, it was like one step we were going, like when the early AI was itself in a primitive stage, it was like feed a data, give some more data, and then do a predictive analysis. Now with agentic AI coming in, just get a very basic data of the patient, the filling drop boxes, and suddenly there is a predictive model that is going. Can it happen or not? This is more like looking into what to say, zodiac signs and things like that. May happen or may not happen, but at least there is some logical way we can start talking to the patient. And in this disease, particularly acute myeloid leukemia, who I was talking about, this disease just looks like a single disease when it's seen under a microscope or a bone marrow biopsy. But within the NGS platforms, it is at least 1,000 different varieties of diseases. We have drugs for at least 4 to 5. Even to use those drugs for 4 to 5, it's a very quite a confusing task to do. So this is MOA, multidimensional optimization model, that has been developed for AML across the world. It's more like an app-based system where all the data integration goes into right from the blast percentage, the blast morphology, the flow cytometry diagnostics, and comes the next generation sequencing modeling and the cytogenetics data. Everything goes in, and this data gets generated to give out a kind of a predictive score and how I may treat the patient. Then what happens? That is a feed which we have to do later. But the beauty about AI is it is not like I should say, like some of the humans who are very resistant to learn or unlearn, but AI has got the capability to do that. It is a good student that it will learn, it will accept its mistakes if the right feeds are given, and we can make it unlearn and relearn in the proper way how we want. I suppose that's possible because it's at the end of the day, it's not a human with ego, it is a machine with no ego, I should say. So that's about the machine, I mean the how it useful in the treatment. And the next is a very early part of AI. I don't know how many of you, most of us here would have been using this drug called as warfarin. And warfarin dosages, what we do is every time we go 3 weeks once, do a PTINR and keep on checking. Patient would have taken a cabbage, patient would have taken a carrot or a red meat, and suddenly things go wrong. We hike up the dose, he comes back with the bleeding. All these things used to happen very early. I'm talking about 20 years back. There was a predictive model for this particular drug that there were 78 mutations that were being done on a laboratory basis. And when there was an app that was created in Japan where you put those things, the mutations into the app, and it will kind of predictively say what dose of warfarin the patient can be started on. And then slowly based on INS, it gives out a prediction even to the patient himself or herself that how can we kind of continue. So that is about pharmacogenomics. That is like individual patient preferences, how things change. They all can be fed into the AI. And when it comes to hemato-oncology, lymphoma is one area where I should say a 360 integration of AI has already happened, right from scheduling of appointment to communicating to the patient, PET scan, how much dosage of radiation the patient should be getting in, integrating the genomic models for the different, at least there are 78 drugs that are now available if money is not an issue to the patient. So all those things have already started coming up in lymphoma. And this is something really great, the radiation dose optimization. Cobalt we had, then we moved on to precision linac, everything, but still we have, even in Chennai, we have gotten proton center. Everything is there, but still sometimes we feel that we are over treating the patient, giving unnecessary radiation. So this A has integration into the radiation designing as kind of, it's possible that we will be able to kind of dose optimize and make this patient, because olden days when the patients are there, there is a lot of radiation. 2-3 years later, they don't even live to know what happens due to radiation. Now they are living longer. We are facing the secondary effects of the therapy that was given earlier. So that way, if it is really done, it can be done. So there are ways to do that. Are we doing it regularly? I don't know that we are doing it regularly or not, but still there are ways to do all this very final tuning of patients with oncology, I should say. This, everybody talked about the wearables. Wearable general Apple watches are something different, but I will talk about specified wearables, especially post chemotherapy patients, because as I said, in patients who have normal immunity, a fever or something is all that great, but a patient who has got a neutrophil of 100, even a pulse rate variation of 10 from the baseline indicates that he may fall into a sepsis category. So that way, these wearables have been integrated into the EMR system of the hospital that they're continuously monitoring. I can't say it's remote, even from the patient bed to the nursing station for that matter. So that way, A has got some prediction alerts are being sent out so that an intern who is just new into the hemato-oncology ward, he shouldn't be missing out on these very minor variations that are kind of happening. So next, where we are, yes, as I told you, the agentic AI is the greatest disruption that is kind of happening now. Slowly, even in our own country, we have started doing something called as virtual tumor board discussions, where there is an app developed and the data is kind of fed into the app, and the app gives out are suggestions. And naturally, there are humans sitting over at the back of what to say, the backstage, looking into what AI is generating, and always a fine tuning can happen. And as I said, beauty of AI is it is ready to learn after that fine tuning and remembers it for lifetime. So that is how we slowly make things better. And one great thing that is happening with CAR T cell therapy is the moment the patient enters into a CAR T cell therapy, there are a lot of data inputs that happens, like let it be the ferritin level, let it be this level, that level, etc., etc. Sometimes it just goes over the head. So my intern's duty is enter all the data into the app. Sometimes the app itself takes it from the EMR system of the hospital and kind of gives out a predictive analysis that this patient may develop a CRS or he may need a tocilizumab on a preventive scale and things. These are all places, small places where AI has already started kicking in and giving out some useful inputs to us in our day-to-day practice of medicine. But naturally, it's all there, but is it really overhyped? I should say yes. It looks exciting for us. Anything beyond medicine, anything apart from medicine always looks exciting for us. I suppose we're kind of bored out of medicine, I suppose. But that way, yes, there is a bit of a overhype that AI can do everything. No, I don't think so. As I said, it's a master slave principle. So AI should be a slave and we should be the masters, and slowly we should make us the slave learn things in a proper way and be a slave always. Because at the end of the day, anything goes wrong legally, that AI is like a faceless organization. We are the ones who are going to go to the jail for that matter. So basic, whatever happens, yes, nothing wrong in learning it. It is better we start learning it. These are all great platforms to do. We should start small. We should train our people in small things how AI can be used. But I will say that verify each and everything, the data that is being outputted. So it's not like something you're going to blindly accept and say what is happening. See, there is a letter you're going to sign under. It's better you recheck the letter, which is that letter in the sense whatever the patient data may be. So that is something which we should be doing, and we stay relevant. Yes, there are ethical hurdles. We talked about the laws that are being made. I think few years down the line, the laws will become more kind of skewed enough so that we will have a data. I mean, we'll have a proper way how we can use the AI. So this is where we are. The winning formula needs to be a AI and a human hybrid, where AI can handle all the data crunching, pattern recognition, 24/7 help for us and routine analysis. Whereas as a human, we can be empathizing with the patients, making real world complex decisions and ethical judgment, and then naturally with the patient relationships. So A for VIKSIT Bharat is what the mission, I mean, the vision of this particular meeting is. I think we are already there. The central government or any government for that matter, they are kind of looking into it, I should say. Already they are coming with a Bhashini platform, which is there, which literally kind of translates a lot of data into the local language, especially the lab data into the local language thing. And we have got ABDM, that is Ayushman Bharat Digital Mission, where I can on anonymity load all my data to make it as a platform for research and other things in different specialties. As a hematologist, yes, I may be talking about hematology, especially Prime Minister's vision of when India becomes a total developed country in 2047. We want it to be a sickle-free country. AI has kind of greatly helping us to kind of get all the data and things like that into that. So this is kind of a very clear road ahead for us. We have started already AI-based diagnostics. As I said, I was talking about Fiji, Mauritius, and Seychelles, but reality is I want to talk about Jaunpur and Sultanpur so that this AI-driven technology can help even the primary healthcare centers to at least make a red flag diagnosis and refer the patients at the right time to the referral centers for that matter. Slowly, it is better we kind of optimize the data entry. The biggest problem as Indian, I should say, we have is we always look upon the West for all the data generation. No, we have got data that is 10, 20 times more than what the West can actually generate. But unfortunately, it's scattered. But I think AI is a great platform which can try to get across institution data can be beautifully collated so that we will be in a position to dictate what those guys have to do rather than they dictating what we should be doing. So this is possible. This is democratized. So that is the main policy. Democratizing things, democratizing healthcare technology is something which I think like crypto coins, very simple. Democratizing the currency, very simple. Same way, I think technology and healthcare can be democratized if AI is used on the right sense. So that's what even everybody, we all have said, because this was AI generated. AI is not going to replace us, but a hematologist or a doctor using AI someday or someplace will be replacing us. So I think it is better we learn it. But as I said, master slave principle is something which we almost always have to follow. And the slave should be kind of teached in a right way to make the best use of it. Thank you very much. Thank you very much again for the invite.
Thank you to be very much on time. We have time to take a couple of questions, comments.
Bit worried about getting scoldings from sir, so I thought I'll finish it on time.
No, sir. I mean, there are some platforms like Sick2Pill and other things
Yes.
which are trying to see and then categorize those things. So, what is your fear of miss rather than diagnosis? If it comes, we're happy.
Yeah,
If
yeah.
it misses, how do you deal that?
The aim of doing AI itself is not to miss things.
Correct.
So yeah, at this point, it is not that we are going to totally rely on what is kind of being said and done. We keep on rechecking. The miss happens because AI doesn't think on its own. Though we say it's artificial intelligence, this is not intelligent as simple as that. It is all protocol code driven things. So what we give as an input does matter, and that small input changes with a backup, whatever the data that is there. It's a big library, and the library is getting updated every day. So naturally, small changes to the inputs what we give and totally alter. It's like a black box thing. It will give an answer, but whether the answer is right or wrong, we as a human need to cross check that. Yeah.
So, one question is in clinical practice, how frequently, because you are also in corporate, see that patient comes with the AI-driven treatment protocol versus your protocol.
Yeah, yeah.
How do you handle that?
Everybody here, I will think it has been quite long that we have used Google for our search. Now we use ChatGPT or anything. Even every data platform person in India is giving a premium subscription free of cost. So that happens. That is okay. That's fine. One way, if you really look at it, that makes our things easier sometimes. That also gives out the negative part of it. I'll just take it to them, write down the prognosis and give it back to them. That's fine. So it makes my job easy because we both, I should say, have a very unpleasant way of even talking about mortality to most of our patients. So that way, I find that AI has made the job easier. Yeah.
So to make it more interactive, I request the delegates who have the questions
Yeah,
first,
Dr.
let them
Anjali.
ask.
We start this AI from our, like, I'm a gynecologist, like there's so many patients with the critical care and so many patients missed, like to decrease the near misses. Like, can you advise how do we start with our staff and with the patient? And so that what are difficulties you encounter from your experience, we can learn that.
At the end of the day, it's again the institution-based policy, ma'am. Because, like, for example, my institution has got an EMR app which has got an AI integration, and the teaching happens at that level. So it's not that I run, it's not a separate department that I'll be having my own way of doing things, and ultimately, it's at the end of the day, it's a big hospital, and all patients belongs to hospital. So that is one thing. It's a policy decision, but I personally believe last 2-3 years, even the EMR app people, they become totally kind of more skewed towards integrating AI and using it on a kind of at least acceptable platform. I think that will happen in the due, even whether we like it or not, it's going to happen. And especially in gynecology, ma'am, with the robotic surgery, AI assisted robotics, that is something great with a small pelvic area. We are finding beautiful results when it comes to AI assisted, I should say. Yeah.
Yes, Professor Rahul Khanna. Yeah.
It was a nice lecture that you gave. And end of the day, what is happening is that
So please close.
like this AI will be what we call a mathematical model.
Yes.
Like in mathematical model, if we see that then 8.5 plus 7.5 will always be 16.
True.
But human body does not follow. It's a biological system.
Never.
And biological system does not follow the mathematical. There 8.5 plus 7.5 will be maybe
What?
15.8, or it might become 16.4.
True.
And this small difference is very critical in very important in critical patients.
True. True.
Very, and that is where the true judge of a good physician or surgeon comes in, when the patient is actually critical, and there AI will not.
Yeah,
Not help.
for sure, sir. It is just like I will say, for example, in the CAR-T AI part, many a times if you really ask me, 50% of the time these red flags are like just to alert us. Maybe 10-20% of the times is the real action I take. But my worry is, if I'm going to be away, say I'm sitting here giving out a lecture, my intern not knowing, just a new guy who is there, but 8 out of 10 times it's not something to worry about.
Right. Okay.
Yeah.
Yeah. But again, like the examples, two examples you gave here.
Yes.
The first example that it will predict the survival.
Survival scores.
So that will tell you that the survival possibility is say 88%.
Yes.
But in that particular patient, it is either he's surviving or not surviving.
Yeah.
That AI is not going to predict.
No, never, never, never.
And the second, that variable what you told, that it will detect the price in pulse rates. Say. So so that's a remote patient sitting.
Yeah, very
Some staircase, one floor. So that AI is not helping at
True,
all.
sir. True,
It's misguiding rather than.
yeah, it's just another gadget which we should be kind of deciding on how we are going to use it. Yeah.
Ultimately, what you said, master slave. That's
So, yeah. Yes. Sir.
So complicated to understand, or there is a fear of unknown. I mean, why the people have difficulty in accepting it and changing their mindset to start using it.
Yes.
Immediately. I mean, what are the?
Sir, I will just compare it to something. A good student who reads a lot. When the question is very simple, he will say that the exam paper was very tough because he was not ready for the simplest one. I'll put it that way. I sir will accept. AI is actually making things simpler for us. But naturally, this is an early resistance we all will have. And to be more frank, unless we are exposed to the use in a hands-on pattern, whatever I'm going to talk here, it's not going to really get into that. I think it should be a part of the curriculum slowly, but it's very wide, sir. Like, we really don't know how to use it. At one point, we were not knowing how to use a PowerPoint. I still remember MBBS people are teaching me how to use a PowerPoint. Now it has become part and parcel of what I'm doing. So something similar, it will happen. Maybe it needs a decade more. Maybe next decade when I'm talking here, I may not be even talking, and the AI will be giving a lecture on behalf of me. That's I suppose. But I think people are doing so. The young generation is really pushy. But naturally, there is an over expectation also. There is a hype. I don't think we should get into a kind of.
We're expecting too much.
Yes, yes.
And I agree with you that AI should become a part of UG and PG curriculum.
Yes.
Then our generations will be exposed, and then they will be more comfortable in adopting it. Thank you.
Thank you, Dr. Kishore. Just like few advices you want to give to our younger generation who are sitting here. What are the apps which will be very useful as a clinicians, which can be used AI-based apps?
Yes, so to be more from the easiest ones are like what everybody uses here is a regular one like ChatGPT or Cloud or whatever. That they're not apps actually; they're platforms. But if I want to talk about apps, I don't have a general one to give out a suggestion. They're commercial.
For hematopathologists?
Hematopathologists, we have got, sir, few apps which I can share it to them. Even Path AI, what sir talked about, they're all something really great. Cure AI, these are all something already there's integrated. But I think leave aside the apps, the general generative AI itself is something which is greatly helping us. I don't want to even really get into an app-based system. Well, specialty-wise, it is there. People are developing it for that matter. But at the end of the day, everything comes from a common cloud platform. So naturally, that's where we should be looking at. Thank you. Thank you.
Thank you. So the next speaker, who was previously the first speaker, Mr. Grish Raghavan, he is going to speak on AI, how AI is going to shape the future of healthcare.
Thank you, and apologize for being late because we had some logistics problem. I realized that AI doesn't solve all the problems, and one of them is IT problems. Okay, yeah. So today I'm going to talk about precision medicine a bit. I'll give more of technology flavor than a clinical flavor, like Dr. Kishore and others have been talking about. So precision medicine. So I'll start with three statements. One, there is the bad news. The bad news is that there is an alarming number of things which we do not know than what we thought previously. One example is cardiology, for example. It's okay. Yeah, one example is cardiology as an example. So today, if we know, we thought few years back that we knew heart quite a bit, but today we knew only, I think we know only maybe 20% of it. It's worse for brain because one of my colleagues used to tell me that we know perhaps 1% of how our brain functions today. So there's lots more we do not know than what we think we know. The second one is the lot of predictions. If you open every year at New Year, there are so many predictions in financial market, healthcare markets, and so on and so forth. So the predictions are great. The challenge is for us to know when it will happen. It is such a very tough prediction to make when it's going to happen. The third one is about the future will be incremental. I think one of our previous speakers mentioned about the fact that healthcare has evolved a lot in the last several years. He was mentioning about the fact that every 60 days, the knowledge of medicine doubles. If you go back and see the last 10 years, healthcare and medicine has evolved maybe more than what it has evolved in the last 1,000 years, right? So there is a pace at which healthcare has been evolving. So with these three statements, I would like to take my next 20 minutes talking about three topics. One is how the healthcare ecosystem has been evolving. Second is about some of the key themes of precision medicine. And finally, I'll spend a good amount of time on specifically on how technology is shaping precision medicine, so which is the most important piece of the session. Continues. Okay. So look at the healthcare ecosystem today. So there are four, I would say, profound trends which healthcare is bringing today. One is there is a huge shortage of resources across the world. So it's easy to build CTs and MRs and so on. I'm from medical devices background. I spent all my 25 years working in imaging space. So it's very easy to build all these wonderful technologies. It goes into rural areas. But the challenge is that we don't have enough people who can man those systems. So that is a huge constraint across the world in terms of having people who can use those systems. The second is also in terms of productivity and efficiency, right? If you go to any hospital in big cities or even small towns, you will find that the queue you have for people to get into a CT scan is huge, right? So you may have 5 or 6 CT systems and you have some 50 people, 70 people waiting in queue just for CTs and MRs. So there is one big issue is about the global resource constraints. Second is we perpetually across the world, India is much better. Across the world, we have a huge aging population. The chronic diseases are increasing. We also see that the lifespans have increased considerably, and with that comes its own pain points. The third is increased consumer awareness. Dr. Kishore was talking in the previous question. So people today go extremely well prepared. So if you go to doctors today, that the patients comes with all the Dr. Google knowledges, and it is a big challenge for doctors to explain that you can't replace 10 years of medicine education with a single search on Google. So there is a big constraint. The fourth big trend we are seeing is digitization. So we expect by 2030 we would have 1 trillion systems interconnected. That is phenomenal, right? So these are the four trends we are seeing today from a healthcare technology perspective. And today, whatever you talk about precision medicine, three things are extremely important, right? If you don't do these things, there's no point having precision medicine. One is the question of affordability. Is medicine affordable to the people, right? If you look at PET scans as an example, if you go back and see 20 years back, 15 years back, PET scans were super expensive, right? It cost close to a lakh, 50,000 to a lakh. But today, PET scans are accessible, cheaper. With around 20,000 bucks, you can do a PET scan. CTs, for example, brain CTs were 10,000 bucks few years back. Today is hardly 1,000 bucks, right? So affordability is very important for medicine to go to places. Second is accuracy, and we discussed this quite a bit. To your question, sir, on why people don't trust AI, why people don't adopt AI, it's all about trust. How trustworthy is AI in healthcare? I think the medical fraternity is extremely worried about the accuracy and the credibility of AI solution at this point in time, which will change with which time. Right? Third is accessibility, right? Is it can you take these CTs and MRs and X-rays or any healthcare solution you have to the tier 2, tier 3 cities and make it accessible? So this is one, I would say, a trend we are seeing today from a healthcare perspective. The second is about some of the themes we are seeing today in healthcare. So I'm sure all of you would have experienced this. Okay, I have never stepped into a police station or a hospital. It's a matter of pride for people to say I never gone into a hospital, right? Which actually is very scary, by the way. Because it just shows that we are reacting to symptoms as against reacting to a problem. So hospital visits also means loss of livelihood. So especially in India, people go from tier 2 to tier 1 cities. So normally in our Indian society, when somebody falls sick, you go to a big city, say Delhi, for example. Along with me comes my dad, mom, uncle, aunt. We have a big chunk of people who come along. You have to stay in a hotel. You have to pay for the food, etc. So it's pretty expensive. So it's a loss of livelihood for a lot of people, right? So if you look at today, why the previous slide is important is, if you look at this page, we have been traditionally working in this space, right? Healthcare means we only get into this space, which means as the disease progresses, we get into the hospital. One of the big trend and one of the most important element of precision medicine is how do we get patients how do we get humans, I won't say patients, to get into this space. So today we are seeing that's exactly why as you age, the healthcare expense goes up dramatically, because mostly people after 70, 60, 50, it just goes up exponentially and the cost goes up quite late. So the big challenge for precision medicine is to get our humans to start working in this space. So that is exactly why, if you look at mammograms, for example, or breast cancer, people ask for screening every year or every 2 years, depending upon what age you are in. Mandatory health checks have become very important because it's all part of predisposition testing, so that you can predict and you can be more effective as you go up the chain. The other one is about other big theme in precision medicine is about virtual care. So if you go back and see a few years back in a ICU, you used to have, even today in the US, right? In many hospitals, you have one nurse for every bed. Right, that's how it used to be. Very expensive. But today, if you go to a lot of big hospitals in India, you have cockpits where you can have 30 beds manned by one nurse. How does it work? It's because of these technologies where you can have a nurse sitting, looking at the entire cockpit. You have AI algorithms running, which can keep watching all the vitals. And when they see a bad trend in a vital, it can give an alert, and you can have somebody going and looking at it. So we are seeing a lot of focus on those kind of technology. Today, the other example I would talk about the whole question of virtual care is in a lot of places in the country, even in India, you go to Northeast, we don't have enough radiologists over there. So you have CTs and MRs which are installed over there, and you would have a doctor sitting in Bangalore or Chennai or Delhi who would be monitoring those exams. So you have a technologist who will do a CT scan, you will send it to Bangalore, you have a hospital sitting there looking at all these scans, and within a period of 10 minutes, you have the report to the patient who's in Assam, as an example, right? So we are seeing a lot of this kind of virtual care happening quite a bit. Today, we have Practo as another example. So somebody is not well, you just go open Practo, you can just find a doctor in some part of the world, and you can leverage that. So this is the other thing about virtual care. The last thing is about, again, we covered this, I think a lot of themes which are common across all the speakers is about the data. So we have close to 260,000 systems across the world. Unfortunately, only 25% of these systems are connected. So that makes it a big challenge. So one of the biggest challenges in healthcare system is we have a lot of systems, highly fragmented, disparate systems. They just don't talk to each other. They don't connect to each other. And this is the case between enterprises and within enterprises also, right? So you have all these kind of challenges which we face across the healthcare ecosystem. And then comes the process of cybersecurity and so on and so forth. So these are some of the I would say key trends or key themes of precision medicine. So now we'll spend some time on the technology part. So look at the technology. So there are several technologies which is playing a role in healthcare. One of them, and all these are exponential technologies. This slide keeps changing pretty much every year, unfortunately. There is a pace in which technology has been growing on a day-to-day basis. First is AI. I think we covered quite a bit, so I will not talk about it. I got some more sessions in the next slides. Genomics is another big space, especially in precision medicine. Genomics plays a huge role, where you're able to take end-to-end, right? The ability for us to take data from multiple sources, be it pathology, be it radiology, imaging, genomics, you're putting all of them together and coming with a comprehensive assessment is what helps us to go one step towards precision medicine, right? The third one is additive technology, which is basically 3D printing. So today we know there are many doctors across the world, even in India, who are able to take CT scans of your heart, they put them together, they build a 3D model of your heart, right? Your heart is not the same for everybody, right? Just structurally, they are a bit different inside. So before a surgery, you have a 3D model of your heart. The doctor looks at the model and they're able to precisely know how to operate the patient before the surgeon goes into the theater. It's phenomenal, right? Because there are many cases we know that the doctors are surprised when they open your heart. So this actually gives them a very good understanding of how your heart is structured and accordingly decide how to plan your therapy or how to plan your operations, right? So that is one. We are seeing a lot of additive work happening in the space of orthopedics, a lot, right? Blockchain is another very important technology. This is primarily for, I would say, patient safety of data. Privacy is a big element being discussed today. So with a blockchain technology, you can have data fragmented. It could be at multiple places, and the blockchain would be able to tie them together and get them together, right? So this is another big technology. And finally, robotics. The previous speaker mentioned about that, about robotic surgery. So again, in orthopedic, we are seeing quite a lot. AI-assisted robotics is one part of it, where you can precisely the precision level what you get with robotics for orthopedic is amazing. 10 years back, if you had gone and told somebody in your friend circle that I'm going to do robotic surgery for your hip replacement, people would be really worried, right? Or if you want to do I would say knee replacement or hip replacement. But today, if you go and tell your friends that you haven't done a robotic surgery, it was manual, there'll be a bit of shock, because the level of precision and accuracy and the success rates you have with robotic surgery is significantly higher. And today, this area is again evolving as we speak. There's a lot of technology evolution happening on physical AI, which physical AI is basically robotics with a lot of AI technologies coming in together. Okay. So these are 5 fundamental technologies which are, I would say, shaping the way precision medicine is evolving as we speak. So we spoke about the AI quite a bit. I want to bring attention to this particular page, right? So if you look at this page, the way to read this page is on the x-axis, you have the levels of AI, right? So you're talking about no AI, they're talking about tools, you're talking about being a consultant, you're talking about being an expert, and you're talking about being a superhuman, right? And there are 2, I would say, columns over here. The first one is about narrow AI, the second one is about general AI. If you look at narrow AI, has evolved a lot, right? It's evolved significantly. For example, if you look at Siri, Siri comes in it comes in this section, level 2, Siri comes over here, Alexa comes over here, right? I'm sure all of you have used Siri and Alexa. We are just here, okay? Level 2, it is not level 4, level 5, it's level 2. If you go down the line, you can see, I'm sure some of you would know what is blue deep is, right? The deep blue is from the 90s or 2000s, where we had, from the 2000s, where the chess players were playing. It was very, very famous those days. Human is playing with a computer, supercomputer, right? So this is where deep blue is. And today we have gone all the way down to stockfish, which is super intelligent, right? A man cannot compete with a computer on a chess. It is level 5. Interestingly, if you look at the general AGI, artificial general intelligence, the chat GPT we're all talking about here, which is like a wow for us, we are just at level 1. At level 1. Just imagine where we will be when we go to level 5. Level 5 is super intelligence, right? Artificial super intelligence, it is a different level. So we are nowhere. At this point, whatever AI we are talking about is just a tip of an iceberg. 10 years from now, maybe even 7, 8 years from now, when we progress around this path, when you get to this point, the world will be very, very different. Okay, so don't feel that we have got anywhere close to where we are on the space of AI. Data is a big challenge. I think we again discussed in previous sessions. 30% of the data on this world, on this planet, is healthcare data. Unfortunately, 93% of the data what we have can never be used. It can't be used because, again, fragmented systems, not connected systems, you can't get the data. But very big challenge for us is obviously privacy. There's a lot of concern about data privacy, so you cannot get the data outside the hospital premise. So data is so fragmented, so isolated, getting them to come together is going to be a big challenge. If you're able to get from 93% of data not being used, if you're able to get it to say 20% data can be used, I think we would have made tremendous progress in healthcare. Digital twin, again, digital twin, we covered quite a bit about in the previous sessions as well. It is no more a hype. I can tell you from the work I do, we have a digital twin of every system, every premium system on this planet in our back office. We know exactly when a particular system will fail. For example, if you have a CT scanner, we have a digital twin of a CT scanner. You know exactly when the tube will fail. We know exactly when the detector might go for a toss. Okay, you know how the system is getting used. So with this, the advantage what you get is very high. You know how your system is functioning. You can tailor make your solution for the customer depending upon how the systems are. In the space of humans, again, a long way to go. There is some progress, as the previous speaker mentioned, but still a long way to go. But as all of you know, the data which is getting collected from your annual checkup, etc., is just getting into space. Okay, so this is another big area. Recently, FDA has also been very open to digital twin. So some of the regulatory work what we do today, FDA is perfectly fine in us having a digital twin of a patient, building the data. So in the past, if you go back and tell to the regulatory agencies that I'm using a virtual data which I created, they will just throw us out. Today, it is very normal for us to go and build synthetic data which can be used for submission to various regulatory agencies. The advantage is very high. You don't have to put patients through unwanted dose and unwanted torture, right? Because you have to go through so much of collections of data. So today, regulators understand the value of it. They trust the data what we build synthetically, as long as the methodologies are well defined. Smart devices is another big thing. Many years back, if you have a scanner with you, the basic assumption is the system is dumb and the operator is intelligent. I'm an operator. I'm supposed to know how the system works, and system is dumb. I just tell what the system has to do. Today, it is the other way around. Our systems are super smart. I'm taking an example of CT here because I'm sure all of you know what CT is. Today, CTs are super smart. Today, if you take a hospital setup, you have a radiologist who sits elsewhere in a PAC system. You have a technologist who's sitting just outside the scanner. A patient walks in. In the past, the technologist would not know what protocol to use in that scanner. He would have to call the radiologist, ask him. He might have gone for a coffee break, loss of time. Today, our systems are super smart that it will just go and connect to the radiology information system, pull the information, look at the patient history, look at the patient data. Oh, it's obese patient, this patient of this height, so on and so forth. It would recommend protocols to be used. So if you take a normal system, you have, say, 1,500 protocols. The system would look at the patient and the data and recommend for this patient, these are the top 3 protocols, pick whichever is most relevant. By the way, of these 3, the first one is 88% closer to the patient requirement, right? So there's a level of smartness we have. Today we have MR scans. When we do MRs are pretty lengthy procedures. People often shake a bit. So we have got MR scanners where when you do a MR scan, the system would detect motion of the patient. It will alert the technology saying the patient is moving. So you have to take a rescan. I don't know how many of you experience X-rays. You do X-ray. After X-ray, you have to go out and somebody calls you and says, please come back. The X-ray was not good. Today's systems are smart. Before the patient goes outside, as you do the scan, the system would say, look, the patient is, the X-ray taken is not at the right level. You have to take a rescan again. So there's a level of smartness these systems have built over the last several years. And the level of intelligence we're going to see as we go forward is humongous. Some of the work we are doing today are really forward-looking, which I, of course, cannot talk about here. The last but one is about smart detection and smart decisions. We spoke about radiologists, right? How tough their lives are. 5 years back, 8 years back, a typical radiologist would have, say, 20 CTs and maybe 15 X-rays to look at. Today, the poor guy walks into a hospital. he would have in a day 100 CTs and 100 CTs and X-rays to look at, or MRs to look at, and he has to do reporting towards the end of the day. The highest burnout today in the industry is with clinicians today, because of you have to get into a dark room, you have to be there from 8 a.m. in the morning till 8 p.m. in the evening, you have to write reports and so on and so forth, very complex. Today, what we do today with our AI solutions is that it can, as you do the scan, it can look at all your X-ray scans or CT scans, it can bubble up to the top. Okay, out of that 100 patients you have, these 5 patients, there are problems, please prioritize these first. It will just bubble up to the top. So the clinicians can focus on those 5. And for the remaining 95, they can do after lunch and so on and so forth. Right? There's a level of AI, how AI is helping to bubble up those critical cases to the top of the field. Similarly, in terms of reporting is one of the most complex things we do. Right? I know my sister, when she was going through her treatment, a PET scan. After taking a PET scan, she had to wait for 10 days to get a PET report. 10 days. In the 10 days, she will lose some 5 kgs, right? And the anxiousness, waiting to see what happens and so forth. Today, reports are fully automated, right? In fact, the advancements we are doing in reporting is mind-boggling. It just, the reporting of tomorrow would be from the images directly. There's no triaging, right? So if you look at the reporting we're referring to here, so by the time the patient walks out, today, there are a lot of AI solutions which will pre-format and build the report. It will build all the contents. All the clinician has to do is review the report, make some corrections, changes, and then sign off. So within a day, today people get the reports, right? So that's the level of advancement we are seeing today. And the last one is about the wonderful thing of our screens, right? One of the big things I would say why technology will help a lot in taking precision medicine to the nook and corner of the world is because of the small screen. Today, be it ultrasound, be it anything, right? Be it anything, you have this small screen is going to make a big difference, because you can see on your mobile or on your iPad what's happening, and you can access it with much more ease. And we have to use this quite a bit. I know there are certain countries like Japan, Indonesia, where you have people who are staying in very remote parts of the world, Indonesia especially. We have used some of the technologies where they can use the screen to do pretty much everything, right? Being remotely connected to wherever you are. So this is at a high level what I wanted to share from a technology perspective. The future is very bright. What we are seeing in AI is just tip of the iceberg. We have a long way to go. If you go back and see, 10 years from now, or even our children, when they look at this kind of slides, they'll be amazed at the healthcare of 2025, 26, 28, 30 was so old. Right? That's the level of change we're expecting in healthcare in the years ahead. Thank you.
So thank you, Girish, for a wonderful presentation, like how the AI is going to shape the future of healthcare. So being a vice president at GE Healthcare, you must be covering very important aspects. So GE is also investing too much in India for Make in India things. So now how this AI technology, which is like Make in India, is being covered by the GE?
I think again, Dr. Kishore mentioned about this. See, the power of India is the data we have. Our laws are very flexible compared to some of the laws we have in other parts of the world, right? So we are actually trying to use the data what we have. At least from my perspective, we have a lot of partnerships with very big hospitals across the country, and we get the data and we use the data to build models which can help to make precision medicine a reality. So the big change you're going to see because of AI is that in the past, we always used to take models which are built in US and Europe, and we assume it will work for India, which is not true. Okay, we are very different from as a race. So getting those data makes a big difference. So we work with some of the big hospitals across the country to get the data, build AI models. We also use the ecosystem to go and validate the models what we have built, so that we can be sure it is trustable and has got credibility for us.
Those machines which we are using in our hospitals, the GE machines, so are they now using the Indian data set?
Yeah.
So predicting the reports?
Yeah. So we're doing it, I would say, not as much as we would like to, but at least for the products which we have been made in India for India, from a technology perspective, we use India data. But otherwise, most of the systems we build are built in other parts of the world, and we try to customize for Indian market.
Thank you. So house is open for questions from the delegates first. So any delegates? Yeah.
So first of all, I would like to thank all the doctors sitting here to serving us. Like, you all are God to us. When a patient goes to you, he or she acts like now he's served to, you will be serving him like anything, like you will put all the efforts to save his or her life. Now my question is very general, like AI is serving a lot, it is helping to save time, to serve more patients to all the doctors. So like in general, any doctor or any radiologist especially facing any problem using AI, like in general, so like would you like to give any suggestions to engineers especially, like in general, how it is affecting or any drawback of AI in especially radiology department?
You're asking from an engineer perspective or from a doctor perspective?
Both.
Okay. Okay. So from a doctor perspective, see again, I've been in this space for 25 years. I've met so many doctors in big hospitals. I also met a lot of startups. We mentor a lot of startups, etc. One big differentiator which I have seen why clinicians don't adopt technologies because of what I mentioned, trust. There's a very large hospital in Delhi where I visit very frequently. So today there was, I mean, again, on one hand, I mentor AI companies, startups. So there's one company I've been mentoring for a while, and this guy told me that I've gone and met this doctor in Delhi. We have installed our system. We have no issues. There's no problem. I haven't even got one call from the customer so far. So the customer likes it. So I happened to go to the same hospital a month later, and I met this doctor and I asked him. I asked a simple question: how is the system doing? I heard great things about it. He said, look at that corner. There's one computer lying there. That is that system. I never touched it after he came. He didn't pestering me, so I kept the system over there. Then I asked him why. He has two problems. One, he says trust. He says that big corporations with a lot of credibility in healthcare over the last, say, 30, 100, 50, 150 years, they have systems in place that they know that they take healthcare seriously. So trust becomes a very important factor. Second most important factor is workflow integration. See, if you look at hospitals, they are running under a lot of pressure, right? They have like back-to-back CTs, MRs. You've seen hospitals just chaotic, right? And then they are also very high, very strongly less staffed. They don't have enough people to man the hospital. The worst thing can happen in hospital is to come with a wonderful system, which will slow them down, right? In this particular example case, what happened is you need to have a separate person to man that system, to look at the data and give advice. It's super complex for them. So basically, hospitals expect that the solutions, whatever you build, should be seamlessly integrating into their workflow. You can't expect the hospitals to align with the workflow what we have in our mind, right? I think these are the two things I would say, both for engineers' perspective and why doctors are very hesitant sometimes: workflow integration and trust.
So Girish, I think for any technology which is coming, so there are early innovators, like which is around 1 to 2% who will adopt the technology very fast.
Yeah.
And there are some who will not adopt anyhow.
Yeah.
So it's like this type of conference is going to be a thought-provoking thing for the audience, like how the AI is going to reshape our the healthcare. And I think let's not resistance should not be there. Let's adopt it, and sooner we adopt it, then better we will be.
Fully agree.
Thank you. So with these words, yeah. Please.
Thank you, Dr. Grease, for your very nice lectures and making this very simple, complicated topic. And I think if there's no further questions from the audience, then we would like to close the session. Thank you.
Session of today's scientific program. Moving on to the next session of today's scientific program, to the session 3, we are deeply honored to invite our esteemed chairpersons for this session, Professor Rahul Khanna sir, Department of General Surgery, IMS BHU. So please kindly come on stage. Then Dr. Anurag Tiwari sir from Department of Gastroenterology, IMS BHU. Then Professor Rajesh Meena sir from Department of Anesthesiology, IMS BHU. Thank you, sir.
Thank you. For the next session, I would like to invite Dr. Puneet Khanna for to speak on topic problem beyond implementation and validation of models, reality bites. Dr. Khanna is professor in All India Institute of Medical Sciences, and he has a interest in the post-operative delirium, post-operative cognitive dysfunction, and artificial intelligence. Professor Khanna has published 8 books and more than 290 research papers with H index of 28. He has best 5 papers presented in Euromed in 2024 in Morocco, and he got Travel Award to present paper in Seoul, South Korea in 2024. Thank you. Welcome, sir.
First disclaimer is that I am not a pessimist, but I will talk realistically. One. Second thing is, whatever I speak is my opinion, not of Government of India and not of my hospital. But it will be realities. Third disclaimer is, I would like the talk to be interactive and I want the liberty to speak in Hindi as well. And I hope the House agrees with it. नहीं सर, बिल्कुल सर, नहीं सर, देखिए वास्तविकता से दूर नहीं भाग सकते, सिंपल सी बात है, वास्तविकता से दूर नहीं भाग सकते, ठीक है. The first disclaimer is कि ये मेरी अपनी ओपिनियन है. I come from the hospital which has got the biggest budget in India. हमारे पास 3500 से 4000 करोड़ आते हैं, ठीक. आज खड़े होके यहाँ पे सुन के मुझे ऐसे लगा कि हमारे बीच में ही डिवाइड आ गया है, ठीक है. Despite being the biggest hospital in India, we don't have an EHR. पहली डिस्क्लेमर, हमारे पास इलेक्ट्रॉनिक हेल्थ रिकॉर्ड नहीं है. और फिर जितनी बातें इससे पहले हुई हैं मुझे बहुत बड़ी बड़ी लग रही थी, ठीक. दूसरा डिस्क्लेमर, एक अंग्रेजी की कोट है जिसे हम बोलते हैं द कैमरा डजंट लाइज. फाइन, फोटोग्राफ झूठ नहीं बोलती, बट यस इट डिपेंड्स अपॉन द टाइम टेकन, द एंगल टेकन एंड द लेंस. कौन सा लेंस यूज करा है, किस टाइम पे फोटो खींची है और कहां से खींची है. वी हैव टू कम एट रियलिस्टिक टर्म्स विद इट. फाइन, तो जितनी बात सर इन्विटेशन में बहुत बढ़िया लगेगा आपको, मेरी टॉक पहले किसी ने सुनी नहीं होगी. Yes, sir.
Being from AIMS, yes, sir. The telemedicine facility established there are not maintained properly.
Sir, please. Again, I told you the first line, the opinions are mine, not of my hospital. Please. Because if I be quoted, unquoted, I will be put to task. Fine. The third thing depends, again, जितनी बातें हम AI के अंदर, इंडिया के अंदर करते हैं, ठीक है, वो या तो रेडियोलॉजी की है, या हेमेटोलॉजी की है, या स्किन की है, या ऑफ्थेल्मोलॉजी की है. फोटो झूठ बोल ही नहीं रही ना. या बायोकेमिस्ट्री की है, या लैब वैल्यूज की है. तो वैल्यूज एंड फोटोग्राफ्स आर नॉट स्पीकिंग द अनट्रूथ. भाई मरीज आया इमरजेंसी में, किसके पास टाइम है. आई एम अ क्लिनिशियन एंड दीज आर द रियलिस्टिक फैक्ट्स. दीज आर द जो एआई जिस स्टेज पे हमारे देश में है वो यही है जहां पे डाटा इज परफेक्ट, फोटो परफेक्ट है. स्किन के फिजिशियन ने 50,000 फोटो खींच रखी हैं, उसके हिसाब से एआई एल्गोरिदम लगाना, उसको प्रोस्पेक्टिवली प्रूव करना, वैलिडेट करना इज वेरी इजी. बायोकेमिस्ट्री, पैथोलॉजी, यू गो टू इमरजेंसी मेडिसिन, एवरीथिंग फेल्स. मैंने पहला एक वो डिस्क्लेमर बोला था ना कि आई माइट साउंड सर्टन सिनिकल. ये पिछले साल की बात है, अप्रैल 9 2025. NAGM AI, न्यू इंग्लैंड जर्नल ऑफ मेडिसिन, AI एक जर्नल चलाता है, न्यू इंग्लैंड जर्नल ऑफ मेडिसिन, एवरीबडी ऑफ अस हर्ड. आई वाज अमंग द पैनलिस्ट. और टॉपिक क्या दिया गया था, मतलब they were basically trying to where AI fills the gaps, hurdles, health literacy, workforce shortage, slow progress, opportunities to collaborate, actionable deploying AI. Fine, but what I was speaking on was bridging developed AI technology to lower resuscitating. और ये झूठ तो नहीं बोल रहे, काम है, it is deepening the divide. Fine, we were representatives from South Africa. हमारे जैसे देशों पे जाइए ना, जापान, चाइना, US, they are very progressed. आज भी ईएचआर नहीं है एक सबसे बड़े सरकारी अस्पताल के अंदर, और हम बातें कर रहे हैं डाटा इंटीग्रेशन की। बट इट्स नॉट द फैक्ट। स्लोली 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 एवरीथिंग इज कमिंग। ठीक है, अब नाउ टू द पॉजिटिव एस्पेक्ट ऑफ इट। बुराई बहुत कर ली, अच्छा ही देखते हैं। प्रॉब्लम क्या है इज इन इम्प्लीमेंटेशन एंड वैलिडेशन। कितने ही मॉडल्स बना लो, मैंने खुद बनाए हुए हैं। यहाँ पे खड़े होने के लिए इसलिए बुलाया इन्होंने कि आपने मॉडल बनाए आईसीयू के अंदर, आप कुछ बोल दीजिए। फाइन। आज की डेट में आप लोगों को सबसे सक्सेसफुल मॉडल क्या लगता है? पता नहीं, बनारस के हिसाब से मैं नहीं जानता, दिल्ली के हिसाब से जेप्टो, स्विगी, जोमेटो इज द मोस्ट सक्सेसफुल मॉडल। भाई मॉडल वो होना चाहिए जो आपके खून के अंदर आ जाए। यू डू इट विदाउट थिंकिंग, वही सक्सेसफुल मॉडल है। जिस मॉडल के बारे में आपको सोचना पड़ रहा है वो मॉडल है ही नहीं, वो आपके लिए बना ही नहीं है। आपको ओला, उबर, रैपिडो, कल मेरे को वहां जाना था काशी, मैंने कहा डॉक्टर साहब आप ऐसा है, भले ही प्रोटोकॉल लगाया हुआ है आपने, बट आप जो है रैपिडो से आना, गाड़ी से बिल्कुल मत आना। द थिंग्स आर सिंपल, दिस कम्स एज अ फ्लो, कि आप बाइक से ही आ सकते हैं और बाइक भी आप रैपिडो से ही बुक कर सकते हैं, सोचना नहीं पड़ रहा किसी को। तो दैट इज द बेसिक प्रिंसिपल ऑफ अ सक्सेसफुल मॉडल। बाकी सब मॉडल हमारे लिए बेकार हैं अगर हम उसे अपने वर्क फ्लो में नहीं ला सकते। इससे पहले वो जी के साहब बोल रहे थे ना, I know his chairperson पहले जो होता था श्रवण सुब्रमण्यम, he used to talk to us and take our critical inputs. Practical problem at the ground is very different. If you walk into a 7-star hospital, it is different. वहां पे EHR, EMR सब कुछ मिलेगा. Let us talk about 130 crores, I suppose 10 crores को छोड़ देते हैं, वो तो कॉमन मैन है ना, वो तो सब नॉर्मल जगह ही जाएगा. चलो लेट्स टॉक अबाउट artificial intelligence is no longer futuristic concept. 2026 में it is a silent engine driving significant shifts in how we learn, how we heal, from agentic AI that autonomously manages clinical workflow to hyper-personalized learning platforms, and impact is measurable and profound. Yes, in a developed setting. In 2026, it is described from moving from the honeymoon phase to the reality bite phase. AI की भाषा, sir was working on I think 1995, that was an eye opener. 1995 में हम AI की बातें कर रहे थे बनारस के अंदर, जब he was working on EEG. तो the honeymoon phase is over, now the reality is biting us. It is not about who has the smartest models. वो बात गलत है कि हमारा मॉडल सबसे अच्छा है. It's about the execution of the model, which model gives you the best robust governance. Organizations are investing now 50% of their AI into post-market surveillance, ongoing monitoring after it has been deployed so that the model stays accurate and fair. It's not about deploying of a model, whether that model is working for you or not. We are such a heterogeneous population. Forget about India. दक्षिण जिसे कहते हैं पश्चिमी उत्तर प्रदेश में जो होता है गोरखपुर वाली तरफ वो नहीं होता, जो लखनऊ में होता है वो बनारस में नहीं होता, जो बनारस में होता है वो मेरठ में नहीं होता. We are such a heterogeneous population. How do you expect कि एक मॉडल जो दिल्ली एम्स में बना होगा वो सारी हिंदुस्तान में लग जाएगा, या जो अमेरिका में डेवलप हुआ होगा वो इंडिया में लग जाएगा? इसको कैसे दूर करना है? The ongoing monitoring after deployment of the model to ensure whether it is working properly or not. Again, radiology. AI-driven tools, deep chest X-rays are not the standard in many regions, automatically reading X-rays, identifying TB, early stage of cancers, often outperforming human specialties, and the speed is good and it is consistent. Precision medicine treatment plans are now tailored according to specific genetic makeup by genomics, lifestyle, and environment. But kitne % of population has access to your genomics? Hardly 1%. ये जितनी बड़ी बड़ी कंपनियां होती हैं, they target what 1 to 2% of the HNIs, जिसका is precision medicine, genomics, HNI मतलब हाई नेटवर्क इनकम वालों के पास ही इतने पैसे हैं कि ये सारे टेस्ट करा लें। अभी पीछे आपने इंटरनेट पर रील देखी होगी, 7 रुपए में बिहार के अंदर एक हॉस्पिटल में ब्लड टेस्ट हो रहे हैं। तो देश की 50% जनता तो वही चाहती है, जिनोमिक्स पे तो बाद में पहुंचेगी। एडमिनिस्ट्रेटिव रिलीफ, 30% of the health costs are administrative. AI scribes, billing agents now handle the patient intake, does the coding, ensures pre-authorizations, allowing the doctors to spend more time at patients rather than screens. This again, this is just for completion's sake. ये एक private setup, एक corporate setup के अंदर है। AI एक बाबू का काम कर रही है। आपने हेल्थ इंश्योरेंस ले रखा है, क्या हेल्थ इंश्योरेंस वैलिड है, क्या कोडिंग लगेगी, क्या इंश्योरेंस लग जाएगा, पेशेंट, ये सब चीजें ये कर लेगा आराम से। नाउ वेरेबल्स की बात होती है, हर कोई एप्पल वॉच पहन के घूम रहा है, ठीक है। रियल टाइम प्रिडिक्टिव एडवर्स इवेंट, सेप्सिस, हार्ट फेलियर, ऑल गुड, बट इन अ पर्टिकुलर सेटअप, नॉट फॉर एवरीवन। मॉडल बना लिए, पैसे मिलते हैं बनाने के, क्यों ना बनाए। टेक्नोलॉजी आ गई है, क्यों ना बनाए। वैलिडेट कितने हुए हैं हमारी पॉपुलेशन में। आई विल गिव यू एन एग्जांपल। एम्स के अंदर इतने सारे आईसीयू हैं, एक मॉडल एक आईसीयू में बनाया, दूसरे आईसीयू में नहीं चला। Supposingly, I am developed a model in a surgical ICU. I could not run it successfully in a medical ICU. So 2025 study revealed so many devices and nearly 43% of the recalls happened within the first 1 year. कितने मॉडल बने, कितने डिवाइस बने, सब वापस बुला लिए गए। At least 43% is a good chunk because they were trained on clean university data, which often failed and faced with messy reality of fragmented hospital records and low quality imaging, which is a fact. मैंने पहले एक डिस्क्लेमर दिया था, रेडियोलॉजी एंड नंबर स्पीक। उसके बावजूद भी जितने भी मॉडल्स डेवलप होते हैं ना, दे डेवलप ऑन अ क्लीन डाटा। आप यू योरसेल्फ सी, जितने लोग गवर्नमेंट हॉस्पिटल में काम करते हैं, इवन कॉर्पोरेट हॉस्पिटल्स में, वेयर देयर इज एनी मैनुअल एंट्री, हाउ मेनी ऑफ यू फील द डाटा एंट्री इज कंप्लीट? ठीक है। तो जब ये मॉडल्स बनाए जाते हैं, हमारे जैसे लोग बैठते हैं आईआईटी वालों के साथ, तो कहते हैं जी चलो इतना मिसिंग नंबर है, इस पे बूस्टिंग लगा देते हैं, इतने को डुप्लीकेट कर देते हैं, इतने डाटा को क्लीन कर देते हैं, तो क्लीन डाटा बन जाता है। और वो क्लीन डाटा एक इमरजेंसी में रात को नहीं चलता। जब जिस इमरजेंसी में एक स्ट्रोक आया हुआ है, एक एमआई आया हुआ है, एक रोड ट्रैफिक एक्सीडेंट आया हुआ है, एक बस्ट एब्डोमेन आया हुआ है, फ्रैक्चर आया हुआ है, वहां ये डाटा नहीं चलेगा। तो द रियलिटी इज क्वाइट डिफरेंट। A model that accurately detects sepsis in Boston hospital might fail in an Indian rural clinic because of the difference in demographics, local equipment, even the clinical protocols. This is known as model degradation. Yes, है, सब कुछ खराब नहीं है, but इस मॉडल को अगर आप लगाना चाहते हैं तो you have to retune it. What is called as retuning. इसके बारे में लोग बात कर चुके हैं। If AI suggests a treatment that leads to an adverse event, who is responsible? In 2026, the industry is shifting with the human in the loop, HITL systems, where AI proposes, humans validate, and then specifically manage this legal gray zone. ये चलता रहेगा और ये और आगे आएगा। मशीन ने डिसीजन लिया, डॉक्टर ने उसको वैलिडेट किया, और फिर इसके बीच का जो एरिया है कि वो उससे इन्फ्लुएंस हुआ कि नहीं हुआ, दिस विल बी इन अ ग्रे जोन। So what are the critical challenges? The black box, the explainable AI is now a regulatory requirement. Bias, AI trained limited data sets पे है, ethnicities और genders. There is a global push for inclusive AI. हम कहते हैं ना कि वसुदेव कुटुंबकम, हम सबको मिला लें, inclusive AI, ठीक? Data privacy, yes, with AI needing vast amount of personal health and the breach is a top concern. क्यों हुआ हमारे साथ? हम अच्छा खासा AI डिप्लॉय कर रहे थे, इतनी बड़ी न्यूज़पेपर हेडिंग्स बन के आई थी ना, ये हमारा डाटा चोरी हो गया था। किसको नहीं पता? बिगेस्ट डाटा सेट, पूरे इंडिया का हो गया चोरी। क्योंकि जिस टाइम पे हम इतना बड़ा कुछ सब कुछ कर रहे थे, किसी ने ब्लॉकचेन का नाम ही नहीं सुना था कि ब्लॉकचेन होती क्या है, ब्लॉकचेन को लगाना कैसे है। नो मैटर हाउ मच फायर वॉल्स यू बिल्ट, डाटा इज वेरी प्रीशियस। Last line, the data monetization has become a heated legal and an ethical battlefield. अगर आपका एक सपोजिंगली एक डाटा सेट है एक आईसीयू का, आई विल बी टॉकिंग इन दैट टर्म्स ओनली, एंटी माइक्रोबियल रेजिस्टेंस पैटर्न पता चल जाता है किसी एक स्पेसिफिक कंपनी को कि इनके ये बैक्टीरिया आ रहे हैं और ये है, सो लेट्स पुश दिस ड्रग। That is a simple example of a data monetization. वो आपकी हैबिट्स पढ़ेंगे, आप इन कॉमन टर्म्स, आप बार बार वो नहीं आता आपको फोन के ऊपर मैसेजेस आते रहते हैं डिपेंडिंग अपॉन व्हाट यू स्क्रॉल, दैट इज बेसिकली कैप्चरिंग योर हैबिट्स। सिमिलरली दे विल आल्सो डू इट एंड मोनेटाइज इट। फिर हम लीगली कहेंगे कि हमारी पर्सनल इंफ्रिंजमेंट हो रही है, अभी तक वहां पहुंचे नहीं है बस। दिस इज आई ऑलरेडी टोल्ड, मतलब एक साल पहले तक तो हम यही बात कर रहे थे कि बहुत पीछे हैं, अभी एक साल में कुछ ऐसा खास चेंज हुआ नहीं चाहिए। So what is a FAVES framework? The model should be fair, appropriate, valid, effective, and it should have safety. Pre-deployment data and bias representative data. Was the model trained on a specific population that matches your local demography? That's what I was citing an example. यूपी के अंदर ही इतनी बड़ी वो है, इंडिया के अंदर इतनी बड़ी वो है, आप एक यूएस का मॉडल उठा के इंडिया में लगा देंगे तो कैसे चलेगा? Bias training, subgroup analysis to ensure model does not underdiagnose or specifically marginalize the groups. Interoperability. You should ensure that fast healthcare interoperability resources standards talk to your existing EHRs. ये भी बड़ी बात है। देखिए, आप सबके यहाँ एक सेटअप है, सबके यहाँ मशीन्स लगी हुई हैं, सबके यहाँ पेशेंट्स आ रहे हैं, तो जो भी मॉडल आपके पास आए, it should talk to your existing data set, existing machines. ऐसा कोई मॉडल जिसके लिए आपको नई मशीनें खरीदनी पड़े, दैट इज यूजलेस फॉर अस। हेल्थ केयर का 2% तो हम लगाते नहीं यार पूरी जनता के ऊपर, तो जो करना है उसी में करना है ना। इम्प्लीमेंटेशन, this might sound something different. Establish a protocol where AI results are provisional until and unless it is signed off by a licensed clinician. Mandatory override. ये चीज हमने अपने यहाँ देखी, कुछ लोग इसके अगेंस्ट हैं, कुछ इट इज अगेन एन ओपन डिबेट। जो इवेंट्स रिकॉर्ड हो गए आप उसको फज कर रहे हैं, सबसे कॉमनली यही एग्जांपल दिया जाता है। Why do you want to override? But yes, you cannot totally depend upon the AI. It may pick up artifacts also. पेशेंट की पोजीशनिंग हो रही है, ईसीजी हिल गया और आपने कह दिया रिदमियास आ गए, तो AI will pick up it as an arrhythmia only, ना? It won't pick up what was manually happening at that point of time. Does the tool provide a model card or a heat map showing why it has specifically flagged something? It should be, the patient consent is mandatory and the intake forms to disclose when AI is being able to assist its diagnosis or triage. पीछे आपने एक और मैसेज घूमता हुआ देखा होगा कि एम्स के अंदर रेडियोलॉजिकल रिपोर्टिंग अब AI से होने लगी है। फाइन, यस, बट अगेन वही डिस्क्लेमर के साथ होती है, टू बी रिलेटेड, क्लिनिकली कोरिलेटेड। दूसरा, they picks up only clean x-rays. Any pathology, it specifically flags. But again, फिर मैं वही बोलूँगा, the camera doesn't lie. इसीलिए हम फोटो जो नंबर्स उसी पे पटे हुए हैं, मरीज के हो क्या रहा है क्लिनिकली उस पे नहीं पहुंचे हैं। Algorithmic drift, set a revalidation schedule, 90-day check if the model accuracy is dropping, or rearrange your protocols, change your protocols. अगर आप किसी का मॉडल अडॉप्ट भी कर रहे हैं तो create a no blame reporting channel to the staff और unsafe recommendations, इस पे बाद में आएंगे। हम लोगों ने बहुत कोशिश की, एक मैंने आपको बताया कि जो हमारा डाटा ब्रीच हुआ, we were lacking in blockchain technologies, fine. Second, किसी भी मॉडल के एग्जीक्यूशन में आपको क्या लगता है सबसे मुश्किल काम क्या होता है? ओपन हाउस क्वेश्चन। मैंने आपको एग्जांपल भी दिया था, हमें हमारे अंदर कितने आसानी से रैपिडो, ओला, उबर, जेप्टो, जोमेटो घुस गए हैं। Execution is the most difficult part. Deployment, readiness, everything is fine. Execution is the most difficult part. We started it in our ICU. Chalo ji, paperless ICU rakhenge. Started as a pilot project. It was so difficult to engage the staff. Unko, they are ready to fill the paper. Urine output kitna hai har ghante mein, rather than entering on a computer. No matter how good a model you build, no matter how many drop down boxes you have, इवेंचुअली एक ह्यूमन इंटरफेस लगता है जो कि लैगिंग होता है। मेरे से तो नहीं हो रहा, मैं तो नहीं कर रहा, मैं वैसे ही ठीक हूं। Unless and until that behavioral change comes in you, the model cannot be successful. अभी हमने 2-3 मॉडल्स का जस्ट फॉर द कंप्लीशन से एक मैंने एग्जांपल दिया। अर्ली प्रोग्नोसिस प्रेडिक्शन इन मैकेनिकली वेंटिलेटेड यूजिंग मशीन लर्निंग मॉडल्स। प्रोजेक्ट्स चलते रहे, आईआईटी और हम लोग मिलके काम करते हैं, आईआईटी दिल्ली, और वो बना लिया प्रोजेक्ट, हो गया अर्ली प्रोग्नोसिस। बट अगेन here we tried huge data set, 660 mechanic. It was a very painstaking exercise, सबकी consent लेना। Again I'll tell you, इसके अंदर भी क्या हुआ कि जो अब इतने सारे पेशेंट ले रहे हैं, we could only develop a model. I could not validate it. Fine. And again, datas were missing. I had to, the IIT people had to use their boosters, or what do you say, data copying. इतना ही होगा, ऐसे ही होगा. So I cannot be accurate, although area under the curve सबके अच्छे आ जाते हैं. The 39 features were selected, used SHAP, whatsoever. The automated machine learning model for prognosis prediction may assist clinicians in early triage. Again, prediction with sepsis in tertiary care in a low to middle care ICU. Proposed model could preemptive estimations into prognostications. Predicting mechanical ventilation duration. AI driven prediction of mechanical duration can enhance ICU workflows. ये जितने भी ICU के अंदर करने की कोशिश की, उसका पर्पस सिर्फ ये था कि अगर आपके पास इमरजेंसी में कोई पेशेंट आता है, if you can decide upon whether he requires a ward, he requires an ICU, he requires an HDU, whether he will go on a ventilator. If he goes on a ventilator, how many days he will be ventilated, eventually whether he will survive or not survive. So many models being built. But again, to execute in that emergency in the night with a first year resident or just an intern is very difficult. This is a critical care. It's a roadmap to future, tree-tiered approach. Responsible AI principles should be integrated. Common roadblocks to AI, including technical, organizations, and clinical challenges, still remain a practical roadmap. अब ये एक roadmap देखते हैं, ठीक है? ये basically I am a critical care physician, so I am talking in terms of that. What? To provide a practical overview, how effectively to prepare and implement an AI in ICU. WHO, an international group of AI experts, clinical first-hand experience. ये हर ICU में, हर particular ICU में खुद को करना पड़ेगा. It cannot be extrapolated. So they are giving generalized point. You should have a vision. What is your ICU goal? Your ICU goal should align with the hospital goals. The government set up ICU goals and hospital goals will be different from a corporate goal. Engage a leadership. Start low risk, high value. Start with admission AI. Those patients who can come to ICU, make it AI based. Focus on foundations, digital infrastructure, AI literacy, and form a multidisciplinary AI team. Readiness assessment, evaluate the data. Availability, quality, staff, and workflow readiness. It should inflow. Use a case selection. Have a responsible implementation. Have a governance system. Avoid the pitfalls. Choosing high-risk AI without foundational readiness, failing to involve the clinicians, underestimating the data quality, deploying unvalidated models, lack of continuous validation and monitoring. And then the lesson learned and you adapt. Real-world utility is hampered by operational irrelevance, system constraints, and feedback loops. So these are just for completion's sake. To bridge the gap, advocate for a shift from a treating model as a static product to viewing as a team members, proposed validation strategies, silent validation, and human-centric design. This is a book we are coming up. It's just a amalgamation. We tried to contact people, those who work in AI digital health throughout the world and throughout in India. And I specifically have only 2-3 chapters, not more than that. It was work of Mr. Khare. So my home message will be, take home message will be, treat AI as a co-pilot, not an autopilot. वो हमने देख लिया 141 जब गिरा था, उसको ऑटो पायलट नहीं को पायलट बनाए. Thank you.
Thank you, Doctor. Thank you, Dr. Puneet, for such a frank presentation. Yeah. And why is it important? I'll tell you. I'll go further. That one step further than what you said, and that is because we will never be able to generate honest data with good fidelity. And the reason behind that is, like, whenever there is a patient who goes out with a bad outcome, either is a severe complication or a mortality, then what's the first reaction of the physician or the surgeon? It is to save his own skin, and the data gets fudged at that point. And this will never go on report. It will never go on record. And that's why all the and what AI all driven by the data it has been fed into. And if it is fed with first data, then it becomes a monster.
सर वो बड़ी फेमस सेइंग है ना, जब ये हम शौक होता है हमें शुरू में मेटा एनालिसिस सिस्टमैटिक रिव्यूज करने का, गीगो बोलते हैं हम, गार्बेज इन गार्बेज आउट.
Yeah, exactly.
तो जो अंदर जाएगा वही बाहर आएगा.
But having said that, so that is why it's never going to be honest data that it is being fed with, because and that can be dangerous. For suppose a surgeon is called to a court of law, and then the judge is depending on what the data is coming out from the AI, and he might be said that कभी ये तो कोई होता नहीं, आपने क्या कर दिया आपने.
सर ये ज्यादा दिन दूर नहीं है, अगर आप कभी यूएस गए हो तो वहाँ के नेशनल टीवी पे ना एडवर्टाइजमेंट आती है, एक नॉर्मल एडवर्टाइजमेंट आती है, दूसरी वकीलों की एडवर्टाइजमेंट आती है.
Okay, and but still it has got a role, and the role, yeah, and the role you brought out briefly in just in passing, I think that's a very important role, and that role that you pointed out, like in radiology, so it's a very, like you take, say, X-ray of the chest specifically. I'm very specific here. So our own hospital generates about 500 X-rays of the chest every day. So the AI can be used to screen out all the normal ones and flag out the 20 out of those 500 which need to be seen by the radiologist. So that is the role where we should put, like, that's one example where AI can play a role, but not in decision making in a critical patient, like you pointed out in the beginning.
We have to take, I'm not denying, I told I might be a, yes sir, please.
You talked of AIMS radiology using AI for reporting. So what is the status, and it was only AI or there were also radiologists who were doing it? Sir, because it came in newspaper and there were a lot of
many
meetings
things.
and
I mentioned it, sir. देखिए,
है ना?
उस पे लोगों ने.
I want to keep my question short क्योंकि लंबा question पूछने से then audience का interest खत्म हो जाता है.
Sir, answer भी उतना ही short है.
Yeah.
Existing database, क्योंकि see again I told camera doesn't lie. फोटो है, फोटो झूठ नहीं बोलेगी. तो जितनी फोटो थी उसके बेसिस पे एक मॉडल बनाया, उस मॉडल को एग्जीक्यूट किया और नॉर्मल एक्सरेज को करना शुरू किया, जहां पे फ्लैग, और जो ये बनाने वाले लोग थे अगेन आईआईटी दिल्ली और एम्स. उसके बाद उस मॉडल को एग्जीक्यूट किया, ठीक लगा, और नॉर्मल एक्सरेज को अलग करना शुरू किया. बट अगेन विद अ डिस्क्लेमर, खाली एआई पे नहीं छोड़ा.
Thank you.
तो जाना शुरू होंगे, गए कहाँ हैं?
Thank you.
We are in that process. When the lawsuits will be filed against us.
I think we are.
बहुत टाइम हो गया.
Okay, one last.
Please, yeah, shoot. वो ये है ही इतना interesting topic.
Sir, I'm thankful that you have throw a light to a specific gap. I would like to know your views about the Neuralink. Neuralink. Elon Musk project also.
भैया वो Starlink, Neuralink, इतना नहीं. हम अभी वही मैंने कहा ना कि I mentioned again, getting the highest budget, still we don't have any HR. भाई पहले normal लोगों पे काम कर लेने दो. Sorry.
Previous lectures, I thought that yes, we are a bit backwards in terms of AI.
नहीं sir,
But now you have.
नहीं, see, AI we are adapting into our culture, but again I told na, numbers don't lie. Pathology reports, microbiology की photo, hematology की photo, skin की photo, झूठ नहीं बोल रही होगी, उसी के आप models generate कर सकते हो and you can validate it. Similarly, numbers के model generate कर सकते हो and you can validate it. But general surgery, general medicine, emergency medicine, ICU, it will take a long time. We have a long time to go.
Yeah, there's a term here that what is operator dependent. Whatever is operator dependent, like ultrasonogram, so that can never go into the hands of AI. Yeah.
See, again, if I talk from a corporate and a medical industry setup, it becomes very different. राघवन ने दिखाया था वो एक छोटा सा अल्ट्रासाउंड. सर आप अपने हॉस्पिटल में एक अल्ट्रासाउंड को एक कमरे से दूसरे कमरे में हिला के दिखा दो. फॉरगेट अबाउट सीइंग इट ऑन अ मोबाइल फोन. पीसी पीएनडीटी जान ले लेगा आपकी. आप मोबाइल फोन पे तो भूल जाओ कब देखोगे अल्ट्रासाउंड. So things are very easily, it is very easy to make the thing glamorous. You go to Rajasthan, you go to Maharashtra, यहाँ पे अल्ट्रासाउंड की मशीन डिप्लॉयड है ना, उसके अंदर एक मार्कर लगा हुआ था, यहाँ से हिल के यहाँ तक नहीं आ सकती वो. और आप फोन पे अल्ट्रासाउंड देखने की बात कर रहे हो. बात करनी चाहिए धरातल पे. We should talk about the ground levels of reality.
But सर प्रिवेंटिव मेडिसिन में इसका रोल हो सकता है.
इसमें सर
प्रिवेंटिव मेडिसिन
सर बिल्कुल हो सकता है. परमिशन कौन देगा? मैं अभी ऑस्ट्रेलिया गया था अपने फ्रेंड के पास. इज एन इमरजेंसी मेडिसिन फिजिशियन. डॉक्टर अतुल गोयल सिडनी में काम करते हैं. हम अपने गाड़ी में फोन चार्जिंग पे लगाते हैं, वो अपना प्रोब चार्जिंग पे लगा के बैठे हुए थे. टेस्ला चल रही है, प्रोब लगा हुआ है. तो वो वहां तक पहुंचने में हमें बहुत टाइम है अभी.
So I think the take home message is we should start from the screening and assessment part.
बिल्कुल सही. अब और उसे को पायलट बनाएं, ऑटो पायलट ना बनाएं. सर आप भी फटाफट.
वेरी गुड टॉक सर. सर इसमें जैसे आपने बताया यही से हम नॉर्मल चेक्स रे तो डिस्क्रिमिनेट कर ले रहे हैं, बट अभी मेडिको लीगल कोई गाइडलाइंस या स्टेजिंग है बाई चांस जैसे हमने कोई नॉर्मल एक्सरे बोला उसे
उसमें कुछ निकल आया,
कहीं पे वो एबनॉर्मल आ गया.
सर वो नीचे वही सर बोला ना,
एडमिनिस्ट्रेशन इज रिस्पांसिबल और
एक लाइन लिखी हुई है सर. अभी भी हम बच रहे हैं, अपने आप को बचा रहे हैं. कोरिलेट क्लिनिकली. फांसी लगी हुई है 4 हफ्ते से, बलगम आ रहा है और कह रहे हो एक्सरे ठीक है भैया. कोरिलेट क्लिनिकली. नहीं नहीं, अभी ऐसा कुछ नहीं है. दीज आर वेरी फार फेच टूल्स. सॉरी, वो अगेन डिस्क्लेमर, जो बातें थी वो मेरी थी. दूसरा, सरकार की नहीं थी. तीसरा, मैं पेसिमिस्ट नहीं हूं. आई ऑलवेज ट्राई टू लुक फॉरवर्ड. 4-5 मॉडल बना चुका हूं और कोशिश कर रहा हूं कि किसी तरीके से चल जाएं. थैंक यू.
Thank you so much, sir, for your a very informative talk. So it's now time to call upon our second speaker, Dr. Vikrant Mohanty. Sir will be speaking on AI-enabled tobacco cessation. Sir is a professor, senior professor and head of the department from Maulana Azad Institute of Medical Sciences. And he is a vice president of IA PhD. Sir is.
Thank you so much. I think that much is enough. Thank you so much to the chair and all the members on the dais. And I think where did sir go? Sir, हाँ पीछे बैठ गए हैं. अब sir, you're right on the behind the camera and taking the right picture. Dr. Puneet is taking the right picture from behind the camera. But मुझे लगता है कि सर ने इतना I think धुआंधार उन्होंने बल्लेबाजी की है. It has made my life even more difficult. Because अब कोई, if I slow down the pace and I take you back to numbers, I don't think so many of you would like it. But then yes, as assigned, we have to do our roles and responsibilities. Yes, again, I will come up with disclaimers in some time. But before that, just that I work on certain areas like primarily I'm a dentist, specialist in public health dentistry. Further working in a core area of tobacco cessation, which is something I know many of us as we don't have to step out only. अंदर ही आपको बहुत सारे tobacco users मिल जाएंगे. And as we step out in Banaras, we know what happens. The truth is always on the walls and it is visible clearly. And so that is the biggest problem that we have. I have not developed much models again, but then yes, we have a problem at hand and we are trying to solve it. So through my presentation, I would just bring out what is the current problem that we have in hand, what work is happening across globally, and understand where the challenges lie and what is the road ahead. So that's broadly my talk, and I would just stick to that without taking it any deeper or further. So one disclaimer from my side too. So certain content has been developed from AI, some images. Let's look at this particular opening slide. I think many of us working in government hospitals do understand the number of patients that come report to OPDs. So if this is the status in a government dental hospital where a patient who's a daily wage laborer comes to you telling that he has certain burning sensation, he's been using some form of chewable tobacco with certain mucosal changes, and you have there's a consultant and then there's a junior who's sitting, and as soon as the consultant sees कि अच्छा इसको बता दो छोड़ना है and give him the medications and just send him back. So that's like, because time बहुत कम होता है, contact period तो छोड़ ही दीजिए, कितने की बात है, वो तो बोलते बोलते वो आधा चीज prescription लिख भी चुका होता है. So when that is happening, that is what reality. And then the next thing, only thing that would be said to that patient who is from a lower socioeconomic with lower educational status is that देखो भैया छोड़ दो वरना cancer हो जाएगा. So a very single straightforward fear is instilled in the patient, the person who is right there, without addressing much of his behavioral or his psychological or his deeper needs that could have been addressed. But yes, there's a challenge, the numbers, and this side is a patient who would want that the doctor could have spoken to him a little bit more. Next, I will just, the next slide. Yeah, I think the slide changes here. Same thing, look into the realms of AI coming into picture. So before the patient walks to the doctor, he is being assisted through a simple model in which he gets his digital interface where he interacts, shares his information, gets his clinical pictures clicked, and gets certain information already before he moves in front of the doctor. Doctor is looking at the screen. The junior has already read the screen data and has already informed. A summary is created out of that data, and that data is being shared with the consultant. Consultant quickly says that you need to undergo this, but at the same time also links him back to the system, which automatically starts sending him either reminder messages or connecting him with the local primary healthcare setup. So we can look at things differently in times to come. I'm not saying it's happening today, but this is the picture that we would obviously like to envision, where is this what I just said, is this a reality or still it is a collective imagination? It still remains as a collective imagination is because we know, and I will talk about the problem in some time, because we're just opening up, trying to understand where this interface lies. And let me tell you, I just recently heard one of the speakers who told that AI is nothing but an outcome of philosophical thinking. It is an imagination which someone actually thought of, and thought of that there's a problem, and maybe he thought of there could be possible solutions, and those solutions were either handwritten or drawn, and then they were taken up by data analysts, and then they were coded, and then they came up with certain models, and these models are being tested, and ultimately it's now an algorithm that we are trying to use to solve a problem. So it is out of an imagination that it has led to certain changes like this. So taking things further, we all know that tobacco use in general is a huge problem, and it is one of the biggest problem in terms of any of the non-communicable diseases, whether it is cardiovascular, respiratory, dental health or oral health, number of cancers. Tobacco use, affects from the tip of the hair to the tip of the nail on your toe. Every body part is affected, and the burden is straight in front of us. Talk about, this is how the growing numbers are, and we'll not go into details of this. But if we look at what happens in this particular problem of tobacco use, I have broken it down in three parts. Tobacco use has its own physical dependence, it has its own behavioral dependence, and there's an environmental issue also. And when we talk about environment, there could be, peers who are around, there could be colleagues who are around. There are cues like models around, like, heroes or people who are influencing you and ultimately are causing triggers to you. So when the problem is large and the problem is multifaceted, we can't go with a single solution. A single solution may or may not work. Taking things further, trying to also understand what happens when the person is addicted to tobacco use. It's a cyclic process. As soon as someone consumes tobacco, whether smokes or chews, it enters into the system, reaches the brain in no time. And again, there's a release of these, amazing neurotransmitters like dopamine, which is a reward pathway and completes the cycle, as a result of which the person starts, feeling a sense of pleasure, relaxation, and a level of stress which is being relieved. So when such a pleasurable sensation is right happening in front of someone in someone's body, how do you think you can retrieve it? And when the levels go down, automatically the person's demands or the body starts demanding for more. So that's a cycle which happens, and we need to break that addiction cycle that is happening. So we have to put all these things in front of us, because if you want to develop a solution, it has to meet these needs that we're talking about. I've already told you about, and being from the health background, I don't think so this requires much of orientation. But let's see what is the current status of tobacco support or cessation support, which is one of the WHO's mandate under the Empower strategy. There's an Empower public health strategy, one of the I would say, broadly implemented strategy under the Framework Convention of Tobacco Control by the WHO, which has been signed by more than 180 plus countries and being implemented across the country in Empower, MPOWER. It stands as, this is what Empower means, in which O means offer to support. So offer to support is about cessation, about provision of cessation services. You look at this map and you still see that huge gaps still remain in cessation. This is global data. And when we look at Asia specific data, India seems to be on the blue, where most of the services are covered according to what the data says. But again, as what sir said, the data is what is being shown, is what has been, the right photograph has been clicked, the right information is being provided, but you still see huge numbers outside your, anywhere you walk out. Whether he's a taxi driver, whether he's a rickshaw puller, whether he's a ward boy, whether he's even a doctor, surgeon, or whether he's, anyone, whether it's a male or a female. Today we see these numbers greatly being influenced by many aspects. If you look at the last data which was submitted by the GATS, the Global Adult Tobacco Survey, again a standardized survey, you would see that there is huge numbers in terms of people who are consuming. Currently, 30 people out of 100 in India are actually smoking or chewing some form of tobacco. And if you look at them, almost 55 to 60% of them want to quit it, but they are unable to do it. The kind of support that they get is hardly anything. You see this graph, it talks almost 70% of those who want to quit do not receive any support. The kind of numbers that we talk about, these are what data has actually shown. The amount of medications, the amount of behavioral counseling, the amount of switching over to different products is still very low, and amount of people who are trying to quit is huge without any support. So why I'm trying to talk about all these things is because we have to first bring what is the problem in front of us. We have numbers, we have a problem at large, and now we need to look at what are the successful interventions that are happening. And then we need to look at whether these interventions are actually happening in our country or not. And we have to see whether our, the capacities among the healthcare professionals is there or not to address these situations and address this particular interventions. So when all these things are put together, we see there's a huge gap. Demand from the patient side is there, but there is no much focus from the healthcare professionals. They are not very inclined to discuss this particular issue, try to develop a behavioral plan and try to help the patient. So when that kind of gaps are there, we need to know that what are the, these are the existing current approaches which are there, and the limitations remain that tobacco cessation clinic, though the government of India has made a lot of effort under the National Tobacco Control Program, under the National Oral Health Program, but still the number of tobacco cessation services at, in dental colleges have opened up, in medical colleges, just 2024 it started off, but we all know the status of these cessation services or these services which are there for the patients. Patient is never aware where even forget about the patient. The people working in the medical college, dental college are not aware where this particular clinic is. They don't even know who sits there. They don't even know what is the, course of action that the patient would receive there. So keeping all these limitations, access is poor. There are resource constraints. There is a huge relapse because tobacco is so addictive that patients fall into this trap every now and then and go back into consuming furthermore. And there's limited personalization in terms of, what sir was talking about. Once I think Dr. Kishore was talking about is one size does not fit all. So we need to understand that every patient's demand or every person's tobacco use practice is different than the other. And we cannot generalize one model to other. Like how Dr. Puneet also said that what models work in the US don't work here, because in Western UP, in UP itself, the model, the variation is so much, the patterns are so different that we cannot actually say that this model will be working. So we need to understand that there's a problem at large, and we know that AI is is one of the many things that we can talk about in terms of addressing this gap. So we know where all it is being used. But what we have to understand that now people have started working on more personalized care. I think precision medicine is already there. Now personalized care. If, for example, if you look at what sir was talking about in terms of Blinkit, in terms of Zomato, they give us once after doing the purchases, it already starts giving you recommendations in terms of what you did, what was the last purchases that you made, what are the items that you like, and there are certain kind of push messages or reminders which are sent to you, which all of us allow in our phones. So that kind of adaptability is what we're looking at. So this is what now has happened, that the demand for cessation and personalized medicine is increasing. And to use that particular gap, we need to address. The growth is tremendous over the years. We have seen that the amount of AI applications that have been developed or platforms that are developed to address cessation needs are also on the rise. And if you look at the different models that have come up, we all know about, we've been talking since yesterday, there was a brilliant workshop, and now we're talking, and today and tomorrow we will be discussing about different ways. And already these platforms are in place. There are conversational AI models, there are social media monitoring models. They look at what kind of searches you're doing in terms of tobacco use, and there are predictive analytics in terms of understanding that if you are a user today with this kind of pattern, when do you think you will be able to quit based on the current trends? Or what all things can be added to improve your quit outcomes? So there are many such interventions which are personalized. And obviously there are, I know, newer, all these things are now working as a combination and also in isolation. So other than that, other than cessation, the tobacco control also, there are a lot of AI platforms which have been done. We'll not go into details of this. Look at this particular thing wherein people have been working. They don't limit themselves to only specifically cessation, but they've already taken into the empower strategies, and they're trying to develop AI platforms where reporting is better, where information is more accessible. WHO came up with Sara, which is the AI related a health assistant which can speak in different languages globally, and was able to interact as a personal health I would say guide to patients. Further, there are certain tools which came up which try to analyze sentiments. For example, right now, if someone is under stress, so it understands the kind, and it like a variable is there, and variable is able to detect this change in your pulse and automatically says that this could be possibly because this is the usual time that you consume your tobacco and you're not consuming it right now. It sends a reminder to you that, okay, now it understands your sentiment, it understands the changes that are happening and automatically sends you reminders. So we can have such kind of networks which are actually used not only in sentiment analysis in terms of when it is your own personal changes, but also the way you search over the internet and other places. So AI can be used, one, in terms of counseling, in terms of reminders, in terms of your reminders, in terms of medication, reminders for healthcare providers, reminders in behavioral counseling, as well as quit lines. I'm not sure how many of you have heard of the National Tobacco Quit Line services, which are again manually manned by counselors, and the kind of load that they have, they are hardly able to attend 10 to 12% of the calls that they get. If they receive 100 calls, only 10 calls are answered completely. So you can understand the amount of demand that is there for such services. So we are looking at solutions where the human interface is not eliminated. As Sir said, it is not going to autopilot mode, but a co-pilot mode where before the person reaches the actual end counselor or healthcare professional, he is being able to get some information. So keeping that in mind, I think wearables are something which all of us are aware today in terms of understanding the real-time craving detection can be there. It can be just-in-time interventions wherein we, in timely fashion, we are able to remind our patients regarding the craving pattern, as well as send reminders so that they can modify their behavior rather than getting trapped to the craving cycle which is there. So all these interventions put together, we did review a particular article where we saw that they did a very good systematic review and a meta-analysis of the data that was there. But yes, this data was only based on certain studies which were done only in certain regions of the world and had a lot of bias in terms of because they just looked into certain things, mainly looked into the kind of I would say chatbots, social media, and avatar-based interventions which focused on AI. So there's a huge, though this study particular showed us that there's almost there is inclination, there is a success in terms of using AI in cessation, but we still need to work more in developing models which are more relevant to what our country or our cultural demands are. So there are huge gaps because most of these studies were based on small sample size, short follow-up periods, and there was a high risk of bias in most of the studies and the lack of control groups. Most of them were on interventions. So we need to focus more on these gaps and try to develop certain strategies which can bridge this gap. So another study which actually worked on cessation messages, where they were able to understand the emotions, provide messages which are more appealing to them, as well as have the understanding of risk perception, where all situations the risk was there, and accordingly try to understand and fill that gap in particularly in those situations. So this led to a very important aspect that they were able to scale it up to effective messages, provide risk awareness, and at the same time, they've also increased the outreach by such a service because it was not limited to just tobacco users, but also targeted non-users so that they are also, provided information in a different manner. Again, this was another prediction analysis in terms of data, like what Sir was talking about in terms of the real-time data which is given to the patient from the patients can be analyzed, and we can do proper predictions so that we can analyze when this particular patient is going to quit or how long will he continue even after having these kind of habits. So this particular study looked into that, and this particular study was able to use experiential AI, and that was actually helping patients to quit the habit better. So the key insights, more or less, from what existing research is currently there, says that the predictive accuracy of the particular studies that I just quoted were good, almost 80%. They were effective in their communications because many of them were based on certain behavior, certain understanding of the patient's personality, and then it had the ability to scale up because it targeted not only patients but also looked at non-users or non-tobacco users. So we need to move from what we look at chairside, that is mainly in terms of a dentist, we look from chairside to community, because that is where our ultimate goal as a public health expert is, that we move from just looking at one-to-one patients at a larger public health problem. So we need to obviously look at how detection can be improved. We need to look at how we can improve screening and ultimately bridge this gap between screening and prevention before the disease occurs to into a bigger problem. We need to target regions where primary prevention is key. That is at the school level, it's at an early age group itself. We can have gamifications with the use of certain AI tools where games are created for children to understand what would happen if they enter into a game, enter into such a habit, and what could be the possible outcomes. We need to look at the upstream, that is at the policy level also, and monitoring the data also, because both the ends, that is the downstream as well as the upstream, if addressed properly, will able to, I would take that, what I would say, we would be able to put an end to the problem that we're looking at. So ultimately, the benefits of such AI tools would be that they're going to be cost effective. They would reduce the time period between the healthcare provider as well as the patient. There would be a broader reach in terms of usability. Real-time analysis can be there based on the data that is entered, transparency, and obviously it would be data-driven. There are gaps mainly in terms of privacy, in terms of personal information, in terms of ethical issues, as well as regulatory, I would say, oversight might also be there in many of these apps, which has need to be, needs to be bridged. So we need to work on low resource settings. That is what is happening in our country, is more or less like where we have people, but we still don't have the right kind of people to address the right kind of problem. Most of us are actually trapped up either in administrative roles or in clinical overloaded OPDs, where such time is not available to address patient issues. So we need to look at issues like that. And one, because India has a diverse cultural fabric, it is important to understand, to address these issues also, we need to develop certain strategies. So what we need is, we need to look at how we can implement them. We need to look at the equity. We need to look at cultural adaptation, and at the same time, cost effectiveness.
Obviously, how they can be addressed is by use of all the different models of AI that we just spoke about and what has been discussed previously, keeping in mind that there could be challenges because data is something which is being manually fed. It is important that the data be collected properly and then fed properly. And obviously, we need to have checks to have that data quality in mind. And privacy and security remains a big challenge. And in terms of user acceptance, which is ultimately the, even if you develop a beautiful AI model, until and unless the user is not accepting it, all these problems will be a failure. All these solutions that you provide are going to be a failure. So what we talked about is tobacco use itself should be a part of the basic case history as well as the EHR that we're looking at. It should be integrated. Like we have telemedicine here, there could be teleconsultation services that could be integrated. It should be a part of the routine workflows and a proper referral pathway has to be there. So just to conclude, I would say that though AI has been addressing many aspects of healthcare in terms of diagnostics, in terms of data management, but when it comes to personalized care, we need little bit more than what we have just looked into. It has to be culturally sensitive. It has to be personalized based on what the patient input parameters are. It has to be specific to what kind of educational or socioeconomic background they come from. Because we have also seen that developing the apps or developing these platforms in multiple languages also helps to address these problems. And at the same time, we need to be able to understand the ethical challenges, the data privacy challenges, as well as the regulatory challenges to address. So a multidisciplinary collaboration between the industry, between the healthcare professionals, as well as the patient who are the end users need to be there so that we are able to address this larger problem that we're looking at. So I would just like to conclude by saying that the greatest promise that AI brings in is not to replace human. And I again end with what Sir just, Dr. Puneet just said, that we are not looking at an autopilot here. We're looking at a co-pilot here. We're looking at a person a person who is there with the patient all the time addressing these needs so that the doctor or the healthcare interface is reduced. But whenever it is required, we are able to provide that kind of services. Thank you so much for your patient hearing. I do understand it was a pretty generic presentation in terms of, what the problem statement is something which we have to go back with because the solutions in this area are still very less. And specifically because our country is so diverse, we don't have solutions at this point of time. So whatever data has been presented is global data or specifically, I would say the US or in China, certain countries, but in India specific, there are not many AI platforms which are providing this kind of services. So there remains a huge scope to address this. And I think many of the young researchers who are working here can think about developing and working on these areas that we've just talked about. Thank you.
Thank you, Dr. Puneet. Very nice talk. Any comments?
So Dr. Puneet just finished.
Sorry, Dr. Vikrant. Dr. Vikrant, sorry.
Yeah,
sorry.
I know it was very impactful.
Yeah, sorry. Yeah.
Dr. Puneet, that's why I was telling, I was going to find it very difficult speaking after you because, even after the next speaker.
My apologies.
No, not sir. That was just on the lighter side.
Somebody wants to say.
You told us that बहुत सारे calls were not attended by the counselors. So how AI, ultimately patient has to be counseled for cessation of tobacco. Ultimately AI is for clinician or a counselor to tell how to counsel, but how patient is going to contact with AI to get counsel for cessation of tobacco.
So that's what the government of India is right now working with is, see, we have the healthcare providers of different, whether dentists, clinicians, all of them are there in one. That is one, one. We have the quit line, which is the next aspect. Quit line is where counselors are there. And then we have the patient. So like right now, all the tobacco products have the quit line number displayed on it. So what they do is that is now motivating them to call them there. So before they reach the quit line services, the counselor, the waiting period which is there is one interface where we can have AI, where they can start, digital counselors can start interacting with the patients before the basic data is already collected there.
So like in like in our government setup, we have a cell called non-communicable disease.
Correct.
So
And that is where the counselor is also sitting.
yes, so they have a different dedicated number for that.
Correct.
But there is no such app, especially, I mean, I'm from Department of Health and Family Welfare only, but that app is not there, but that helpline is there.
Yes, that is what the government is trying to build. It is trying to integrate all these things into one platform so that this kind of info, that the lag which is there. Like, for example, I told you only 10 patients are able to get this counseling services over the phone. The 90 remain without this service.
So do you have data for that? I mean, how did you just get this data? Because we have a different dedicated number. It's not like
No, I'm not
toll-free
talking
number.
about NCD. I'm not talking about NCD. I'm talking about the NTQLS.
No, see, NTQLS is different from NCDS, but in like it's a in national level.
Correct,
What you are
correct,
saying.
correct.
But at state level and that too on a district level, we have NCD cell which have a dedicated BSNL number. It's not like a toll-free number. It's a
Correct.
mobile number.
Okay.
Where patient can call directly, and there are like telemedicine. We have doctors, so we have counselors for that also.
Okay.
So,
But
I
we
mean-
ultimately the data, as in that is a maybe a district level data or state level data. We need to look at the the overall country. So I'm not very sure whether NCD this kind of reporting is there uniformly
Yes,
across.
they have a different HMIS portal. For
Yeah,
that.
I know that.
Then at that HMIS portal, we have to report that how many
That
calls
is-
you have received.
Yes.
And if they have missed a call, then you have to call back to that number.
I
It's
know
like-
that is there.
like-
That is
like-
very much there.
Yeah, like in psychological counseling, they have suicidal tendencies. People are there. So
Correct.
for their counseling, they have a different dedicated number. So like this, we also have this different.
So ultimately, the GATS-3 will tell us all these numbers and all this data, whether they have reduced, like 28.6 is the burden right now, whether it has come down or not. Then only we will say all this was successful.
That's what I'm saying. Data will only say, sir.
Data only will
Data will only say.
And what data I'm giving you is published data by Dr. Rajkumar, who's the head of NTQLS in Delhi. It's a published paper in respiratory medicine, in the Journal of Respiratory Medicine.
So ultimately, you are saying, sir, that with AI, we need to develop a tool for counselors only first.
Yes, not counselors. It's going to be a uniform service for all the, a bridge between the counselor, as the healthcare provider, and the patient.
Thank you.
Yeah.
Thank you. But end of the day, Dr.
Yeah.
Vedant, phone call is never going to replace the human interaction.
No, not at all.
Because this cessation of smoking or tobacco use, the intellectual input is one thing, but that's only part of the problem.
Yes, sir.
More than 50% of the problem is the fear psychosis, the feeling of empathy, and support provided, which only a contact with another patient
Totally
or human
agree,
being
sir.
can.
Totally agree.
That
We-
AI is never going to replace.
It's not going to replace that because this is a more personal issue, and they sending reminders might be overwhelming many
Exactly.
times. Sending videos or content like voice messages can also be very scary and might be not even looked into because people are busy with their day-to-day practices. So they don't, and only when they go to a healthcare provider, they are more all ears to that. So I think we have to look at it in a staggered manner. We have to look at this is a particular gap which is being addressed with AI. This is where the healthcare professional will always be there, and this is where at the end data is going to be managed and how it's going to help us in all this bridging this gap.
Okay. Yes. Thank you, Dr. Vikrant.
Thank you.
Thank you so much, Dr.
Yeah.
Vikrant, for excellent presentation.
Thank you.
So we are already running short of time.
Yeah.
So we close this session.
Thank you.
Thank you.
Thank you so much for your patient hearing.
Thank you.
I'd like to thank our chairperson and speakers for such a highly informative session. Now I'd like to request them to kindly proceed to the selfie point for facilitation.
Good afternoon, respected faculties and dear delegates. There is a small announcement I would like to share that I would like the delegates who are presenting the posters kindly go to their designated panels and put up their posters if anyone is lacking. And also there is a evaluation of posters at 3:30 p.m. So everyone who is presenting should be there at 3:30 p.m. Thank you.
Now moving further with session 4 of today's scientific program, it gives us immense pleasure to invite respected chairperson, Professor Bikram Gupta sir, Professor Department of Anesthesiology, IMS BHU, Professor Dharmendra Jain sir, Professor Department of Cardiology, IMS BHU, and Dr. Ritesh Kumar sir, Department of Endocrinology, IMS BHU.
So kindly, yes. So kindly come on the stage. Thank you, sir.
Good afternoon, everyone. So I would like to invite for next lecture Dr. Amit Agrawal. He's a project lead and coordinator, PGI Chandigarh, and his area of interest is artificial intelligence, telemedicine, and cybersecurity. So over to you, sir.
Thank you. Can you put the presentation? So actually, there are a lot of talks about the AI and how the deep learning and AI models working and in the different areas. So I am here to tell you about the bridge between the telemedicine and the AI, which is the basic theme of this conference, how telemedicine and AI can bridge itself. And because I am working with closely with the Ministry of Health and how the ministry is doing the things and how the PGI is working, the RRCs are working. So my talk is related to this only. Why the telemedicine is needed in the in India, in our country? You all know that there is high disease burden with persistent specialist shortage there, and there is a huge gap between the patient and doctor ratio is 1:1500 plus. There is a significant rural and urban healthcare access gaps is also there, and telemedicine is the basic you can say the national healthcare to access this gap. एंड यहाँ पे एआई कहाँ यूज हो सकता है बिकॉज वी हैव टू सी दी we have to enhance the scale, the efficiency and the quality. So we know that if we integrate the AI in the telemedicine platform, it more enhance the quality, which is mostly important now because you in the previous call also you said that the 100 calls, the 10 calls is mainly efficient calls or quality calls. So we have to check there by integrating the AI. So when I talk about the Indian telemedicine journey, you can see that in 1990s to 2018, there is a foundation, there is a pilot projects of the ISRO, and in 2015, the National Medical College Network is there, and different regional resource centers has been made by the Ministry of Health. As the BHU also, the regional resource center in the eastern region, the PGI Chandigarh in the north, and SCPGI in the eastern region also. And there are 8 RRCs now in the different parts of India, and we are catering the telemedicine facilities are there. In 2019 to 22 is the best medical telemedicine era because of the COVID pandemic. The telemedicine importance लोगों को समझ में आई कि क्या है. And in 2020 telemedicine practice guidelines, actually उससे पहले कोई practice guidelines नहीं थी how to do the teleconsultations. So when the ministry and जब COVID आया उस time पे the ministry उनको realize हुआ that it is needed. So in 2020 ministry that telemedicine practice guidelines released in 2020, and in 2022 there are center of excellence are made in PGI Chandigarh, AIMS Rishikesh, and AIMS Delhi. In 2020 through 2026, we are now in the AI-enabled era, and we are now the center of excellence for AI, and taking many many AI projects in India. So in the telemedicine, it is the national telemedicine platform is eSanjeevani, and eSanjeevani, you know, all know that there are two models are working in eSanjeevani, that is patient to doctor and doctor to doctor platform. And there is a large scale adoption. Every state, every union territories are now adopting the eSanjeevani in their healthcare system. And but it is always enhanced service expansion is needed. So we need the AI to manage the exponential scale, because now 1 crore plus consultations are doing by the eSanjeevani. So how we can analyze the quality calls, how we can do the clinical decision support system, how we can do the AI in that, it is very much needed. So you can see the national impact that 370 million teleconsultations are there, $3 billion saving by the eSanjeevani, and it is the number one global leadership. So when we talk about the policy context, it is the growing clinical workload and disease burden day by day, and we need the early diagnosis, prediction, and prioritization. And AI is the best enable for the telemedicine digital health, and it is aligned with the Ministry of Health digital health strategy. So when we talk about the hub and spoke model in the telemedicine, the teleconsultation, we all know that the spokes are the Ayushman Arogya Mandirs. 1.5 lakh Ayushman Arogya Mandir are there in India, and we all know that they are connected with the hubs in specialty hub, in super specialty hub. So, but what is the AI when we the need of the hour is to enable the AI between the spokes and between the hubs, so that they can screen better, they can triage, and preliminary diagnosis can be there. So in the same lines, we have 4 layers. Actually, we have 3 layers, and we have to integrate the AI layer in that. So we have the patient layer. Patient has their mobile application, web portal like eSanjeevani and other platforms, and they have to they can go to the health and wellness center, and where they can ask the doctor, if doctor see that there is a problem and he cannot diagnose the thing, he can refer the call to the specialist. He can do the call to the referral end. There is a service layer, that is the registration, the video consultation, e-prescription generated in the eSanjeevani, and the clinical layer where the general doctor, specialist, and super specialists are there. But we have to integrate the AI layer between the service layer and the clinical layer to for the smart triage, for the diagnostic assist, for the language AI, and for the CDSS engine. So key AI use cases in telemedicine. So we can do the AI based triaging and assessment, so that we can use the chatbots, we can use the intelligent symptom checkers, and access the patient conditions severely before doctor interaction, and direct the patient to the point of appropriate patient of care. We can do the AI based, we can integrate the AI assisted diagnosis like biochemistry analysis, the microbiology analysis embedded in the eSanjeevani platform, so that, and other mobile application which already developed. So we can integrate this in the eSanjeevani or AI based diagnosis can be embedded. Automated telefollow, because now what is the focus of the Ministry of Health is like to for the telefollow-ups. So we are working on the telefollow-up session, like when the patient is doing the physical consultation, first physical consultation in the hospital. After the physical consultation, his EMR can be built in the hospital, and after that he can call online or online consultation according to the patient consent. So that after 6 months, जैसे patient आता है for only writing the prescription की same medication, so वो जो burden है it can reduce. Or in the future, we can start the smart scheduling system, so that patient and himself can do timely do the consultation like from the referral end. Tele ICU is now is very important and real time requirement, and it is been very much in flow of or very much need in the countrywide. So just for example, suppose there is a tele follow-up. So problem is we have already the hospitals are overburdened OPDs, and there are fragmented follow-ups. We don't know the patient care actually. So and long waiting lines. So what AI solution can do? They can work with the national telemedicine workflows. They can automate their scheduling, and they can the risk stratifications can be there. So what is the impact on that? That they can reduce the tertiary care load. They can improve the it can improve the outcomes and enhance the patient satisfaction and adherence. So how the policy and government framework, everything, every telemedicine consultation or AI is aligned with the ABDM. Already the previous speakers already told about that the Ayushman Bharat digital mission should be, it should be aligned with that. And it always follow the telemedicine practice guidelines, which is released by the ministry in 2020. And it has to be follow the DPDP Act because it is very important now. And India is already been and developed the DPDP Act, and the AI which is to be deployed is ethical. So always the AI is to should be like no bias will be there. transparent will be there, and human in the loop is always been there. So it is like compliant, secure, and transparent ethical AI should be there. So the key challenges for integrating the AI is the data quality and interoperability. The most important is that, because the data is not what we have in the files here, or we are entering the data is not the good quality data. Because suppose some data entry operator or someone is entering the data in the computer, if यदि हम एज की बात करें, यदि वो ईयर में लिख देगा, लाइक सारे ईयर्स में होने चाहिए और ईयर और मंथ, तो वो क्लीन डाटा नहीं होगा. इट इज लाइक, so clean data is most important in building the AI, and data quality is very much important. Second is the infrastructure and connectivity. Every telemedicine facility need the robust infrastructure and connectivity, so that every rural and urban area, or where the remote area, should be connected with the telemedicine center, or with the regional resource center hub, so that the high resolution imaging, everything comes from there. It should be recognized by the AI. The clinical trust and adoption, it is very much important, because you all listen from the morning that black box is there. So clinician has to be adopt the AI technology. The regulatory framework, the policy, the AI liability, their validation, and their algorithm, the data privacy, data confidentiality, everything will be there as a regulatory frameworks. So how is the role of PGIMER, and what we are doing in the AI and telemedicine is equal to the BHU is doing as a telemedicine. But as we are the Center of Excellence for AI, so we are the national leadership now, and in the digital health policy, we are doing the different capacity building workshops for the AI, for the clinician, in the prompt writing, actually, because a clinician doesn't know or doesn't want to do the coding and everything. So we do the workshop for the prompt writing, and we have to, like, because in the regional resource center is basically with the Ministry of Health directly. We are catering with the Ministry of Health, so we are bridging the gap between the ministry and with the central policies. And evaluation is scale up is the most important for the AI tool. So we are doing, basically, I just want to show you that we are doing the two basic AI applications in PGH Chandigarh. First is the AI MAH study, which is already been completed, and it is in the testing phase. It is the AI-based mortality prediction in alcoholic hepatitis with the Ministry of Health and Family Welfare. The second is AI-based oral cancer risk assessment. This talk will be given by tomorrow. Dr. Arpit Gupta is there. He is the PI of this project. And there are different ICMR funded project, like related to diagnostic accuracy and validation studies and translation of AI model into the clinical workflows. So the regional resource centers of telemedicine can act as a implementation and capacity building workshops. They can support the AI enabled telemedicine deployment. They can train the clinician and healthcare workers for the AI, and monitoring, evaluation, and feedback given to the MHFW for better AI deployment. And what are the associated medical colleges with the RRCs can do? They can act as an associate center for AI projects, because when the AI is like developing in the only in one center, it is given the bias. So if we act with the as a like multi-centric studies, so the data is diverse, and we can build a robust AI model. So so the regional resource center, what the medical colleges associated with the regional resource center, they can act as a associate centers for the AI projects. They can provide clinical data and validation for the validation support, and they are integrate the AI. And the most important, the medical colleges uh, can build something and talk to the higher authorities to uh, for the digital health into their curriculum. That is most important, because now if we teach the digital health and telemedicine in the curriculum of NMC, it will be better for the future perspective. And they can support research, innovation, and for the scale up. So if we talk about the 2027 plus, we will work on the, like, basically in the generative AI. The robotic telesurgery is now in the infrastructure field. And there is a quality and global scale we can scale up for the strategic shift for the patient safety and replicating the model globally. So Ministry of Health National AI Initiative. So the Ministry of Health made the AI Kosh, establishment the AI Kosh. AI Kosh is the data for they can the researcher who are doing the AI application, who are doing the PhD or MD thesis in the AI, they can take the data from the AI Kosh for their research purpose. And there is a technical and policy guidelines for AI adoption. Recently there is a conference between the NHA and Ministry of Health, and they are making the Sahi. Sahi is like a strategy for artificial intelligence in healthcare in India. So they are working on the strategy to roll out the basic strategy of AI in for the India. The capacity building across states and institution are been the initiative, and the all the alignments with the National Digital Health Mission. So National Committee is for the AI is there in the government. They can check the ethical, legal, and the regulatory oversight, and how they are standardized and validation. They are doing the validation throughout the year. So it is checking, rechecking, and rechecking again and again for the models that it is doing good or not, and ensuring the responsible and safe AI use. So the way forward is we have to be this AI should be integrated standard way, and it has been used because we have to do the capacity building in each and every college. We have to do the capacity building workshops how AI can be used for the clinician, and we have to think that AI will not replace the clinician. Always human will be in the loop in the AI model, and it always need the robust and governance should be there, that implementation of this AI should be efficacious, should be safe and ethical for the use, and always need a collaboration between the academics, between the ministry, or and between the innovators or between the industry, so that it can be scaled up. So the validated AI models through telemedicine platform is needed, and RRC-led strength, the implementation of AI in the RRC's Regional Resource Center strategically is very important, and clinician AI collaboration is to be promoted, and continuous evaluation is needed. So in the conclusion, there are four parameters like AI act as a powerful catalyst, exponentially increase the reach, efficiency, and speed of telemedicine delivery in remote population. AI is designed to support and enhance the human expertise, empowering healthcare professionals rather than replacing them. There should be a trust, because everything is related to the clinical trust. So robust regulatory frameworks, data privacy, and ethical guidelines are essential to build the clinical trust. And universal health coverage should be achieving the critical technology pillar for achieving this USC. So in the conclusion, the AI is a strategic enabler for the equitable healthcare delivery. The COE AI provides the national leadership, and Ministry of Health and Family Welfare initiative to ensure safe, ethical, and scalable adoption. Thank you. Any questions, please?
Thank you, Dr. Amit. I want to say something that we will take only one or two questions because our next program is inaugural function. So I was part of the telemedicine since it started here at the RRC. So I found that there was versions of that software where we interact in the eSanjeevani, and in 1.0 it was there very good separation of super specialty patients coming to only to super specialist. In 2.0 it is lacking. So then we lost our interest and now not part of that. We are waiting for that solution. So can you have?
So actually, sir, recently in like 2 or 3 days back, we are again inbuilt this eSanjeevani, the super specialist and specialist. Last 3 days back, already it is incorporated, and if you see the eSanjeevani, there is an option. You can check the where to go. thing.
So that's
Yeah,
good
it
thing. I
missed
think.
it missed in the 2.0, but
Yes.
it is coming in
Because
T3.0.
we expect something one from two should be
Yes,
some
yes.
more AI enabled. So I think rightly done. And I want to inform the audience that eSanjeevani is a platform from very good platform, and where any patients like CGHS patients from home, they can get the prescription signed by your specialist or super specialist, and it's valid for reimbursement also. They will get the prescription just like when you prescribe it on your clinic. So that same prescription with your same sign, with same format, it will go to the patient in a soft copy, and it is valid for reimbursement. So those people which are coming to your clinic just for the reimbursement purpose, they are getting it continue same treatment, that can be avoided. This is the beauty of this. And other things are there that the people should not travel for a asymptomatic that atypical chest pain, which we can identify and talk to the patient in this Sanjeevani, just like you are talking to in your clinic. You can do video call, you can do chatting, you can do whatever means is possible, and network whatever allows. So it's a very good platform, and I think we should encourage eSanjeevani, and such platforms should be accessible to all. That should be the, I think, Madam can also favor this, that eSanjeevani should be advertised more. I think it is underutilized.
That's why we are doing the eSanjeevani follow-up. It is the dream of Ministry of Health, so that we can reduce the burden of the tertiary care hospitals in AIMS, PGI, BHU, where the patient load is very much. So because patients are coming only for the just same medication as before. So that kind of patient, they are traveling so much from different areas, and they are coming here. So economic saving, the distance saving, the
Time saving.
yeah, time saving. So we have done the research also on this, and we have find that approximately there is 972 rupees is saving for government for every consultation.
Another thing, how in a spoke model he talked about, for that we have done a pilot study from ICMR for STEMI patients, which needs to be thrombolized within 1 hour of golden period. And that is proven by, this is a study by ICMR. I was the PI for that in BHU as a hub, and spokes were there in the whole Varanasi district hospital and CSCs. And we done more than 200 patients thrombolysis and saved that life. And then it is being implemented. Now it is implemented in UP as a UP STEMI project. And soon we are going for a national dissemination of this for anywhere in India. Anybody has chest pain, ECG will be done immediately when we reports to nearest center, and that will come to a specialist in a hub, and it will be reported, and they will get the benefit of advice. And if thrombolysis is required, it can be done in on time or primary PCI if available. So this is use of only that e-platform. We were using one software also, app, and also the WhatsApp group. So ultimately people found app little cumbersome. We made a simpler one. Simla is using simpler app also successfully. And we used WhatsApp group, and it's in UP state also they are using WhatsApp group.
So for the AI is also requested from the Ministry of Health. You can participate the ongoing AI projects which are going on with the Ministry of Health and with the COEs. So you can part, and you can participate. You can give the data for making the robust AI platform. So as an associate center.
If there is no question, we'll conclude this.
Thank you. Thank you
Thank
so
you.
much,
Thank you,
Dr.
Doctor.
Amit, for such
Wonderful.
a nice lecture. And continue with this session. Now I am inviting Dr. Pradeep Rangappa, and he is well-known intensivist in India, and elected as a president-elect of Indian Society of Critical Care Medicine, the largest society of critical care in India, and is currently affiliated in the Columbia Referral Hospital, Yeshwanthpur, Bangalore. So, sir, please.
Yeah. So good morning, everyone. So thanks BHU for having me here. So bring greetings from Manipal hospitals that I represent from Bangalore. So the talk that I'll be giving is what is AI in sepsis? So what is the role of AI in sepsis? So it is terribly important that intensive care is a data-rich sort of a specialty, and we deal with lot of data points. We deal with 1,000 data points per hour. So that's the sort of data we have. And this is a specialty where AI can really make a difference, and AI with telemedicine, which many speakers have spoken. So why sepsis is important? Because every 3 seconds, there is one patient dying globally out of sepsis. That's the global burden. And if you look at the number of sepsis patients worldwide, it is actually exceeded the cardiovascular death at 4.89 CR. And there is 1.1 CR deaths that are happening. And the one major burden that India we are facing is 4 million deaths that we tend to have due to antimicrobial resistance. And we all know India is at the forefront of antimicrobial resistance. And 85% of the global burden of sepsis comes from our countries, lower middle income countries, Asia and Latin America. So that is the burden of sepsis. And we need to see how we can save more lives by incorporating AI into the system. And it is a leading cause of hospital mortality. If you look at hospital deaths, most of the deaths, I think the leading death would be one of them is it would be the sepsis. So why there is a problem with sepsis? Because there are delay in the diagnosis. When they come to ICU, there has been already a significant delay that tends to happen. And there's a whole lot of clinical heterogeneity when we are trying to diagnose sepsis and treat them in a very protocolized way. There is because the heterogeneity is huge. And the patient's response. If you look at the definition of sepsis, it is life-threatening organ dysfunction due to dysregulated host response. So how the host response to an infection is very variable, and we need a lot of different sort of a information to understand how the patient responds. For that, in intensive care, we have scoring tools. We put a lot of variables to determine how the host responds to the infection, and that really determines the outcome in the sepsis. And even today, with all the advancements, the mortality in septic shock remains up to 40%. And over 10 to over at least 1 to 2 decades, things have not changed very much. So what does AI do? So AI because ICU is a data rich, we have 1,000 sort of a data points at this point of time in a complex ICU patients, and it is humanly not possible to integrate so much data in a very sort of a dynamic way. So AI tends to adopt this data, have an insight, and have a timely action plan. And machine learning sort of algorithms are put into all our monitors, which tends to do this predictive analytics and has a real-time analysis of the data, because the data in ICU is a real time and it flows second to second data, and humanly it is not possible to interpret and collate this data and make semblance. So real time interpretation and predictive analysis leads to paradigm shift in the detection, diagnosis and dynamic sort of a management. And sepsis is not a static sort of a disease, it dynamically keeps changing, and the organ dysfunction tends to keep happening in a timely way, and we need to do certain interventions in a timely way, and that's what AI helps us in. So why AI matters? Because in sepsis, there's no single biomarker and there's no single definition that defines sepsis. The clinical signs are very non-specific. I'm sure most of you would have treated sepsis. It's very non-specific. And once they have infection, it is very hard to determine who are the patients who are non-survivors and who are the patients who rapidly deteriorate into shock. So it is very difficult clinically, despite our advances, to be able to predict, and we need a lot of variables to do this prediction. And the challenges are lack of data and lack of sort of a timely intervention. So we have certain scores in ICU as intensivists we all use. So we use these SOFA scores, Q SOFA scores. These are the scores to determine who are the patients who will do well, who will not do well when they have sepsis. These are retrospectively studied. They fail to capture temporal dynamics and individual variability. So as I said, the modern ICU, we deal with 1,000 data points per hour, and this data comes from these sort of monitors. I'm sure when you enter ICU, patient is connected to a lot of gadgets, and these monitors have second to second sort of a data, and there's a lot of data from the lab that flows into ICU, the imaging, the biochemistry, hematological data, so on and so forth. We need to, the whole science of ICU is integration of the clinical variables, monitored variables, and investigative variables, and all the data that comes from all the gadgets that the patient is connected to. So this is the rich data. It's a data rich or data intense sort of a specialty. So AI helps in integrating all this data together. It does it fast, it does it in a continuous way, and there's no fatigue that tends to happen, because for humans to integrate so much data and make a logical sort of a semblance of that data is going to be difficult, and there is no sort of a fatigue when it comes to AI. And I will have to say that with so much of data, It is, and there is a lot of room for errors in sort of decision making. And as we speak, the AI algorithms are already put in some of the ICU monitors. AI algorithms are already put into the new age ventilators. Now we have closed loop ventilators where there's already AI algorithms incorporated, which they auto adjust to the breath to breath sort of a asynchrony that tends to happen. So it's already there. It's not something very futuristic. There are AI algorithms already put in these monitors, in the new age monitors, and into the ultrasound machines, that point of care machines that we use, and into the ventilators. So AI tends to simulate the human intelligence and has a sort of a predictive ability with regards to integrating all this sort of information and helps us to make clinical decisions. And of course, coupled with machine learning, it tends to analyze the large recurring data pattern with regards to ICU. There's a lot of data points, and it tends to make some sort of a sense of all the data that gets captured. So now we have spoken about the sort of a conceptual understanding. Are there data points? Are there algorithms established in ICU? Yes, there is these algorithms which are validated, which are tested, which is the ICE model, which is AI sepsis expert. It's very simple. So they basically take all the monitored variables, and for intensive care AI, we need to have EMR. We can't have pen and paper sort of information. So the key essence for future in ICU will be tele-ICU and EMR, electronic medical, because all the data gets auto-populated from the EMR and the monitors and all the gadgets patients are connected to. And this particular model has been able to predict sepsis 4 hours prior, because in sepsis, every hour counts, because we have a golden hour within which you have to do a lot of intervention. If you are able to predict the onset of sepsis 4 hours prior, we can significantly influence the outcome of sepsis patients. And the AUC was 0.85 in this particular model. Then there is the Swedish model called long short-term memory, where they have looked into 59,000 patients from Medical Information Mart of intensive care database. This is a large global database. Even BHU can access. Anyone can access this database and look at validating your own patients and your own algorithms. So here they have taken all the patient records, vital signs, and lab reports. So it is, they have not reinvented anything. It's all the data which it is integrating and making sense. And they have looked at area under curve versus Cox proportional. That was quite significant. It performed better, and it could recognize the possibility of someone developing sepsis even up to 20 hours prior. So these are already the algorithms that are tested and validated in large subgroup of patients. So this was another study from UK where they put in all the investigative variables like interleukins, tumor necrosis factors, so on and so forth, which are the predictors for, like in COVID, you would have seen we were doing CRP, we were doing interleukin 6. So they fed all these into the deep learning, and they looked at the area under curve, and that was 94.6, and accuracy was very good with high sensitivity. So these models are tried in sepsis, and they're found to be very effective in predicting the onset of sepsis and early intervention to influence outcomes. So this was another study from Taiwan where they looked at 106 variables in ICU that was captured along with organ dysfunction, and they looked at the time to diagnosis of sepsis, and the accuracy was more than 80%. So these are some of the models which are validated. Maybe perhaps in India we have tropical sepsis, we have dengue. So we need to obviously tweak and have our own algorithms or prediction models, because some of these models, we don't know how they perform to our Indian tropical patients. For bacterial sepsis, they may do well, but for tropical sepsis, we don't know. Then there is a SERA model, which is sepsis early risk assessment, which warns clinicians 2 hours in advance. And again, they have shown, this was from the Singapore study where they took all the vital signs, lab data, and medical record. And as you see, AUC was 0.94, and it performed better than your clinical and QSOFA assessment and SIRS response. So these models which are validated seems to be performing better than our conventional markers that we use, our conventional scores like Apache, SOFA, they seem to be performing better. So what about the precision management, whether AI has a role in precision management in ICU? See, we have a whole lot of fluid and vasopressor optimization that we do in our ICU. So these are some of the models they have tried, MIT, AI clinicians, so on, where they have looked at 40,000 ICU episodes, and they've shown these are useful in optimizing titration of fluid management in ICU and the use of vasopressors in ICU. And they compared it with our human interface, and they found it mirrored expert level human decision making. So these models are being validated for fluid management and is shown to improve outcome in retrospectively validated studies. So which means AI has a role. There is a lot of development that is happening, and we need to adopt this in our sort of a practice going forward. And antibiotic stewardship is extremely important in India because we are at the forefront of antimicrobial resistance. So AI sort of algorithms incorporate your resistance pattern within your ecosystem, and they integrate to your antibiogram in your microbiology, and they look into the patient's sort of a cohort and try to mitigate the antimicrobial resistance by guiding you and calibrating towards appropriate usage of antibiotics. So this is terribly important in our Indian subcontinent as to how we can utilize this to mitigate our antimicrobial, because that is leading to increase. Around 4 million deaths are happening per year due to antimicrobial resistance and sepsis. And what about hemodynamic and organ specific? So AI has shown to forecast possible hypotension. So there is a AI algorithms in the new age monitors which gives you early warning whether there is a possible hypotension that is going to set in that particular patient. And some of these have been validated in the intraoperative setting, where AI algorithms tend to auto-populate your monitored variables and predict that this patient may develop hypotension. So these are already there, and there are AI algorithms to look at possibility of developing AKI 6 hours prior. So these are the things that we want, because in ICU, every minute and every hour is important, and our whole intent is to prevent organ dysfunction, prevent hypotension, so on and so forth. So these are terribly important. And about ventilation, so the AI algorithm, there is a better care software already put in our some of the new age ventilators, which tends to optimize PEEP and weaning readiness, and these are also used for sort of a weaning as a weaning protocol. But apart from all this, there are challenges that come with AI, because the quality of data, I think many speakers have already spoken, the data that goes in is what determines the accuracy of the algorithms that you use, because garbage in, garbage out, we all know that. And there can be bias, because all these algorithms which are tested in the West not necessarily may have included our Indian cohort of patients. So we do not know how they function to our. And we have heard about black box, the type of analytics and solutions it gives. We may not be able to understand how those solutions were derived. So those are some of and the trust issues. So these are some of the challenges that we have, and whether they fit into the workflow, and that has been already spoken, and contextual relevance leading to alarm fatigue. I think we know about this. So these are some of the challenges, and the confidentiality and the data privacy. I think the ethical ambit of this is also a concern for us. So these are some of the challenges that we have in our ICU as well, and taking consent from the patients to get all the data archived for us to develop algorithms is another sort of a ethical dilemma or accountability that we have. So the real-time enablers are, it has to be patient-centric, it has to be clinically interpretable, and it has to be workflow compatible going forward. And we have to look at AI as an assistance and not to automate. As all the speakers agree that AI is not here to replace us, it can synergize our workflow and it can assist us. And the whole fulcrum of the clinical care should be a clinician, and AI should be a tool to assist rather than automate. I think that is something that we all agree upon here. So in India, what is the context in India and future vision? India, the whole beauty about India is we have huge amount of data, and how we collate it effectively to create our algorithms is what we are all here for, because our diversity is our strength. And we can have a large data to create a robust algorithm for our subgroup of patients in ICU. And the scaling of this digital data is what is important. So the way going forward is we need to have integrated network. I think the whole thing about is everyone is doing data archiving in silos. I think it's about time that we integrate all this data, and this integrated network can only happen by the digital means or telemedicine. So tele-ICU is the way where we can integrate all the data effectively across the hospitals and reach out. And NDHM, National Digital Health Mission, has already started that. I think intensive care as a custodian of critical care, I think it becomes onerous responsibility of us to partner and integrate our intensive care data so that we can have a robust algorithms for our patients and treat sepsis more effectively. I think that is the way forward. So it has to be a collaborative project where we have the data which is incorporated with metagenomics and maintain the good sort of a database for us to identify sepsis very early on, and determine our own Indian phenotypes as to how they behave to different bacterial infections, viral infections, or tropical infections, which not necessarily our Western algorithms will tell us. And we have our own pathogens, which are very unique to India. And this can happen with archiving database effectively through integrated network, which can happen only with EMR and tele-ICU way, for which I think many of us are working towards it. And this will be the future of ICU as we see it. So AI will help us in triaging, monitoring, and help us to mentoring the area of need sort of a patients, because I have partnered with my Karnataka government to do tele-ICU during our COVID, and we have mentored, we have adopted Nagaland and few other states where we have trained people, and IIT Mumbai has been partnered with the e-governance, which we are doing some work. So there is a lot of scope as to what all we can do in this sort of an area. So the conclusion is AI is not to replace an intensivist, as we know, but it is here to synergize our efforts to optimize the care and improve the outcome of sepsis patients. And it's not a reactive care, it should be predictive in nature, and it should be protocol sort of a driven sort of an approach to how we manage our ICU patients, and it has to be personalized. The key thing about ICU is it is dynamic. So we can't have a solution as a static measure, because ICU patient the sort of condition changes minute to minute, and it has to be dynamic in nature, and that is where AI would be very helpful. It has to amplify our clinical intuition and computational foresight. I think that is what AI will help us with. And as I said, it's not man versus machine, it is integrating and synergizing for timely sort of a recognition of sepsis, save more lives, and have a sepsis sort of a chain of survival. So that would be my conclusions. And in sepsis, every minute counts. But with AI, every data point can too. I think that is the message that we are left with, that every data point in ICU becomes terribly important, and that can be done effectively by AI incorporation. So thank you, friends. So thank you one and all.
Thank you, sir, for such a nice lecture. And as we know that the sepsis is an emergency as per the surviving sepsis guideline, and for any emergency condition, the time is tissue. And with the development of AI, it will help to save the time. If we save the time, then tissue will save. So as a previous speaker already mentioned that we have very less data, mainly for the emergency surgery and the critical care setup. So using use of the AI in case in the critically ill patients, what are the solution in your right?
Yeah, I think, see, as Vikram would know, that in intensive care, AI algorithms are already incorporated into some of the new ventilators we use. Because before, we used to sort of determine lot of sort of settings in the ventilator. Now we have something called closed loop ventilators. There is a sort of a weaning protocols that are already incorporated. So the human's effort hour to hour in trying to see whether the ventilator setting is up, because the clinical situation in ICU changes hour to hour. And humanly, it is not possible that a doctor keeps tweaking the ventilatory parameters or certain medications like vasopressors or fluid resuscitation cannot be done hour to hour by a doctor by clinically assessing. So these have to be auto populated, and there has to be pop-ups, and there has to be recalibration of settings on ventilator, which is already happening with our closed loop ventilators. Because when there is change in certain pressures, there are certain adjustments that happen within the ventilator. Those are all AI driven as well. And these monitors. So those monitors already give clues with regards to, suppose, a simple thing like pulse pressure variation. It's already giving a cue that this patient needs some fluids and you need to administer a fluid bolus. So these are already incorporated, but now the challenge would be to incorporate these monitored variables into all the clinical variables and investigative variables and create sort of a decision trees for us to predict the outcomes. I think prognostication and outcome. I think that is the way forward. And we are there and we are doing good. I think we need to have more Indian sort of a database and our own sort of algorithms for our cohort of patients. I think that is the challenge that we are here to address.
Thank you so much, sir. House is open for question. If there is no question, then we'll the session, complete the session, because very soon we will start the inaugural program. Thank you once again, sir, for giving your time. Thank you.
Thank you, sir, for the highly informative session. Now I would request the respected chairpersons and the speakers to move to the selfie point for the felicitation.
And with this, we conclude session 4 of today's scientific program. Shortly, we will start with the inauguration ceremony. Audiences are requested to be seated.
Thank you.
ठीक।
वो चेयर्स लेके यहाँ पे देखो, चेयर्स लेके इधर इधर चेयर्स इधर चेयर्स इधर देखो और एक टेबल इसके आगे लगाओ, पीछे से चेयर्स हटाओ, वहाँ पे चेयर्स हटाओ, चेयर्स हटाओ, चेयर्स हटाओ पीछे से यार, चेयर्स हटाओ ना तो मनीष इसमें 7 चेयर्स होनी चाहिए, एक चेयर होगी, एक चेयर होगी।
एक और
और सुविधा नहीं चाहिए ना ऊपर रख रखा है
हेलो हेलो। हाँ हाँ ठीक है
ठीक है और क्या चाहिए
शशि बॉस एक बार आगे से चेक
मेरे पास
पानी
से जो रहेगा बेटे हाँ मैं रहूंगा तो मैं आप कर रहे हो
एक लाइन इसको नेम प्ले कार्ड
लाइन में लगवा के उससे बोल
टेबल के एज पे और एकदम लाइन में ये नेम प्ले कार्ड और ये सभी एक सीरीज में एक लाइन में रखा जस्ट ऑन द वर्ज ऑफ टेबल। ठीक है बेटा तुम इसको लाने के लिए ऑर्डर लगा दो टुवर्ड्स द एंड ऑफ द टेबल है ना बस बॉटल इसके जस्ट बगल बॉटल इसके जस्ट जैसे को बोला पता नहीं बाहर ही तो गए थे कोई बात नहीं बहुत आप पाँच सेकेंड तक कुछ करिएगा और बहुत करते बहुत करते वो भी बाहर ही है आप ठीक है
गंगा तरंग रमणीय जटा कलापम गौरी निरंतर विभूषित वाम भागम नारायण प्रियमलंग मदापहारम वाराणसी पुरपतिम भज विश्वनाथम। सम्मानित अतिथिगण और यहाँ पर उपस्थित सभी देवियों और सज्जनों, महाशिवरात्रि के इस पावन पर्व पर आज हम इस राष्ट्रीय अधिवेशन जो कि एआई इन हेल्थ केयर पर आधारित है, इसके आयोजन के सम्मेलन में आप सबका हार्दिक स्वागत और अभिनंदन करते हैं। ये नगरी बाबा विश्वनाथ की नगरी है और हम उनके आशीर्वाद से अपने सारे काम शुरू करते हैं। हम सब बाबा विश्वनाथ को नमन करते हैं। मैं आप सबको याद दिला देना चाहता हूँ कि ये विश्वविद्यालय परिसर हमारे संस्थापक महामना पंडित मदन मोहन मालवीय जी की प्रेरणा का एक अनुपम उदाहरण है। हम अपने संस्थापक को नमन करते हैं। हम मंचासीन अतिथि को हार्दिक स्वागत करते हैं। हमारे साथ हमारा परम सौभाग्य है कि आज हमारे बीच मुख्य अतिथि के तौर पे माननीय श्रीमती अनुप्रिया पटेल जी हैं, जो भारत सरकार में स्वास्थ्य एवं परिवार कल्याण तथा रसायन और उर्वरक विभाग की राज्य मंत्री हैं तथा हमेशा एक अभिभावक के तौर पर इस विश्वविद्यालय परिवार के साथ खड़ी रहती हैं। मैडम, आपको सादर प्रणाम है। हमारा सौभाग्य है कि आज हमारे साथ माननीय श्री दयाशंकर मिश्र जी उपलब्ध हैं, जो कि उत्तर प्रदेश सरकार में आयुष, खाद्य सुरक्षा और औषधि प्रशासन में स्वतंत्र प्रभार के मंत्री हैं और जिन्हें काशी में प्रेम से दयालु गुरु कहा जाता है। आपका स्वागत है सर, आपको प्रणाम सर। हमारे साथ मंचासीन हमारे संरक्षक, हमारे कुलपति महोदय हैं प्रोफेसर अजीत कुमार चतुर्वेदी सर, जिनकी सरल कार्यशैली हम सबको प्रभावित करती है। सर, आपका स्वागत, आपको प्रणाम सर। हम आभारी हैं, हमारे साथ मंचासीन भारत सरकार की ई हेल्थ की निदेशक श्रीमती रीना दास मैडम मंचासीन हैं। मैडम लगातार हमारे साथ जुड़ी हुई हैं और कल से ही हमारे साथ यहाँ उपलब्ध हैं और हमारा मार्गदर्शन कर रही हैं। आपको प्रणाम मैडम। हमारे साथ मंचासीन हमारे निदेशक महोदय हैं, जो सहज रूप से हमेशा हमारे लिए उपलब्ध रहते हैं, प्रोफेसर SN संखवार सर, हम आपको प्रणाम करते हैं सर। इस अधिवेशन की वैज्ञानिक समिति के अध्यक्ष डॉक्टर अमित द्विवेदी सर, जो कि रेडियोलॉजी विभाग के विभागाध्यक्ष भी हैं, आप भी मंचासीन हैं, आपको भी प्रणाम सर। और इस अधिवेशन की धुरी इसके आयोजन सचिव डॉक्टर नीलेश सर सबसे किनारे बैठे हुए हैं, आपको प्रणाम। हमारे विश्वविद्यालय की परंपरा के अनुसार हम सभी मंचासीन अतिथियों से अब अनुरोध करते हैं कि वो हमारे संस्थापक की प्रतिमा पर माल्यार्पण करें और इस ज्ञान दीपक को प्रज्वलित करके इस सभागार में ज्ञान का के दीपक को जलाएं।
शुभम पुरुषोत्तम कल्याणम आरोग्यम धनसंपदा शत्रुबुद्धि विनाशाय दीपं ज्योतिर्नमोस्तुते दीपं ज्योतिर्नमोस्तुते शुभम पुरुषोत्तम कल्याणम आरोग्यम धनसंपदा ज्योतिर्ब्रह्मा दीप ज्योतिर्जनार्दनः दीप ज्योतिर्भरतः दीप ज्योतिर्जनार्दनः जादीपनमोऽस्तुते शुभं पुरुषं कल्याणम् आरोग्यं धनसंपदः शुभं पुरुषं कल्याणम् आरोग्यं धनसंपदा दीप ब्रह्म सुप्रस्थ ज्योतिषां प्रभुः ओ दीप ब्रह्म सुप्रस्थ ज्योतिषां प्रभुः राजपतिं स्वच्छामि शुभं पुरुषं कल्याणम् आरोग्यं
आप सभी मंचासीन अतिथियों का सहृदय धन्यवाद। हमारे विश्वविद्यालय परंपरा के अनुसार अब हम अपने कुल गीत की प्रस्तुति करेंगे। हम अपने विश्वविद्यालय की छात्राओं से अनुरोध करेंगे कि वो कुल गीत की प्रस्तुति करें। हमारा कुल गीत डॉक्टर शांति स्वरूप भटनागर द्वारा रचित है और हम आपसे अनुरोध करते हैं कि कुल गीत के बाद कृपया ताली न बजाएं।
कैसे करें?
एक मिनट
राजेधानी राजेधानी ये तीनों से न्यारी आश सो ज्ञान धर्म और सत्य राशि बसी है गंगा के तट पर ये सर्व विद्या के राजधानी राजधानी ये नहीं है ये पत्थर है विश्व निर्माण का कार्य रचे ये सर्वश्रेष्ठ के राजधानी राजधानी यहाँ की है के हरीश ये सत्य शेषा तेरा तेरानी राजधानी वेद ईश्वर की सत्यवाणी पढ़ी जिन्हें पढ़ेगी ब्रह्म ज्ञानी थे व्यास जी रचे नहीं पर ये ब्रह्म विद्या के राजधानी राज तेरा दीवार सुधा यही भले शंकर ये राज्य ऋषि सुरम धारा वरुणासी कहाँ जिन पे कबीर तुलसी भला हो कबीरा क्यों करात ये वाग विद्या के राजधानी राजधानी कला अनिथ शास्त्री आई ये विश्व विद्या राजधानी राजधानी ये बात ये देश भक्ति ये ये बात ये देश भक्ति ये ये सर्व तेरा
आप सभी का धन्यवाद। अब हम अपने मंचासीन अतिथियों का स्वागत पुष्पगुच्छ देकर करेंगे। सबसे पहले हम अपने कुलपति महोदय से निवेदन करेंगे कि हमारी मुख्य अतिथि माननीय अनुप्रिया पटेल मैडम का स्वागत पुष्पगुच्छ देकर करें। हम निदेशक महोदय से अनुरोध करेंगे कि वो हमारे सम्मानीय अतिथि माननीय श्री दयाशंकर मिश्र जी का स्वागत पुष्पगुच्छ देकर करें। निदेशक महोदय से पुनः अनुरोध है कि आप कुलपति महोदय का पुष्पगुच्छ देकर स्वागत करें। डॉक्टर अमित द्विवेदी सर से अनुरोध है कि वो रीना मैडम का पुष्पगुच्छ देकर स्वागत करें। अब नीलेश सर से अनुरोध है कि आप डॉक्टर अमित द्विवेदी सर का स्वागत पुष्पगुच्छ देकर करें। भूल के लिए क्षमा। नीलेश सर से अनुरोध है हमारे निदेशक महोदय का स्वागत करें। डॉक्टर साक्षी जी से अनुरोध है कि वो डॉक्टर नीलेश सर का स्वागत करें। इस अधिवेशन के आयोजन अध्यक्ष के रूप में और संस्थान के निदेशक के तौर पे हमारे निदेशक महोदय डॉक्टर एस एन संखवार सर से अनुरोध है कि अब वो अपना स्वागत उद्बोधन प्रस्तुत करें।
धन्यवाद डॉक्टर शशि। सभी लोगों को मेरा शुभ अपराह्न। आज इस अवसर पर हमारे परम आदरणीय मुख्य अतिथि डॉक्टर अनुप्रिया पटेल जी, जो कि हमारे मंत्री है स्वास्थ्य विभाग एवं रसायन की, मैं मैम का स्वागत करता हूं। और विशिष्ट अतिथि जन मंचासीन हमारे परम आदरणीय कुलपति जी, ई हेल्थ की मैम डॉक्टर रीना आशीष जी, डॉक्टर अमित नंदन धर द्विवेदी, हमारे कार्यक्रम के जो संयोजक हैं डॉक्टर नीलेश और डॉक्टर दयालु सर, जो हमेशा मरीजों के प्रति यहाँ पर सहायता हेतु तत्पर रहते हैं। सभी लोगों का मैं हार्दिक अभिनंदन और वंदन करता हूँ। साथ में हमारे सारे सहकर्मी, देश विदेश से पधारे विभिन्न चिकित्सकगण, स्वास्थ्य कर्मी, शिक्षाविदों और तकनीकी विशेषज्ञ, साथ में मीडिया प्रभारियों का ढेर सा स्वागत और अभिनंदन करता हूँ। सबसे पहले तो मैं इस मंच से हमारी मुख्य अतिथि भारत सरकार की माननीय केंद्रीय स्वास्थ्य मंत्री श्रीमती अनुप्रिया पटेल जी का हृदय से स्वागत करता हूं। माननीय मंत्री जी का संपूर्ण सार्वजनिक जीवन समावेशी स्वास्थ्य सेवा, जन कल्याण और डिजिटल नवाचार को समर्पित रहा है। आपका यह विश्वास की तकनीक को मानवता के साथ जोड़ा जाए आज के इस सम्मेलन की आत्मा है। आपकी उपस्थिति मैडम हमारे लिए बहुत ही प्रेरणादायक है। और मैम, हम आपको बताना चाहेंगे कि हमारा IMS लगातार अच्छे कार्य करने के लिए जुटा पड़ा है और जब से माननीय कुलपति जी आए तब से उसमें बहुत गति मिली है। हमारे हर एक कार्यक्रम में हमारे माननीय कुलपति जी होते हैं और सबको उत्साहवर्धन करते हैं। अभी आम जनता के लिए सर ने पब्लिक लेक्चर शुरू कराया, जो आम बीमारियां होती हैं, जनता को जानकारी हो और जनता उसे लाभ पाए और बीमारी ना हो, उससे संबंधित सर ने एक पब्लिक लेक्चर शुरू कराया है अभी। हाँ जी मैम, उस पर भी हम लोग एक दुरुपयोग होता है, मैम उस पर भी आगे चर्चा करने जा रहे हैं। और हमारे IMS की 6th रैंक है NIRF में। और मैम जितने नए एम्स हैं उनकी तो बहुत ऊपर 15 से ऊपर है। हमारा IMS मेहनत से कार्य कर रहा है, बस कुछ मैम इंफ्रास्ट्रक्चर्स और कुछ चीज़ों में कमी है। मैं स्वागत के साथ अनुरोध भी करूंगा कि हमारे IMS पे कुछ दया दृष्टि दिखा करके हमारा इंफ्रास्ट्रक्चर, मैन पावर, सैलरी का भी कुछ बढ़ोतरी हो। हमारे जो शिक्षकगण कार्य कर रहे हो और मेहनत से करें। हम वादा करते हैं कि हम अपने IMS को खूब उच्च स्थान पर ले जाना चाहेंगे, एम्स दिल्ली की तरह। धन्यवाद मैम, आप आए हम लोगों को आशीर्वाद देने के लिए। मैं माननीय श्री दयाशंकर मिश्र दयालु जी, जो हमारे उत्तर प्रदेश सरकार के आयुष मंत्री हैं, का भी सादर अभिनंदन करता हूं। आपका स्नेह, आपका अनुभव और जन सेवा के प्रति आपकी प्रतिबद्धता इस मंच को विशेष गरिमा देती है। सर मरीजों के लिए बहुत प्रतिबद्ध है। रात के 1 बजे 2 बजे अगर सर के द्वार कोई पहुंचा है तो सर हमेशा उसकी सहायता करते हैं और कई बार तो आ भी जाते हैं। सर मैं आपका बहुत बहुत स्वागत करता हूं। धन्यवाद सर। मैं अपने माननीय कुलपति जी, जो इस विश्वविद्यालय के मुखिया हैं श्री अजीत कुमार चतुर्वेदी जी का विशेष रूप से अभिनंदन करता हूं। आदरणीय कुलपति महोदय के दूरदर्शी नेतृत्व में बीएचयू ने शिक्षा और अनुसंधान के साथ साथ स्वास्थ्य सेवा के उन्नयन में भी राष्ट्रीय स्तर पर अपनी पहचान बनाई है और पहचान और सुदृढ़ हुई है। IMS BHU को भविष्य के लिए तैयार करने की आपकी सोच हम सभी के लिए प्रेरणा स्रोत है। सर, आपका सर बहुत बहुत स्वागत और धन्यवाद। मैं इस अवसर पर स्वास्थ्य एवं परिवार कल्याण के हेल्थ विभाग के हमारे माननीय ज्वाइंट सेक्रेटरी श्री मधुकर कुमार भगत जी का भी हार्दिक आभार व्यक्त करता हूं। सर, आज नहीं आ पाए, लेकिन लगातार उनका सहयोग रहता है, जिनके सतत मार्गदर्शन, प्रेरक नेतृत्व एवं निरंतर टेली मेडिसिन तथा डिजिटल स्वास्थ्य सेवाओं को सुदृढ़ करने की दिशा में उल्लेखनीय प्रगति संभव हो सकी है। मैं आदरणीय सुश्री रीना आशीष जी, निदेशक स्वास्थ्य एवं परिवार कल्याण मंत्रालय, भारत सरकार का हार्दिक स्वागत करता हूं। आपकी नीति स्तरीय समझ और प्रशासनिक अनुभव यह सुनिश्चित करता है कि एकेडमिक विचार विमर्श हेतु स्वास्थ्य प्राथमिकताओं से जुड़ा रहे और इसका जमीन पर प्रभाव डाले, जनमानस को लाभ हो। मैम, आपका बहुत बहुत स्वागत, धन्यवाद। इस मंच से मैं अपने प्रिय सहयोगी डॉक्टर संजय गुप्ता, डीन फैकल्टी ऑफ मेडिसिन तथा आयोजन समिति के सभी सदस्यों का अभिनंदन करता हूं, जो लगातार इतनी मेहनत करते रहे कि इतनी कार्यक्रम सफल हुई। मैं जब भी मीटिंग करता था, देखता था सभी सदस्य उपलब्ध होते थे। ऐसा लगता था ये वार्ड में भी काम कर रहे हैं, डिपार्टमेंट में काम कर रहे हैं, यहाँ भी इन्होंने AI से कोई क्लोन तो नहीं बना लिया अपना। बहुत मेहनत करी सभी लोगों ने और मैं सभी को बहुत बहुत बधाई देता हूँ, धन्यवाद देता हूँ। आज जब हम AI फॉर विकसित भारत की बात करते हैं तो हमारा लक्ष्य केवल स्मार्ट एल्गोरिदम नहीं, बल्कि सुलभ, किफायती, गुणवत्तापूर्वक और अंतिम व्यक्ति तक पहुंचने वाली स्वास्थ्य सेवाएं हैं। IMS BHU की दृष्टि सदैव उत्कृष्ट स्वास्थ्य सेवा, गुणवत्तापूर्ण शिक्षा और प्रासंगिक अनुसंधान पर केंद्रित रही है। आज का यह सम्मेलन उसी दृष्टि का विस्तार है, जहां चिकित्सा और तकनीक मिलकर भविष्य का स्वास्थ्य तंत्र गढ़ रहे हैं। हमें गर्व है कि रीजनल रिसोर्स सेंटर ईस्टर्न रीजन IMS BHU, जो कि स्वास्थ्य एवं परिवार कल्याण मंत्रालय की एक इकाई है, उत्तर प्रदेश, बिहार, झारखंड, पश्चिम बंगाल और अंडमान निकोबार जैसे राज्यों में टेलीमेडिसिन और डिजिटल स्वास्थ्य सेवाओं के माध्यम से अंतिम छोर तक सेवा पहुंचा रहा है। यह सम्मेलन उसी यात्रा में एक निर्णायक कदम है, जहां हम AI आधारित स्वास्थ्य क्रांति की ओर बढ़ रहे हैं। मैं इस अवसर पर सभी प्रतिनिधियों, वक्ताओं, शोधार्थियों, मीडिया प्रतिनिधियों, तकनीकी टीम, सहयोगी स्टाफ और स्वयं सेवकों को भी हृदय से स्वागत करता हूं। आप सभी की उपस्थिति इस सम्मेलन को जीवंत बनाती है। अंत में यह कहना चाहूंगा कि तकनीक तभी सार्थक है जब वह करुणा के साथ जुड़ी हो और ज्ञान तभी पूर्ण है जब वो समाज के अंतिम व्यक्ति तक पहुंचे। इसी विश्वास और संकल्प के साथ मैं पुनः सभी माननीय अतिथियों, विशिष्ट जनों, सभी संकाय सदस्यों, शिक्षकों, छात्रगण और प्रतिभागियों का हार्दिक धन्यवाद एवं अभिनंदन करता हूं। आइए हम सब मिलकर एक ऐसे स्वास्थ्य भविष्य का निर्माण करें जो बुद्धिमान भी हो, मानवीय भी हो और समावेशी भी हो। जय हिंद, भारत माता की जय।
बहुत बहुत धन्यवाद सर। हमारे साथ मंचासीन हमारे कुलपति महोदय हैं, जिनकी सहज कार्यशैली और सरल स्वभाव सभी को प्रभावित करता है। मैं चाहता हूं कि विश्वविद्यालय के मुखिया के नाते आप यहाँ पर उपस्थित सभी विशिष्ट जनों और सभी सदस्यों का स्वागत करें। प्लीज सर।
आज बहुत हर्ष का विषय है कि हमारे IMS में एक नेशनल कॉन्फ्रेंस ऑन AI इन हेल्थ केयर एंड एजुकेशन ऑर्गेनाइज हो रही है और उसके इनॉग्रल फंक्शन में 2 माननीय मंत्री उपस्थित हैं, माननीय अनुप्रिया पटेल जी तथा माननीय दयालु शंकर मिश्र जी। दोनों का बहुत बहुत हार्दिक अभिवादन एवं स्वागत। आज का जो टॉपिक है वो टॉपिक बहुत ही समसामयिक है, लेकिन मैं एक बात आज कहना चाहता हूं कि जितना एडवांसमेंट AI इन हेल्थ केयर हो चुका है कि अब हम लोगों को BHU में इसको अडॉप्ट करने की तरफ ध्यान देना है। रिसर्च और एजुकेशन तो जारी रहेगा और इस तरह की कॉन्फ्रेंसेस भी जारी रहेंगी। ये कोई पहली बार ऐसा मौका नहीं है जब हम लोग इस तरह की चर्चा कर रहे हैं, लेकिन अब हम इस पे ध्यान दें कि हम अपने हेल्थ केयर में प्रत्यक्ष रूप से डायरेक्टली क्लिनिक तक कहाँ-कहाँ पे एआई अडॉप्ट कर सकते हैं। इसके लिए हम चाहेंगे कि एक टास्क फोर्स बने। अगले हफ्ते 10 दिन के अंदर हम लोग एक हॉस्पिटल के अंदर एक टास्क फोर्स बना लें जो सेफगार्ड करे कि क्या सेफगार्ड्स चाहिए, क्योंकि इसमें हम कोई भी टेक्नोलॉजी जब अडॉप्ट करते हैं तो उसमें कई सारी रेगुलेटरी रिक्वायरमेंट्स होती हैं। तो कोई रेगुलेटरी रिक्वायरमेंट वायलेट नहीं होनी चाहिए, लेकिन एट द सेम टाइम जब कोई नई टेक्नोलॉजी आती है तो आप सडनली उसको नहीं सीख सकते हैं। तो वी आर एट द कंट्री लेवल, आई फील दैट वी आर ऑलरेडी अ बिट लेट इन दैट, इन द एडॉप्शन पार्ट। तो कॉन्फ्रेंसेस करने का फायदा तभी है जब उन कॉन्फ्रेंसेस को हम अपने जीवन में अवतरित कराएं, उस पे उससे सीखें और उसको अपने डेली प्रैक्टिस में इनकॉर्पोरेट करें। तो आज की कॉन्फ्रेंस से हम लोग ये एक तरह से जिसे कहते हैं एक हम लोग विश्वास या हम लोग एक निर्णय ले सकते हैं कि हम एडॉप्शन की तरफ इसको बहुत एक्टिवली प्रोसीड करेंगे। जैसा कि सबको विदित है, हमारे विश्वविद्यालय में रीजनल सेंटर है टेलीमेडिसिन का, रीजनल रिसोर्स सेंटर है, और ये टेलीमेडिसिन का सेंटर और एआई ये दोनों मिलकर जो है बहुत काफ़ी कुछ पहुंचा सकते हैं समाज के हर दूर दराज क्षेत्रों तक। हम क्लिनिकल सुविधा पहुंचा सकते हैं। चूंकि आज हमारे बीच बहुत गणमान्य व्यक्ति मौजूद हैं, श्रीमती अनुप्रिया पटेल जी मौजूद हैं जो कि भारत सरकार की स्वास्थ्य मंत्री हैं, तो मैं ये कहूँगा कि हम लोग की कुछ जो प्रपोजल्स हैं जो एडवांस स्टेज में हैं, हम आपसे रिक्वेस्ट करेंगे कि उन प्रपोजल्स को आगे बढ़ाएं। अब जो एक मेन प्रपोजल है आईएमएस बीएचयू का, वो है एम्स लाइक स्ट्रक्चर। तो एम्स लाइक स्ट्रक्चर का जो काफ़ी एक एडवांस प्रपोजल चल रहा है, हम लोगों को उम्मीद है कि भारत सरकार उस पर ध्यान देगी, और हम मैडम से रिक्वेस्ट करते हैं कि उसमें हम लोगों को अगर कुछ और कार्य करना है तो हम लोगों को दिशा निर्देश दें, जिससे कि जल्दी से सपना साकार हो सके और हमारे आईएमएस की जो पोटेंशियल है, पूरी पोटेंशियल वो रियलाइज हो सके। ये बात सच है कि कभी-कभी जब आप एक बहुत बड़े अस्पताल को चलाते हैं, तो कहीं आपसे जितने अच्छे गुणवत्ता के साथ हर मरीज का इलाज होना चाहिए, कहीं-कहीं हम शायद कहीं-कहीं हम चूक जाते हैं। लेकिन इसका ये मतलब नहीं कि हम उससे ना सीखें, हम उससे कोई भी मरीज हमारे लिए नॉन वीआईपी नहीं है, हर मरीज हमारे लिए वीआईपी होना चाहिए। ज़रूरी नहीं कि उसके लिए कोई कहे तभी हम उसके पे ज़्यादा ध्यान दें, चाहे ना कहे, चाहे कहे, जिसका भी हो, सब मरीजों पे हमें बराबर ध्यान देना है। हेल्थ केयर के क्षेत्र में हमको ऐसा एक मानक स्थापित करना है अपने क्षेत्र में, जो कि बाकी दूर-दराज क्षेत्रों में, बाकी भारतवर्ष के अन्य क्षेत्रों में भी उसकी चर्चा शुरू हो सके। और ये बिल्कुल संभव है, क्योंकि हम लोग एक यूनिवर्सिटी सिस्टम में हैं, हम लोग एक एकेडमिक सिस्टम में हैं, और एकेडमिक सिस्टम में चूँकि रिसर्च का फ़ोकस होता है, तो बहुत ज़्यादा कमर्शियलाइज़ेशन नहीं होता है। तो इसलिए जो है हमारे इंटेंशंस, हमारी जो इच्छा शक्ति है और जो हमारी विज़न है, वो सब अलाइन होकर इस तरह से काम कर सकती है कि हम एक बहुत टॉप क्वालिटी का हेल्थ केयर दें, जो कि एक मानक बने। और इस टॉप क्वालिटी हेल्थ केयर में तभी रियलाइजेशन होगा जब हम एडिक्वेट लेवल पे टेक्नोलॉजी का इन्फ्यूजन करें। स्केल अप नहीं होगा, क्योंकि डॉक्टर्स उतने ही, मरीज ज़्यादा हैं। तो स्केल अप करना है तो टेक्नोलॉजी में जैसे ई हेल्थ है, या जो टेलीमेडिसिन है, या जो एआई है, ये सब बहुत ज़्यादा हेल्प करेंगे। तो इसीलिए मुझे लगता है ये बिल्कुल बहुत सही कॉन्फ्रेंस, अच्छी कॉन्फ्रेंस है, सही समय पे हो रही है। लेकिन इस कॉन्फ्रेंस से हम लोगों को प्रेरणा लेनी चाहिए कि हम जो है कॉन्फ्रेंस में केवल एकेडमिक डिस्कशंस नहीं करेंगे, इसको हम ट्रांसलेट करेंगे रियल एक्शन ऑन द ग्राउंड में। इन्हीं शब्दों के साथ मैं आप सबको, जो बाहर से लोग आए हैं, उन सबका भी स्वागत करता हूँ और उम्मीद करता हूँ कि सबको इस कॉन्फ्रेंस से कुछ सीख के जाएंगे और अपने-अपने अस्पताल में कुछ अच्छा कर पाएंगे। धन्यवाद।
बहुत-बहुत धन्यवाद सर। आज इस आयोजन में हमारे साथ सम्मानित अतिथि के तौर पर माननीय श्री दयाशंकर मिश्र जी उपलब्ध हैं। सर, हम आपका आशीर्वचन लेना चाहेंगे। कृपया अपना आशीर्वचन दें सर।
सबसे पहले तो आप सभी को, चूंकि बाबा विश्वनाथ की नगरी है, भूत भावन भगवान शंकर की इस नगरी में आप सभी महाशिवरात्रि के दिन आए हैं, तो संपूर्ण सभागार को और मंच को आज महाशिवरात्रि की ढेर सारी बधाई और शुभकामना देता हूं। नेशनल कॉन्फ्रेंस ऑन आर्टिफिशियल इंटेलिजेंस इन हेल्थ एंड एजुकेशन कार्यक्रम में मंच पर उपस्थित हम सबकी बहुत ही काशी की बेटी के तौर पे ही हम सब लोग इनको मानते हैं। मिर्जापुर इनकी कर्मस्थली है। हमारी बहुत अग्रज मुख्य अतिथि श्रीमती अनुप्रिया पटेल जी, माननीय मंत्री स्वास्थ्य एवं परिवार कल्याण, रसायन तथा उर्वरक मंत्रालय, भारत सरकार, परमादरणीय कुलपति काशी हिंदू विश्वविद्यालय प्रोफेसर अजीत कुमार चतुर्वेदी जी, निदेशक स्वास्थ्य एवं परिवार कल्याण श्रीमती रीना आशीष जी, निदेशक IMS BHU डॉक्टर SN संखवार जी, डिप्टी चिकित्सा अधीक्षक प्रोफेसर नीलेश कुमार जी, साइंटिफिक चेयरमैन डॉक्टर अमित नंदन द्विवेदी जी, साइंटिफिक सेक्रेटरी डॉक्टर विक्रम गुप्ता जी, कोऑर्डिनेटर टेलीमेडिसिन एवं प्रोग्राम कन्वीनर अमित मिश्र जी, मंच का संचालन करें डॉक्टर शशि प्रकाश मिश्र जी एवं डॉक्टर साक्षी अग्रवाल जी। सभागार में इस देश के ही नहीं, दुनिया के और भी देशों से लोग आए हुए हैं, तो आप सभी का स्वागत, अभिनंदन और वंदन है। आज का दिन बहुत पवित्र है और भगवान शिव की नगरी में आज आप एक ऐसे आधुनिकतम विषय पर, वो भी चिकित्सा केयर, हेल्थ केयर के क्षेत्र में, एजुकेशन के क्षेत्र में, आप एक ऐसी विधा का उपयोग करके आप इसको कितना अच्छा बना सकते हैं, आज उसी पर आज ये संगोष्ठी है। निश्चित ही आज के इस संगोष्ठी के बाद इस BHU हॉस्पिटल को बहुत कुछ मिलेगा। अस्पताल तो बहुत होते हैं, लेकिन मेरी नजर में, जो कि 10 साल यहीं रह के पढ़ा हूँ, हॉस्टल में रह के पढ़ा हूँ, जाने के बाद भी यहाँ से नाता टूटा नहीं, और वो रिश्ते की डोर का कारण था अस्पताल। आज भी खुद भी मंत्री हो गया हूँ आयुष का, लेकिन यकीन करिए कि अभी भी विश्वविद्यालय में अस्पताल को उतने ही संजीदगी से, उतनी ही गहराई से जीना पड़ता है। उसका कारण यह है कि न जाने कितने बड़े हिस्से को ये अस्पताल जिंदगी देता है। हमको आपको लगता है कि बनारस में है तो 2, 4, 10 जिले का इसकी सीमा होगी, लेकिन यकीन करिए कि न जाने बिहार के कितने जिले, मध्य प्रदेश के कितने जिले, झारखंड के कितने जिले, छत्तीसगढ़ के कितने जिले, सबके लिए जीवन का एक बड़ा स्रोत कह लीजिए, एक बड़ी रोशनी उनको मिलती है इस अस्पताल से। यहाँ जितना भी कर दिया जाए वो कम है। किसी विधा का उपयोग कर लीजिए और ओवर सैचुरेशन है। इतनी भीड़ आपको किसी अस्पताल में कहीं नहीं दिखेगी। आप चाहे PGI चले जाइए, चाहे मैं लखनऊ, चूंकि सारे अस्पतालों से भी वहां भी काम पड़ता है, वहां भी राम मनोहर लोहिया, किंग जॉर्ज और PGI, लेकिन BHU जैसी भीड़, तो यहाँ तो शायद और भी जरूरत हो आपको AI की। कैसे मैनेज हो, कैसे सब कुछ आप सेवा भी कर सके और आपके स्तर, आपका जो, जैसे अभी एम्स की बात हम लोग न जाने कब से ये सपना पाल के बैठे हैं। हमारी मंत्री जी मंच पर है, तो मुझको लगता है कि आज लौट के जाएंगी, तो निश्चित ही हम सब की बातों को बड़ी गंभीरता से लेते हुए इस पे जितना जल्दी हो सके, मैंने आपसे कहा बहुत अस्पताल है, बहुत अस्पताल है, लेकिन किसी अस्पताल की एक एक डॉक्टर की OPD की संख्या, कभी आप मंगा के यहाँ का डाटा देखिएगा, मुझको लगता है कि AI में सबसे ज्यादा डिजिटल डाटा का उपयोग होता है। और काशी हिंदू विश्वविद्यालय के इस सरसुंदर लाल चिकित्सालय का कोई डाटा मंगा के देख ले, कितने मरीजों का इलाज हो रहा है, कितनी OPD है, बैठने की जगह नहीं, तिल रखने की जगह नहीं। और मैं अपनी अनुप्रिया जी को बताना चाहता हूँ कि ये आयुर्वेद का अस्पताल शुरू हुआ 1922 में। पंडित मदन मोहन मालवीय जी ने जब चिकित्सा की के लिए सोचा, तो आयुर्वेद का अस्पताल बना। आज भी हमारी पुरानी इमारत जो है वो आयुर्वेद की बिल्डिंग है इस अस्पताल की। एक्सटेंशन हुआ, फिर एलोपैथ आया, फिर न जाने कितनी चीजें ऐड होती चली गई, विस्तार दिन पर दिन। हिंदुस्तान का सबसे बड़ा ट्रॉमा सेंटर 326 बेड का, बगल में महामना कैंसर इंस्टीट्यूट। महामना जाइए तो लगता है कि अब यहाँ जगह नहीं बची तिल रखने की, इतना दबाव इस क्षेत्र पर है। तो ऐसे में हम सबकी जिम्मेदारियां बहुत बड़ी हो जाती हैं कि कैसे पूर्वांचल, कहने को आप समझ सकते हैं कि ये बहुत ही पिछड़ा क्षेत्र, अतीत का बहुत पिछड़ा क्षेत्र था, बिहार के सटा हुआ। तो वहाँ के लोगों के लिए भी आप देखते होंगे सवेरे यहाँ न जाने कितनी गाड़ियां रातों रात यहाँ आ जाती हैं, फिर सुबह सब लोग नंबर लगा लेना, फिर विभाग में रजिस्ट्रेशन करा लेना, एक संघर्ष होता है। एक हजार 1,500 की ओपीडी एक डॉक्टर्स के पास है। तो ऐसे में बहुत संघर्ष है। ये चीजें कितनी सहज और सरल हो और मानवीय संवेदनाएं कम होती जा रही हैं, ये हम लोग महसूस करते हैं। एक डॉक्टर अगर दिन भर न जाने, उसकी सीमाएं, उसकी भी एक सीमा है, सीमाओं के परे लोगों को देख लेना, लोगों को भर्ती कर लेना। अब मेरा शहर छो के उठता है तो मुझसे कहता है कि अरे बेड नहीं मिला। मैं उससे कहता हूँ कि आप जब सो के उठते हैं बनारस के लोग, तब तक बिहार के लोग आके आपकी सीट ले लेते हैं। सीट का मतलब बर्थ। वो पूछता है कैसे? मैं कहता हूँ कि वो रात के अंधेरे में आ जाते हैं, भोर में वो आके लाइन लगा लेते हैं, हाथ में दतुअन लिए रहते हैं, और 2, 3, 4, 5, 10 तक अगर उनको नंबर मिल गया, फिर वो सबसे पहले डॉक्टर के सामने चले जाते हैं। डॉक्टर के पास 3 बेड खाली है उसके वार्ड में। अब एक मरीज सामने आया जो बहुत सीरियस है, किसी डॉक्टर को इस बात से कोई मायने नहीं कि वो जहानाबाद का है, कि वो रॉबर्ट्सगंज का है, कहाँ का है, गॉड नोज। वो उसको तो देखता है कि एक मरीज मेरे सामने आया है। मेरा शहर जब यहाँ आता है तो 12 बजे पहुंचता है अस्पताल, तो कहता है कि अरे 926 नंबर का पुर्जा बना है मेरा। तो पहली सिफारिश उसकी। मैं आपको इसलिए बता रहा हूँ कि रोज जीना पड़ता है। कुलपति महोदय भी, इनसे मेरा पहला वास्ता पड़ा। मेरे बेटे को ये अवार्ड दे रहे थे, मेरा बेटा एमटेक करके आईआईटी रुड़की में। तो जब मनी जी से मेरी पहली मुलाकात हुई तो मैंने बताया कि वो दिन और आज का दिन लगता है कि अब मैं रुड़की आया था और आप काशी आए हैं। तो एक बड़ा अच्छा संजोग है और आपके अंदर बहुत काम करने का जुनून है, बहुत क्षमता है आपके अंदर। तो विश्वविद्यालय को और इस हॉस्पिटल को मैं बार-बार अनुप्रिया जी से कह रहा हूँ, इसीलिए बात को दोहरा रहा हूँ कि इस अस्पताल जैसा दबाव वाला दुनिया में कोई अस्पताल नहीं होगा। ये मैं बड़े दावे से आपसे कह सकता हूँ। तो आपको जो भी सोचना है, जितना सोचना है, आप जितना दे देंगी इसकी झोली कभी भरेगी नहीं। संसाधनों के मामले में जितना भी आप प्रोवाइड कर दीजिए, सुविधाएं दे दीजिए, चूंकि मैंने कहा ना, इंडलेस है। तो आज आप यहाँ आई हैं तो निश्चित ही आज हम सबको आपसे बहुत कुछ मिलेगा। और इस विधा का उपयोग करके मैं विश्वविद्यालय के अपने तमाम डॉक्टर से कहता हूँ, मैंने कुछ पीढ़ियों को यहाँ से गुजरते देखा है। अतीत के लोग इतने, आजकल के लोग थोड़ा सा इरिटेट बहुत जल्दी हो जाते हैं, भीड़ देख लेते हैं तो विचलित हो जाते हैं। कुछ लोग ऐसे आ जाए सामने जिनका व्यवहार अच्छा ना हो तो विचलित हो जाते हैं। तो आप सबको बस एक सलाह है मेरी कि एआई का उपयोग करते रहिए। सुविधाएं होंगी, सहजता होगी, सरलता होगी आपको काम करने में, लेकिन काम आपको करना है मानवीय मूल्यों के साथ, सहज मन से, शांत मन से और अंतर्मन की गहराइयों से। आप सिर्फ डॉक्टर नहीं है, आप ईश्वर के बराबर आपको दर्जा मिला है। तो आप अपने उस पेशे की गरिमा, अपने उस पद की गरिमा के अनुरूप काम करिए। मैंने आपसे बस इतना कहा कि जो काशी हिंदू विश्वविद्यालय में सेवा कर लेता है, फिर वो दुनिया के किसी कोने में, आप कहीं भी बड़े सहज मन से, आपने दसियों हजार लोगों को एक दिन इस अस्पताल में देखा है, तो कुछ हजार लोगों की भीड़ आपके लिए कोई मायने नहीं रखती। तो आज इस सेमिनार के लिए आपने बहुत अच्छा विषय चुना है। दुनिया बहुत तेजी से प्रगति कर रही, हम सब लोग सोच रहे हैं कैसे हमारी गति बढ़े, काम करने की क्षमता बढ़े। तो उसके लिए लगता है कि एक ऐसी सुविधा आई है आर्टिफिशियल इंटेलिजेंस की, कि लोगों के काम बहुत सहज हो रहे हैं। हम भी डिजिटल डाटा के लिए बहुत बड़े-बड़े संस्थान उत्तर प्रदेश में भी बन रहे हैं। तो मुझको लगता है इन सबका सहजता से उपयोग करके हम आगे बढ़ें। इस अस्पताल को पूर्वांचल के लिए सेवा का इससे बड़ा कोई माध्यम नहीं है। तो इसको जितना अच्छा कर पाएँ, वो हमारे आने वाले कल में एक और हमारी खूबसूरती बढ़ेगी, हमारी शोहरत बढ़ेगी, हमारी क्षमता बढ़ेगी। बहुत-बहुत आभार।
आपका सादर आभार सर। मैं अब सभी मंचासीन अतिथियों से अनुरोध करूंगा कि इस अधिवेशन की स्मरिका का विमोचन आधिकारिक रूप से करें। डॉक्टर साक्षी और डॉक्टर विक्रम कृपया अतिथियों को सुगम कराएं। उधर से हटो। आप सभी का सादर धन्यवाद। यह सभागार अब अपने मुख्य अतिथि माननीय श्रीमती अनुप्रिया पटेल मैडम के आशीर्वचन लेने को उत्सुक हो रखा है, इसलिए हमारा मैडम से अनुरोध है कि वो अपने वचनों से हमें अनुग्रहित करें।
इस मंच पर आज के इस कार्यक्रम के विशिष्ट अतिथि के रूप में विराजमान मेरे भाई, उत्तर प्रदेश सरकार में माननीय राज्य मंत्री श्री दयाशंकर मिश्र दयालु जी, काशी हिंदू विश्वविद्यालय के कुलपति प्रोफेसर अजीत कुमार चतुर्वेदी जी, स्वास्थ्य और परिवार कल्याण मंत्रालय के ई हेल्थ डिपार्टमेंट की निदेशक श्रीमती रीना दास जी, IMS BHU के निदेशक डॉक्टर SN शंखवार जी, साइंटिफिक कमेटी के अध्यक्ष डॉक्टर अमित नंदन द्विवेदी जी और ऑर्गेनाइजिंग सेक्रेटरी डॉक्टर नीलेश कुमार जी, यहाँ पर उपस्थित आप सभी हमारे आज के इस आयोजन में प्रतिभाग करने वाले सभी शिक्षाविद, सभी शोधकर्तागण, सभी हमारे तकनीकी विशेषज्ञ, विद्यार्थीगण और मेरे साथ यहाँ चलकर आए मेरी पार्टी अपना दल के सभी कार्यकर्ता और पदाधिकारी। आर्टिफिशियल इंटेलिजेंस फॉर विकसित भारत, ट्रांसफॉर्मिंग हेल्थ केयर एंड लर्निंग, इस विषय पर आयोजित इस राष्ट्रीय अधिवेशन में आप सबके बीच उपस्थित होकर मुझे बेहद प्रसन्नता है और मैं हमारे रीजनल रिसोर्स सेंटर ईस्टर्न रीजन, जो आज एक व्यापक क्षेत्र में टेलीमेडिसिन की सुविधाओं को प्रदान करने में एक महती भूमिका निभा रहा है, हमारे नेशनल हेल्थ केयर फ्रेमवर्क में आर्टिफिशियल इंटेलिजेंस के इंटीग्रेशन को लेकर इस चर्चा को आयोजित करने के लिए इस प्रयास की बहुत सराहना भी करती हूं। आज ये राष्ट्रीय सम्मेलन एक बेहद खास मौके पर हो रहा है। आज 15 फरवरी है, आज एक बहुत पवित्र दिन है। कल 16 फरवरी से हमारे देश की राजधानी दिल्ली में ग्लोबल साउथ का पहला आर्टिफिशियल इंटेलिजेंस पर आधारित 5 दिवसीय AI इंडिया इम्पैक्ट समिट होने जा रहा है और ये ग्लोबल साउथ का एक ऐसा बड़ा इवेंट है, फर्स्ट एवर ऑन आर्टिफिशियल इंटेलिजेंस, जिसमें दुनिया के 100 से अधिक देश प्रतिभाग करने जा रहे हैं, जिसमें बड़े बड़े नेशनल लीडर्स होंगे, ग्लोबल लीडर्स होंगे, बहुत सारे ग्लोबल कंपनीज के सीईओज होंगे, साइंटिफिक एक्सपर्ट्स होंगे, रिसर्चर्स होंगे, एंटरप्रेन्योर्स होंगे, डेलीगेट्स, बहुत सारे अलग अलग तरह के डेलीगेट्स होंगे। और कैसे आज तमाम महत्वपूर्ण क्षेत्रों में, जिसमें हेल्थ केयर भी है, एग्रीकल्चर भी है, एजुकेशन भी है, मैन्युफैक्चरिंग है, क्लाइमेट चेंज है, ऐसे बहुत सारे अलग अलग महत्वपूर्ण सेक्टर्स में एआई के इंटीग्रेशन पर विचारों का आदान प्रदान होगा। और मुझे खुशी है कि इन सारे सेक्टर्स में जो एक बेहद इंपॉर्टेंट सेक्टर है हेल्थ केयर, आईएमएस बीएचयू ने आज उसको चुना है और उस पर इस चर्चा को आधारित किया है। क्योंकि जब हम 2047 के विकसित भारत की बात करते हैं, तो इस सपने को साकार करने के लिए हमें एक स्वस्थ भारत की आवश्यकता है, यानी एक बहुत ही मजबूत हेल्थ केयर इकोसिस्टम हमारे पास होना चाहिए। भारत जैसे देश के लिए आर्टिफिशियल इंटेलिजेंस कोई लग्जरी नहीं है, बल्कि आर्टिफिशियल इंटेलिजेंस आज समय की मांग है। और भारत ने अमेरिका और चीन के बाद आर्टिफिशियल इंटेलिजेंस के विकास और उसके उपयोग में आज दुनिया में तीसरे बड़े देश के रूप में अपनी एक छवि गढ़ी है। इतनी तेजी से एआई का विस्तार हमारे देश के अंदर हो रहा है। और ये सच है कि आर्टिफिशियल इंटेलिजेंस एक ऐसा माध्यम है जिसके जरिए हम एक एक नागरिक तक, जहां हमारे स्पेशलिस्ट नहीं पहुंच सकते, जहां हमारे संसाधनों का अभाव है, हम उनकी आवश्यकताओं की पूर्ति कर सकते हैं। ये एक महत्वपूर्ण सेतु के रूप में है। और भारत की सरकार आज एक बहुत बड़े लक्ष्य को लेकर आगे बढ़ रही है। जब हम विकसित भारत 2047 की बात करते हैं, तो उसमें स्वस्थ भारत की हमारी परिभाषा क्या है? स्वस्थ भारत की परिभाषा है यूनिवर्सल हेल्थ कवरेज को प्राप्त करना, यानी देश का एक एक नागरिक, उसके पास सुलभ, किफायती और गुणवत्तापूर्ण स्वास्थ्य सेवा की पहुंच होनी चाहिए। लेकिन ये जो इतना बड़ा लक्ष्य है, यूनिवर्सल हेल्थ कवरेज की बात ग्लोबल प्लेटफॉर्म्स पे होती है, और हमारे देश में भी कागजों पर यूनिवर्सल हेल्थ कवरेज की बात बहुत हुई, लेकिन इसे हकीकत में बदलने की शुरुआत आज से 12 साल पहले हुई, जब हमारी सरकार ने इसे एक संकल्प के रूप में, एक चुनौती के रूप में स्वीकार किया। और जब हम यूनिवर्सल हेल्थ कवरेज की बात करते हैं, तो ये सामान्य लक्ष्य नहीं है। इसके मार्ग में बहुत सारी पहाड़ जैसी चुनौतियां हैं, जिन्हें हम कहते हैं कि भारत के यूनिक चैलेंजेस हैं। और सबसे बड़ा चैलेंज तो आप सब जानते हैं, वो है भारत की विशालकाय आबादी। 146 करोड़ नागरिक, ये सामान्य संख्या है। दुनिया के न जाने कितने देशों की आबादी को अगर इकट्ठा कर दिया जाए, तो भी भारत की आबादी का मुकाबला नहीं कर सकते, इतनी बड़ी आबादी है। और हम कहते हैं कि हम एक एक नागरिक तक पहुंचेंगे, उसको एक्सेसिबल, अफोर्डेबल, क्वालिटी हेल्थ केयर देंगे, तो कैसे संभव होगा? और ये तो एक चुनौती है। इसके अलावा हमारी भौगोलिक चुनौतियां, न जाने कितने दुर्गम, दूरस्थ, आदिवासी इलाके हैं, जहां तक आज अभी स्पेशलिस्ट की, डॉक्टर्स की, इंफ्रास्ट्रक्चर की पहुंच नहीं है। हमारे देश के अंदर गांव और शहर के बीच का एक अंतर है, खाई है। और दुनिया की 18% आबादी हमारे पास है और 20% ग्लोबल डिजीज बर्डन है। और उस ग्लोबल डिजीज बर्डन में क्या हम देखते हैं? सबसे बड़ा बर्डन है नॉन कम्युनिकेबल डिजीजेस का, और उसके साथ साथ कम्युनिकेबल डिजीजेस भी हैं, क्रोनिक डिजीजेस भी हैं। तो हमारे पास जो इतना बड़ा बर्डन है 20% का दुनिया का, उसके साथ ये तमाम चुनौतियां, संसाधनों का अभाव, स्पेशलिस्ट की, विशेषज्ञों की कमी, इन सारे यूनिक चैलेंजेस के बीच में भारत सरकार ने इन 12 वर्षों में चाहे मेडिकल एजुकेशन हो या हेल्थ केयर इंफ्रास्ट्रक्चर हो या स्वास्थ्य से जुड़े हुए तमाम अन्य पहलू हो, उस पर तेजी से काम किया है और बहुत विस्तार हुआ है। मैं उसके डिटेल्स में नहीं जाऊंगी, लेकिन उसके साथ साथ टेक्नोलॉजी का इंटीग्रेशन बहुत जरूरी है और हमने अपने नेशनल हेल्थ केयर फ्रेमवर्क में टेक्नोलॉजी का कॉम्प्रिहेंसिव रूप में अडॉप्शन किया है। जिस नेशनल टेलीमेडिसिन की सेवा आज हम ईस्टर्न रिसोर्स सेंटर से प्रोवाइड कर रहे हैं, यह हमारा एक बहुत बड़ा प्रयोग है। ई संजीवनी टेक्नोलॉजी का अडॉप्शन है। आज उसके माध्यम से गांव में, सुदूर इलाके में बैठा हुआ एक सामान्य नागरिक जो शायद एक बड़ी टर्शरी हेल्थ केयर फैसिलिटी तक नहीं पहुंच सकता, आज वो वर्चुअल कंसल्टेशन के जरिए लाभान्वित हो रहा है और करोड़ों लोग लाभान्वित हुए हैं ई संजीवनी के माध्यम से। आज हम आयुष्मान भारत डिजिटल मिशन पे काम कर रहे हैं। देश के हर नागरिक का हम डिजिटल हेल्थ आईडी क्रिएट कर रहे हैं और इसके साथ हमने एआई का इंटीग्रेशन किया है, आर्टिफिशियल इंटेलिजेंस का इंटीग्रेशन किया है। और आर्टिफिशियल इंटेलिजेंस के जब हम इंटीग्रेशन की बात करते हैं तो डिजीज सर्वेलेंस से लेकर प्रिवेंशन से लेकर डायग्नोसिस और ट्रीटमेंट तक, यानी एंटायर हेल्थ कॉन्टिन्यूम, उसमें आज हम एआई को इंटीग्रेट कर रहे हैं, बहुत तेजी से कर रहे हैं। तभी आज हम अमेरिका और चाइना के बाद तीसरे नंबर पे आकर खड़े हुए हैं। हमने एक बहुत बड़ा सपोर्ट इकोसिस्टम तैयार किया है। हमारे देश की जो सबसे रेप्यूटेड इंस्टीट्यूट्स हैं, एम्स न्यू दिल्ली, एम्स ऋषिकेश, पीजीआई चंडीगढ़ और ऐसे दो हमारे और इंस्टीट्यूट्स हैं, यहां पर हमने आज इनको एआई के सेंटर ऑफ एक्सीलेंस के रूप में डेजिग्नेट किया है। भारत सरकार के तमाम मंत्रालय, बहुत सारे रिसर्च बॉडीज और बहुत सारे प्राइवेट सेक्टर एक साथ एक कोलैबोरेटिव फ्रेमवर्क के तहत आकर ऐसे सॉल्यूशंस जो क्लिनिकली रेलेवेंट भी हैं और वैलिडेटेड भी हैं, ऐसे एआई पावर्ड सॉल्यूशंस को विकसित कर रहे हैं और उसका भारत में बड़े व्यापक पैमाने पर उपयोग भी हो रहा है। आप मधुनेत्र एआई के बारे में आपने सुना होगा। हमने अभी अपना सघन टीबी अभियान चलाया था, उसमें हमने मैसिव स्क्रीनिंग किया, नए नए केसेस को हम ढूंढ के लाए, उसमें हमने एआई पावर्ड हैंडहेल्ड एक्सरेस का उपयोग किया। तो ऐसे बहुत सारे सॉल्यूशंस हम विकसित कर रहे हैं, लेकिन भारत को ऐसे सॉल्यूशंस की जरूरत है, एआई पावर्ड सॉल्यूशंस की, जो भारत को दिमाग में रखकर डिजाइन किए गए हों। यानी अगर हम अपने देश की तुलना किसी ऐसे देश से करेंगे जिसे हम कहते हैं कि एक रिसोर्स रिच हेल्थ सेटिंग है, कोई पश्चिमी अमीर देश है, वहां की पॉपुलेशन की आवश्यकताएं अलग हैं। अगर उसको ध्यान में रखकर बनाया गया कोई एआई सॉल्यूशन हमें कोई देता है तो हमारे लिए अनुपयोगी है। हमें भारत को दिमाग के में रखकर डिजाइन किए गए एआई पावर्ड टूल्स एंड टेक्नोलॉजीज चाहिए। और भारत सरकार स्वास्थ्य और परिवार कल्याण मंत्रालय ऐसे ही फ्रूगल इनोवेशंस पर अपने सारे ध्यान को केंद्रित कर रहा है। स्मॉल, सिंपल, अफोर्डेबल, स्केलेबल। और मैं आईएमएस बीएचयू को कहूंगी कि आपके पास एक बहुत बड़ा स्कोप है रिसर्च का। ऐसे फ्रूगल इनोवेशंस, रिसर्च को आप बढ़ावा दें। भारत सरकार हर तरीके से इस इंस्टीट्यूट के, आपने बहुत सारे विषय भी उठाए और ये सच है कि भारत सरकार निरंतर, क्योंकि जो बात हमारे माननीय मंत्री जी कह रहे थे आईएमएस बीएचयू को लेकर कि कितने बड़े इलाके से आने वाले हमारे पेशेंट्स को ये दिन रात हमारा ये इंस्टीट्यूशन केटर करता है, ये बिल्कुल सत्य है। ये तो जूझते हैं, साथ में मैं भी जूझती हूँ, क्योंकि मेरे पास भी जो मरीज आते हैं उनको चाहिए होता है सहयोग। और यहाँ की जितनी टीम बैठी हुई है, आप सब सहयोग करते हैं जितना आपसे संभव होता है। मैं तो कहती हूँ कि क्षमता से बाहर जाके करते हैं। और इसीलिए एम्स लाइक इंस्टीट्यूशन का जो कॉन्सेप्ट आया तो उसमें एक एमओयू साइन हुआ, क्योंकि आईएमएस बीएचयू हमारे मिनिस्ट्री ऑफ एजुकेशन से गवर्न होता है, लेकिन मिनिस्ट्री ऑफ हेल्थ एंड फैमिली वेलफेयर और मिनिस्ट्री ऑफ एजुकेशन के बीच में एक एमओयू साइन हुआ। और इसीलिए क्योंकि टेक्निकल फाइनेंशियल गाइडेंस हम देना चाहते हैं, हम चाहते हैं कि हमारा आईएमएस बीएचयू और बेहतर सेवाएं दे पाए, और उसमें जो भी कहीं कुछ अड़चने भी हैं तो निश्चित रूप से उसका समाधान भी होगा। और जो बात मैं कह रही थी कि हमें ऐसे सॉल्यूशंस चाहिए जो हमारी डाइवर्स डेमोग्राफीज की आवश्यकताओं को केटर कर सके। और उस रिसर्च में आप IMS BHU एज एन इंस्टीट्यूशन कैन गिव अ ग्रेट कंट्रीब्यूशन। बहुत कुछ ऐसा आप योगदान दे सकते हैं। एक और जरूरी विषय आता है कि जब हम आर्टिफिशियल इंटेलिजेंस के उपयोग की तरफ बढ़ते हैं, हम तेजी से बढ़े हैं, नए नए सॉल्यूशंस डेवलप कर लें, तो कुछ ऐसे सवाल है उठते हैं। आप पढ़ते हैं, आप सब एकेडमिशियंस हैं, स्कॉलर्स हैं, रिसर्चर्स हैं, और जो हमारी हेल्थ केयर कम्युनिटी है या जो आम नागरिक है, यहाँ पे बहुत सारे आम नागरिक भी होंगे जिन्हें आर्टिफिशियल इंटेलिजेंस के साइंटिफिक और टेक्निकल चीजों के बारे में नहीं पता। तो बहुत सारे ऐसे विषय आते हैं जिनकी चर्चा होती है कि भाई डेटा प्रिवेसी, डेटा प्रोटेक्शन का क्या, एक पेशेंट का डेटा कॉन्फिडेंशियल होता है, ये विषय भी आता है, इसे हमें सुनिश्चित करना है। और एल्गोरिथम्स के बायस होते हैं क्योंकि डेमोग्राफीज डाइवर्स होती हैं, तो उसको हम कैसे मिटिगेट कर सकते हैं, उसको कैसे हम कम कर सकते हैं। और जो हमारे आर्टिफिशियल इंटेलिजेंस के जितने भी हमारे टूल्स एंड टेक्नोलॉजीज हैं, उसकी एक्सप्लेनेबिलिटी और ट्रांसपेरेंसी कायम होनी चाहिए। यानी एक तो हमारे जो हेल्थ केयर प्रैक्टिशनर्स हैं, स्पेशलिस्ट हो या नॉन स्पेशलिस्ट हो, वो जब इन टेक्नोलॉजीज का उपयोग करते हैं तो उनके लिए ये समझ होनी चाहिए कि अगर आर्टिफिशियल इंटेलिजेंस का कोई टूल किसी भी कंक्लूजन पे पहुंचता है तो कैसे पहुंचता है। दैट एनालिसिस शुड मेक सेंस टू मी, सो इट्स इंपॉर्टेंट फॉर मी टू अंडरस्टैंड हाउ इट वर्क्स। और इसलिए हमें अपने स्पेशलिस्ट, नॉन स्पेशलिस्ट, सबकी कैपेसिटी बिल्डिंग की भी जरूरत है। ये भी एक इंपॉर्टेंट पहलू है। और इसके साथ साथ एक बड़ा सवाल है, वो है रेगुलेटरी फ्रेमवर्क को लेकर। अच्छी चीज है आर्टिफिशियल इंटेलिजेंस, बट द मोस्ट इंपॉर्टेंट क्वेश्चन इज द एथिकल एंड रिस्पॉन्सिबल एंड सेफ यूज ऑफ आर्टिफिशियल इंटेलिजेंस। दैट्स द मोस्ट इंपॉर्टेंट क्वेश्चन। और मुझे आपके बीच ये कहते हुए खुशी है कि भारत सरकार का स्वास्थ्य और परिवार कल्याण मंत्रालय उसको एड्रेस करता है। इन सारी चिंताओं का हम समाधान करते हैं। हमने अपने रेगुलेटरी फ्रेमवर्क को बहुत ही रोबस्ट बनाया हुआ है। आज आर्टिफिशियल इंटेलिजेंस के लिए हमारी एक स्ट्रैटेजिक पॉलिसी है, हमारा एक पर्सनल डेटा प्रोटेक्शन एक्ट है, और एथिकल एंड रिस्पॉन्सिबल use of AI के guidelines हैं. So there is a very strong regulatory framework that India is following today. आज जब हम अपने मॉडल्स को AI इंडिया इम्पैक्ट समिट के जरिए दुनिया के तमाम देशों के सामने प्रस्तुत करेंगे, तो ये एक ऐसा मॉडल है विच इज रेप्लिकेबल। बहुत सारे ग्लोबल साउथ के देश इंडिया के मॉडल से बहुत कुछ सीख सकते हैं। हमने बहुत सारा काम इसमें किया है। और एक अंतिम विषय जो बेहद महत्वपूर्ण है, और वो विषय है कि क्या आर्टिफिशियल इंटेलिजेंस डॉक्टर्स को रिप्लेस कर सकता है? दैट्स द बिगेस्ट क्वेश्चन। ऐसा नहीं होने वाला। आर्टिफिशियल इंटेलिजेंस कैन असिस्ट, इट कैन नॉट डिक्टेट। आर्टिफिशियल इंटेलिजेंस हेल्थ केयर प्रैक्टिशनर्स का, डॉक्टर्स का एक सहायक है। मरीजों का बेहतर इलाज करने में उनकी मदद कर सकता है। डॉक्टर्स के वॉल्यूम ऑफ वर्क के बर्डन को कम कर सकता है, लेकिन डॉक्टर्स की, क्लिनिशियंस की ह्यूमन ऑटोनॉमी की जगह कभी नहीं ले सकता। दैट्स द मॉडल वी आर फॉलोइंग, एंड दैट इज एन इंपॉर्टेंट थिंग टू अंडरस्टैंड। सो AI is not competing with clinicians, it is only compensating for their absence. जहां हम हमारे स्पेशलिस्ट नहीं पहुंच पा रहे, जहां संसाधन नहीं है, हम कैसे AI को एक वाइटल ब्रिज की तरह यूज करें, सो वी आर एबल टू सर्व आवर पॉपुलेशंस। क्योंकि हर व्यक्ति को सर्व करना, हर एक नागरिक तक स्वास्थ्य की सेवाओं को सुनिश्चित करना, ये हमारा लक्ष्य है। और AI सिर्फ उसमें एक मददगार है उस यूनिवर्सल हेल्थ कवरेज के लक्ष्य को प्राप्त करने के लिए। लेकिन चूंकि यहाँ पर बहुत सारे हेल्थ केयर प्रैक्टिशनर्स हैं, हमारे बहुत सारे स्टूडेंट्स हैं, तो मैं उनको ये जरूर कहना चाहती हूं कि आने वाला समय AI का है, और हमारे डॉक्टर्स के लिए AI के फंडामेंटल्स को समझना, उसके उपयोग को समझना, उससे जुड़ी हुई चुनौतियों को समझना, ये जरूरी है। तो चाहे हमारी वर्तमान पीढ़ी हो या हमारी भावी पीढ़ी हो, आपको एआई के प्रशिक्षण की आवश्यकता है। और मैं बीएचयू को भी आग्रह करूंगी कि जो हमारे डॉक्टर्स हैं उनको ये प्रशिक्षण दिया जाए। मुझे आपको ये भी बताते हो खुशी है कि अभी बस कुछ ही दिन पहले जनवरी के महीने में हमारे नेशनल बोर्ड ऑफ एग्जामिनेशन इन मेडिकल साइंसेज ने देश भर के डॉक्टर्स के लिए एक विशेष किस्म का ऑनलाइन ट्रेनिंग प्रोग्राम इन आर्टिफिशियल इंटेलिजेंस इसको लॉन्च किया है। और ये 20 घंटे का 20 सेशंस का फ्री ऑफ कॉस्ट एक प्रोग्राम है जिसमें ऑनलाइन 20 हमारे सब्जेक्ट एक्सपर्ट्स के लेक्चर्स के माध्यम से हमारे जो भी डॉक्टर्स एआई से परिचित होना चाहते हैं, एआई के फंडामेंटल्स से परिचित होना चाहते हैं, वो इसका लाभ उठा सकते हैं। तो मैं आप सबको यही आग्रह करूंगी, बीएचयू को भी आग्रह करूंगी कि हमारे भावी जो हेल्थ केयर प्रैक्टिशनर्स हैं, लीडर्स हैं, उनको एआई से अपडेटेड रहने की जरूरत है। जब हम एआई के जरिए हेल्थ केयर में ट्रांसफॉर्मेशन की बात कर रहे हैं, then this is the most important step for us. तो आप सभी को आज के इस आयोजन के लिए, इसमें प्रतिभाग करने के लिए, और मैं समझती हूँ कि इस सम्मेलन के दौरान बहुत विस्तृत विचारों का आदान प्रदान होगा और ये जो हमारी पूरी मुहिम है इसको बल मिलेगा। आप सभी को मैं यही कहते हुए ढेर सारी शुभकामनाएं दूंगी। आर्टिफिशियल इंटेलिजेंस कोई विकल्प नहीं है, ये समय की मांग है। Artificial intelligence is not an option, it is a necessity. But what we need today is safety, responsibility, and ethics when it comes to the use of artificial intelligence in healthcare. बहुत बहुत धन्यवाद।
आपका बहुत बहुत धन्यवाद और आभार मैडम। अब आयोजन समिति की तरफ से हम सभी सम्मानित अतिथियों को आयोजन का स्मृति चिन्ह देने का सौभाग्य की अनुभूति करेंगे। सर्वप्रथम कुलपति महोदय से मैं अनुरोध करता हूं कि वो हमारी मुख्य अतिथि माननीय अनुप्रिया पटेल मैडम को स्मृति चिन्ह भेंट करें। मेरा अनुरोध हमारे निदेशक महोदय से है कि वो हमारे सम्मानीय अतिथि माननीय श्री दयाशंकर मिश्र जी को स्मृति चिन्ह भेंट करें। निदेशक महोदय से पुनः अनुरोध है कि आप हमारे कुलपति जी को भी स्मृति चिन्ह प्रदान करें। मैं डॉक्टर अमित द्विवेदी जी से अनुरोध करूंगा कि वो रीना मैडम को स्मृति चिन्ह भेंट करें। सर बैठ। मैं डॉक्टर नीलेश सर से अनुरोध करूंगा कि वो हमारे निदेशक महोदय को स्मृति चिन्ह भेंट करें। मैं डॉक्टर साक्षी से अनुरोध करूंगा कि वो डॉक्टर अमित द्विवेदी को स्मृति चिन्ह भेंट करें। डॉक्टर साक्षी जी से पुनः अनुरोध है कि वो डॉक्टर नीलेश सर को भी स्मृति चिन्ह भेंट करें। यह आयोजन अब अपनी समाप्ति की तरफ है, तो इसकी परंपरा के अनुसार अब आयोजन समिति डॉक्टर नीलेश सर से अनुरोध है कि वो धन्यवाद ज्ञापन प्रस्तुत करें।
माननीय मंचासीन अतिथिगण, सम्मानित मुख्य अतिथि, आदरणीय विशिष्ट एंड प्रिय सहकर्मियों, राष्ट्रीय सम्मेलन एआई इन हेल्थ केयर एंड एजुकेशन के इस ऐतिहासिक उद्घाटन सत्र के समापन अवसर पर आयोजन सचिव के रूप में मुझे यह सौभाग्य प्राप्त हुआ है कि मैं आप सभी के प्रति अपनी कृतज्ञता और आभार के शब्द प्रस्तुत कर सकूं। सबसे पहले मैं इस मंच से हमारे मुख्य अतिथि, भारतीय सरकार की माननीय केंद्रीय स्वास्थ्य एवं परिवार कल्याण राज्य मंत्री श्रीमती अनुप्रिया पटेल जी का हृदय से धन्यवाद करता हूं। माननीय मंत्री जी ने अपने दूरदर्शी संबोधन में जिस प्रकार सरकार की स्वास्थ्य नीति, डिजिटल स्वास्थ्य मिशन और वंचित व दूरस्थ क्षेत्रों तक तकनीकी के माध्यम से गुणवत्तापूर्ण स्वास्थ्य सेवाएं पहुंचाने की प्रतिबद्धता को रेखांकित किया, वह हम सभी के लिए मार्गदर्शक और प्रेरणा स्रोत है। आपका मार्गदर्शन इस सम्मेलन को राष्ट्रीय दृष्टि और दिशा प्रदान करता है। मैं माननीय श्री दयाशंकर मिश्रा दयालु जी का भी हार्दिक आभार व्यक्त करता हूं, जिन्होंने अपने स्नेहपूर्ण शब्दों और जन सेवा के अनुभव से इस मंच को गौरवान्वित किया। मैं माननीय प्रोफेसर अजीत कुमार चतुर्वेदी जी, कुलपति काशी हिंदू विश्वविद्यालय का विशेष रूप से धन्यवाद करता हूं। आदरणीय कुलपति महोदय के दूरदर्शी नेतृत्व में बीएचयू निरंतर शिक्षा, अनुसंधान, स्वास्थ्य और तकनीकी के संगम का राष्ट्रीय केंद्र बनता जा रहा है। मैं सुश्री रीना आशीष जी, निदेशक भारत सरकार का भी सादर आभार व्यक्त करता हूं। आपकी प्रशासनिक दृष्टि और नीति स्तरीय अनुभव से इस सम्मेलन को मजबूती दी और यह सुनिश्चित किया कि अकादमिक विमर्श राष्ट्रीय स्वास्थ्य प्राथमिकताओं से जुड़ा रहे। इस अवसर पर मैं डॉक्टर एस.एन. संखवा, निदेशक IMS BHU एवं आयोजन अध्यक्ष का विशेष धन्यवाद करता हूं। सर के कुशल नेतृत्व, सतत मार्गदर्शन और विश्वास के कारण ही यह आयोजन न केवल एक सम्मेलन बल्कि एक राष्ट्रीय मिशन के रूप में साकार हो पाया। मैं हमारे सभी वैज्ञानिक वक्ताओं, सत्र अध्यक्षों, पैनल विशेषज्ञों तथा देश विदेश से पधारे प्रतिनिधियों का भी आभार व्यक्त करता हूं। आप सभी ने अपने ज्ञान, अनुभव और विचारों से इस सम्मेलन को समृद्ध किया है। साथ ही मीडिया प्रतिनिधियों का धन्यवाद, जिनके माध्यम से इस सम्मेलन की सोच और संदेश समाज के व्यापक वर्ग तक पहुंचेगा। यह सम्मेलन केवल विचार विमर्श का मंच नहीं, बल्कि भारत के भविष्य के बुद्धिमान, समावेशी और सुलभ स्वास्थ्य तंत्र की रूपरेखा तैयार करने की दिशा में एक सामूहिक संकल्प है। आप सभी का पुनः हार्दिक धन्यवाद। जय हिंद।
धन्यवाद सर। कार्यक्रम के समापन पर आप सभी से अनुरोध है कि अपने स्थान पर खड़े हो जाएं, जिससे हम राष्ट्रगान कर सकें।
जनगण मन अधिनायक जय हे भारत भाग्य विधाता, पंजाब सिंध गुजरात विंध्य हिमाचल उच्चल जलधि तरंगा, तव शुभ नामे जागे, तव शुभ आशीष मांगे, गाये तव जय गाथा, जन गण मंगल दायक जय हे भारत भाग्य विधाता, जय जय हे जय हे जय 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 हे।
जय जय। आयोजन समिति की तरफ से आप सभी से अनुरोध है, सभी सम्मानित अतिथिगण, सभी शिक्षकगण और सभी प्रतिभागी लंच के लिए प्रस्थान करें। सभी विशिष्टगण और फैकल्टी के लिए लंच डाइनिंग हॉल नंबर 1 में है और सारे डेलीगेट्स और स्टाफ का डाइनिंग हॉल नंबर 2 में है। आपको मार्गदर्शिका के लोग बाहर उपलब्ध हैं। कृपया प्रोटोकॉल का पालन
that neutralizing factor in this human bias. So as we shift from evidence-based medicine into data-driven AI-based medicine, intelligence-based medicine, a structured way of learning is very important. And this is what I want to introduce to all of you in the BHU today. Because at the moment, we have to come out of this wow factor and ask the question, how is this algorithm working? Because we are looking at adopting evidence-based intelligent medicine. So the focus should be with foundation knowledge, with practical application, education on the ethical and the legal considerations, like the regulatory guidelines, and constant quality improvement and validation. How do you start? You start with a foundation knowledge with the basics of AI and machine learning. Get yourself familiar with data science principle, relevant algorithms. Look at healthcare applications, ethical consideration, and the practical way is find a collaborator from the technology world who will help you integrate between the need gap that you understand and the technological solution that is existent. So the foundation knowledge should include understanding machine learning, the terminologies, understanding generative AI in today's world, understanding agents and agentic AI solution. AI will have practical applications from diagnostics tool to clinical decision support system to predictive analytics. In a way, primordial prevention can be taken place. Each of these segments, we have to learn this in a proper way. And not to leave out understanding on data privacy, liability concerns. If the AI algorithm goes wrong, then who is responsible for that? And eventually the target is to augment the doctor-patient relationship. The communication and collaboration between the patient and the doctor and the AI ecosystem, this has to be established in the educational pathway with a collaborative approach going forward. And constant quality improvement with patient feedback analysis, evaluation, and the entire AI ecosystem has to be designed in a patient-centric manner. So the medical curriculum, which we propose from Doctors AI, should have an early exposure, integration into the existing courses, and hands-on clinical training. So the early exposure should be in the undergraduate and the postgraduate days for medical students, and also as a part of faculty development program. We believe that there is going to be 3 tiers of AI literacy for doctors. Not every doctor will need to know everything about AI. While the basic AI skills at the bottom is going to be an essential for all, proficient AI skills will be required by 80 to 85% of medical professionals, and only 5 to 7% of doctors may want to become an expert AI skill individual who will go into AI entrepreneurship and develop tools with the technology experts. So these are the 3 fundamental layers of learning amongst the literacy in doctors, which we propose from Doctors AI. We propose that this education should happen in a structured way, starting with the primer, which we conduct in medical schools and medical institutes, which is the Doctors AI primer. Structured certification programs, which we have the certificate course of artificial intelligence in medicine. And then some of us may want to go into an advanced certification program where you will actually be co-building solution as a part of your capstone project. So this is a glimpse of the primers that we have conducted across this country. We have done about more than 30 primers in medical colleges. And I can also see some of our members sitting here. And we are always in an attempt to have a primer. Maybe sometime given an opportunity, would like to come back to BHU and have an AI primer of 1.5 hours with the institute itself. There should be simulations lab, incubation center in every medical institute with interactive workshop and need gap based case study analysis. Only then doctors will be able to adopt AI in the way we want to adopt. It's beyond, it's more than just a technology. It's an ecosystem which has to come in the integration of medicine. This is a look at our course, the certificate course of artificial intelligence in medicine, which is a very popular course across the country now. About 150 doctors have already completed this course, and we have a wait list of 300 doctors. It's a 3-month course with a capstone project for doctors to undergo training on. Yes, this is an online course. Sorry for the, I'll just give you the QR. This is an online course. It's a 42 hours of learning, and it is certification from Healthcare Sector Skill Council and also from Technology University. And we're looking at a collaboration of a medical university as well for this course. This ends with a capstone project where we literally taught how to build, co-build a solution in a group to get started with. So this is the QR code for the wait list. The next batch probably starts in June, which is the batch 4. So we have completed 3 batches, and at the moment we are doing a batch with the Indian Society of Critical Care Medicine also as a subspecialty batch. When we plan to do similar batches with the pediatricians and with the laboratory medicine specialist and the public health specialist as well. And this is the face of AI literate clinicians. This is how they look like. This was in our conference last year in Bangalore in the Doctors AI Global Summit, where we have given convocation to all the participants of the course. So this is how the journey of our doctors should be, from foundation knowledge, learn data science principle, look at the practical application with a hands-on training, and eventually get into a research engagement. We will be very soon starting with the International Journal of Artificial Intelligence in Medicine from Dr. Zia, and we'll be inviting all of you to submit whatever research you're doing with AI into the journal to complete the entire ecosystem. There's going to be a lot of challenge coming in because we are all busy people. There's going to be curriculum overload, 5.5 years and then 3 years of grilling and then another 2 years of super specialization grills you out. So plus now added AI education, it's going to be a burden. The infrastructure will have to be built. Ethics will have to be taken into consideration. But the silver lining is we all have the intent of doing it. So I'm sure this is going to be possible. We have to address this challenge first by taking away all our cognitive resistance and trying to adopt. We must have a structured way, institution-based structured way of faculty development program in every institute. And this is something that Dr. Zay is very happy to collaborate with and bring out small pilot programs and publish the success stories. The strategic implementation could be with tailored programs, partnerships with not-for-profit organizations like us will be very happy, and also flexible curriculum like our CCIM, weekend learning for the busy clinician practitioners. So with this, I will invite all of you to be a part of this community called Doctors AI. Our vision is very simple. We start with education, we encourage research, we collaborate, and eventually doctors should be part of validating and evaluating AI ecosystem. Because for us, it's not a technology. It's an ecosystem that helps us save our patient's life, and we are responsible for it. So responsible AI is more in healthcare than in any other field. This is how we do our regular activities, update hours, journal clubs, we have our podcast, we do webinars. So if you're part of the ecosystem, you'll be a part of the Doctors AI community, and we'll invite all of you to follow this. The primers have been going on across the country for quite some time now, more than a year and a half, and it's got resounding success, and we feel this is a need, but we can't do it alone. So we need all medical professionals to collaborate and take this way forward. We believe in one thing very simply, it's AI for the doctors, by the doctors. We have collaboration with the Indian Council of Medical Research, the National Institute of Digital Health and Data Science, as well as with the Indian Institute of Science Tanu project. And we are also looking at a collaboration with Art Park and few other institutes where we will encourage doctors doing the research, implementing and co-building, with experts from these institutes, and then having a publication going forward so that the ecosystem is forward. We've been part of the Responsible AI NASH, the consensus or the policy which will be brought up by the government of India very soon. And this was one of our participation at the National AI Strategy for Health meeting last month in Mumbai. So this is the QR code. You can just go to our website, take a look at Doctors AI as an organization. The whole focus of Doctors AI is this is a movement. This is just not an organization. It's a movement of the doctors for the doctors, because the end of the day, a person that I've been looking at AI for the last 8 years now, and I feel that the lens with which a doctor will look at artificial intelligence will be much different than the lens with which anybody else will look at. So we have to create our own ecosystem of artificial intelligence for us. We invite all of you to explore the website. This is a link to become a member of the Indian College of Artificial Intelligence in Medicine, which is under the Doctors AI Education and Research Foundation. And this is, of course, for the next batch. And this is a textbook which we have launched last year. If you want to get started with it, this is an AI in medicine update. And this will also be updated every year. And wholeheartedly, I welcome all of you who stayed back skipping your lunch. Thank you again very much to join us for the Doctors AI Global Summit. We believe that in today's world, we have to be bilingual. We have to speak this technology jargon as much as we speak our medical jargon. And with this, I invite all of you to join us in New Delhi on September 19th and 20th for the second annual conference of Doctors AI. This is the Doctors AI Global Summit. And we hope that you all come, meet colleagues, find the network, collaborate, because eventually technology and AI in medicine is a collaborative work together. Thank you very much. And I will leave you all with this message. And I would want all of you to think on this. Healthcare and medicine is transforming with technology. We have to decide whether we want to be in the driving seat or we want to be in the back seat. Thank you so much. Thank you. Thank you, Abhishek.
Thank you so much, sir. Thank you so much. It was a very nice and informative talk in the scarcity of the time. So, sir, I would like to invite Khanna sir for facilitate the Amit Kumar De sir. Sir, please. Thank you so much, sir.
We need all of you to take it forward. Thank you so much. Yes, that's
तो नीलेश बॉस का और डायरेक्टर सर हुआ है। Thank you, dear. ये मेरे को देखने कल के नाम पे मुझे देखते हैं वाल और है अरे बच्चे यहाँ पे सारा करा हम स्नैप सबको बोला
Check one. Hello. Hello.
Welcome back, everyone. Moving on to session 5 of the scientific program, I am deeply honored to invite our esteemed chairpersons for this session. I respectfully invite Professor R.N. Chaurasia, sir, Department of Neurology, IMS BHU, Professor Dharmen Jain, sir, Department of Cardiology, IMS BHU, and Dr. Anand Kumar Rai, sir, Department of Neurology, AIMS Patna, to kindly grace the dais. I request our chairpersons to kindly grace the dais and introduce our speakers for this session.
So, good afternoon, everyone. And now the post-lunch session is going to be start. And the first speaker is Dr. Suresh, who is my MBBS batchmate. And I think I know much and I can speak about 30 minutes, but I don't think so. There is a requirement. Now he is a national coordinator for the artificial intelligence lecture series which is going on, freely available. Madam has also narrated during the inauguration sessions. So without much wasting time, I will invite the my batchmate, Dr. Suresh. Over to you.
Thank you very much. I know post-lunch sessions are always difficult to deal, right? But one of the things that led to what I feel is the most impactful thing, I mean, that may be a different perception for different people, is one test, two outcomes. That's where I feel that I made some impact using the artificial intelligence. But the journey didn't start with this innovation. The journey started way behind that. So the entire journey started since 2010, when close to 25 of us, few of them are gynecologists, few of them are neurologists, cardiologists, we came together. We thought, okay, let us start collecting data. So our intention was to make sure that we have one of the largest publications. We haven't had anything else in our mind. So we started with this, and I'll take you through this journey. When AI was introduced to me in 2014 by Professor Dakshinamurthy, he's the INSOF CEO, he told that it is nothing but advanced mathematics. That eased me. Okay, वो तो maths है, चल जाएगा, सीख लेता हूँ. He told, if you have a strong basics in mathematics, then what you do? You learn statistics. And you start looking at the probability, right? All statistics will confirm your hypothesis. That has already happened. That is retrospective. And AI is like a prospective thing. AI is never retrospective. AI will predict, stats will prove. So we want to understand this basics concepts very clearly. So they help to understand the patterns using math. AI uses these patterns to make decision. Decision is always futuristic. So this is the first lesson of AI which I learned in my classes, right? And then if I keep on telling the same thing, कोई भी सीख लेता है. That's called learning, right? OT में जाओ 10 बार सीखो तो अपने आप आ जाते 11 बार. This is called, machines also do the same thing. It's called machine learning. And if it becomes poetic, it becomes Gen AI. So it can generate its own imaginations. तो पोइट्री में एक ही प्रॉब्लम होता है कि starting from the moon to the girl's face, they can compare anything. That is called hallucinations in actual language. So that's the problem with the Gen AI. वो जो भी बोलते हैं सही नहीं है. It's having a lot of problems of biases whenever it is going to do that. But we are doing with only two numbers so far. That is 0 and 1. That is called classical computing. But if I can use 0 to 9, it's called quantum computing. So the pace at which AI is going to transform is 1,000-fold, and we haven't seen it yet. That's exactly is the future. So this is my first lesson, which I just try to summarize into what it is when I look from the lens of a mathematics, right? So this is what we did. We have close to 4.5 million test records accumulated over a period of 10 years by 25 doctors belonging to 5 lakh patients, and we have close to 1,000 tests available with us. So we used a priori models. I don't want to bore you with what are those a priori models and other things. And our first thing, I'm a medical oncologist and hematologist. My interest is always in oncology. So when I tried to look what happened to the myeloma patients, 7% of the myeloma patients, not a big number, have a constant incremental increase in globulin with a 5 to 10% fall in the GFR, persistent, comfortable. So if this pattern is there, I'm very sure that it is myeloma in the future. So this is like a prediction. So how did this hypothesis got formed? By the past experience. That is, stats taught me how to think the future. That is exactly what we did. Then comes to the NASH prediction, non-alcoholic steatohepatitis. People are worried that the future This is the most common cause of the death, non-communicable deaths. If you see TIBC, AST and bile flow, then I can say that it is 10 times more cases which are otherwise missed can be detected 6 years ahead. That's the beauty of this. Simple 2 tests which we do every day and day out. Okay. Then a leftist we did. We have, there is something called lift. What is the meaning of lift? That means the probability of that happening in that particular population is X many times. That's called lift. Right? So these are the different words. We use p-value in statistics. We use confidence in the AI language. We use relative risk there and we use lift here. So they are all very same. One is past and there is future. It's just like English. So that had happened, that is likely to happen sort of thing. Right? So there's only difference in the language, that's it. And renal prognosis, how fast kidney is going to fail, we are damn accurate. So this is what is our first set of things we did in 2014, 13-14. Right. And then comes our bosses, that is gynecologists and obstetricians. They jumped in. They told, okay, you are doing something in the lab because your wife is pathologist. Why don't you do something for us? Okay, we sat together, started churning the data, whatever data we have. We found that we developed something called, this is a laboratory one, and this is called MIHIC. So 46 risk factors were given to us. That is a challenge for we have accepted. Out of which 18 risk factors, starting from the postpartum hemorrhage to the eclampsia to the gestational diabetes, we can precisely tell at what point, not in second pregnancy, I'm talking about primaries, when and what is going to happen. This is called modeling, and it's called Shapley modeling. What is a Shapley modeling? I explain. Because of GRBs of 88 and because of obesity, the woman is likely to develop at 32 weeks pedal edema. So I tell what is the reason. We call it explainable AI, but the type of explainable AI which we use is called Shapley. So we give the 16 scores for children, 19 scores for mother were validated and the data of close to 10,000 pregnancies across the globe, not only in India, right? So few of our partners settled across the globe also. And this is not what I'm just telling. This has been, thank you. This has been published in Nature as well as in the Frontiers Gynecology. So we are confident that the quality of the work we did is thing. And very important, most of our researchers don't do is we have to patent it. Okay, it is not that we want to monetize it, but no one should tomorrow sue you for your work. अपना काम किया, दूसरे ने पेटेंट कर लिया, हमको दोबारा उल्टा डांट दिया. It should not happen. So these are the three things. One is innovate, publish, and patent. All three are important for us. Right? Then comes our pulmonary colleagues who came. Boss unko to kar diya, and he was one of my very close friends who practiced with me for 14 years. And he told, okay, what is there in for us? Okay, again, we went back to the data. There is something called HbA1c. सब लोग को मालूम है. So any chronic disease require a long-term marker. 3 months average जो बोलते हैं. What is there for COPD? Again, a big problem. There is nothing. We use scores, and you cannot treat chronic disease based upon the snapshot value or given value. So average control की जरूरत है. We came up with this particular machine, which is going to take 6 markers, starting from the ability for the bronchi to dilate, that is fractional excretion of nitrous oxide and volatile organic compounds. There are some things. We consider 200, out of which AI told that these are the 6 things which are important. And the score is damn accurate. Okay, so if you use this score, the COPD control in the last 3 months can be perfectly deciphered. No doubts. That's what we did. So 2026, we got our patent granted very recently. So again, I always tell this. So innovate, prove, publish, and patent. So this is the mantra for all the young scientists who are sitting in this room. So this is what is the formula. That is change in the previous values, COPD score, pH, carbon monoxide, FeNO2, volatile organic compounds. For those who are interested, slides are available. This is something which is public now, right? Then games, okay. Is there a possibility of clicking this? If I click, can you just click this and then just एक icon है ना यहाँ पे, उसको click करके, can you just publish it? One window will pop up. नहीं वो आगे जा रहा है, उसको पूरा कम करके करना पड़ता है. Not this one, sir. Just go back. Go back. उसको minimize कर लीजिए. Slide show से पीछे आके कर सकते हैं. You can do. Just minimize from this slideshow. Try to open it again. Not that one. Okay, it's not coming. But what we did is, I mean, at some point of time, if you can just get it. So the moment you upload the prescription, it will tell which type of food is going to be there. So सुबह 6 बजे पे pantoprazole लेना है, 6:30 high fat meal लेना है, 7 o'clock पे ये वाला tablet लेना है, drug interactions including pharmacogenomic events. And the entire thing costed is only 4,000 rupees, including genomic testing. Right? It's not expensive. So all important drugs have been churned out, and just upload your prescription. It will tell. It is called scheduler. I want to show you probably once the presentation is over. I'll just try, if I have some time, I'll just do that. And again, I came into the jump. अच्छा 3 लोगों के लिए कर लिया, मैं क्या करूँगा? So that is my core is oncology, right? So what we did is, if you give any radiation to any organ, I can precisely tell at what point of time, what intensity of complication happen. Especially our work is on cervical cancer for the bladder, cystitis and proctitis, and head and neck cancers for the dry mouth and other things. So we're very accurate because these are the two things. Cancer gets cured, people suffer for life. You know, that's something which we don't want. So there is a scientific basis, because when there is a fat, it causes inflammation, and that inflammation is going to be perpetual, and that will never heal, sort of thing. So we try to ensure that the radiation planning is optimized. Again, the same thing, 2023, we got our patent granted for this. Then comes detecting the febrile neutropenia using the pulse rate variability, ICU. So there are too many things. Then we did elderly care, geriatric. Vasant Kumar Sinha, he is my colleague who is working with that. So we detected fall using a very simple thing. We use triphasic accelerometer. So when you stand, you have 3 axes. When you want to sit down, you'll be sitting and then sleep, right? It will take 5 to 6 seconds for you to lie down from standing position. But if it happens in 2 seconds, you fell down. So simple, any gyro, that is watches and rings that you have, fall can be detected 100% accurately. But not all falls are important. You know, every vertebrate will stand up after 20 seconds. But if you're not standing, that is called significant fall. So that is the second rule we built. Third rule is, if it is associated with heart rate variability, that means your sympathetic system is not doing well, and there is a BP that will be mapped, sugars which will be mapped. Finally, I tell why fall happened, how soon I need to address. So this is what we did for our geriatric colleagues. So fall detection, fall inferences. So these are the works which we did for the things. And finally came the fight between cardiology and oncology, right? So this is where the entire story started. So there are 3 young patients over a period of 1.5 years. Every time one chemotherapy drug called adriamycin was blamed for the sudden cardiac death in a otherwise normal lady. We are not happy. I told you adriamycin cannot cause heart attacks. It can cause cardiomyopathy. So people slowly die. It cannot cause acute MIs. So we used to fight with them. Finally, we started reading them. This is what is staring in all those 3 women. Breast arterial calcification. This is other woman. This is the another woman. 3 scans. So the calcification that is happening in the intimal layer. So, you know, internal mammary have very similar caliber and characters compared to the coronaries. So if it is happening here, it must be happening in the coronaries also. So we took up this project and we started doing the first visual findings. We saw it. Then we sat together with the radiologist and cardiologist, and then we did the literature review. We thought, okay, let's try to focus on how to develop this. So we know that CVA and breast cancer share a lot of risk factors, starting from obesity to the dyslipidemias. So we started pulling up the CT scans, mammograms, and then started developing a layer and then started giving a score to it. Right? So these are the factors which were considered. So calcification can be very non-specific. Everyone accepts it. So local versus extensive, diffuse versus punctate, micro versus macro, regular and irregular, vascular versus parenchymal, patchy versus uniform, skip versus irregular. So we have considered total 600 characters of a calcification, out of which 25 were found to be significant, which are predicting whether it is secondary to inflammation, intimal, whether it is going to have a vascular implication. So this is how we decoded the calcification which we found in the mammograms. And we started pulling up the data and we started using some of the AI algorithms. I don't want to teach you about that, but I want to tell you how clinician thinks. भाई मलेरिया के सीजन पे बुखार आएगा तो हम क्या सोचेंगे, ये भी मलेरिया है. Probably it is right. Okay, that is called KNN. KNN means अगर 10 diagnosis एक तरफ से जा रहा है, 11 का symptom भी वही है, so put it there. Mostly right, 80-90%. तो calcification का भी हमने वही रूल्स किया. So it's called K nearest neighbor. Nearest neighbor मतलब 10 मलेरिया के केस में 11वां बुखार भी मलेरिया होता है. Right? If it is from the Kala Azar prone region, put it in that bucket. So that is called, we take the distances and average. Then we call it decision tree. उसके बाद क्या करते हैं, कितना दिन से बुखार है, do you have the urinary symptoms, like that we ask, right? Same questions we ask in the mammogram also. Elderly, dyslipidemia, same questions. Only thing, questions are different, pattern is same, how we think. This is how we finally could automatically draw those drawings using the basic 2 rules. We are not happy with it. Then we started going for the CNN. What does CNN means? How to differentiate between a cat and a dog? So starting from the ears, tail and eyes, there are some patterns which your brain will start thinking, and we started building those layers. तो उसके बाद क्या किया था? And I started drawing those lines which were called hyperplanes. These are 3-dimensional planes. And finally, इस तरह से आ गया. This particular calcification in this is giving me a suspicion that it is likely to have a coronary block. And you know our accuracy, 98%. Our ability to confirm. And whenever we say something, we are 100%. So that's why, that's what actually our final breast artery calcification. So mammogram to वही है. The outcomes are entirely different, right? So we took these genetic layers to reach that 100% accuracy for the vascular health. This is for these genes are for the cancer risk, and this is the biochemistry layer 1, biochemistry layer 2, and we use something called Monte Carlo. Monte Carlo means multiple predictions using the same data. That is called Monte Carlo predictions, right? So finally, these are the scores. So, and all including, we proved it using the angios and other things. So what we could predict: cardiac, neural, renovascular, retinal, we are good. Remaining all, we are bad. We admit that we couldn't predict liver, bone and other things. We failed, but we succeeded in first 4. And malignant characters were damn good, and other systems also were very good. Right? So this is when it started, 2013, as I told you. It's a prospective cohort study, right? It's not like something random study. And obviously we have to patent, and cost reduction is there. These are all the publications around it. So whatever we have published. So I just, on time, thank God. Right. So just want to tell that if you have a structured question and a decent data and a proper plan, AI can have a lot of potential and it will throw lot many opportunities to you than what you can think in life. So that's how I conclude. And any questions, please feel free.
Yeah, it's open to the house. Any questions? I have a point that if you give the like just calcium, coronary artery calcium scoring, it's a very simple test anywhere in city, it can be done. So for it's only applicable to women.
Correct, sir.
Right. So
Men we don't solve.
so coronary artery calcium scoring is a very simple tool where we can definitely rule out the cannot rule out, but we can say definitely if it is positive, then you are having something and we have to intensify the treatment.
Correct.
So similarly, whether we have the algorithm that we can say that the coronaries are
Healthy or not. Perfect, sir. So in women, I need not do any CT angio. Mammo is enough for me. एक मैमो कर लो, आप कैंसर का भी रिस्क बोल दोगे, हार्ट का भी रिस्क बोल दोगे.
It's a very simple tool.
Yes, sir. Please.
It is always great to see our seniors coming back to our institute. And we are like very happy to see a senior like this coming to this platform. Sir, like you must be knowing the environment in which we are working in our institute. So the patient load and other things and other technical problems also, logistic issues also. So what's your tips for the clinicians who are here? So how to incorporate the AI in our healthcare system? Tips like
Actually, tell you, sir, mobile में notification bar आते हैं ना. So like that, so there is always a notification bar which is there on my computer. So everything runs in behind. I don't want to go there and then do the job. So, sir, 5 लाख का तनख्वाह आते हैं, 1 लाख दूसरे को दे देता हूँ काम करने के लिए. So वो काम बैठ के करते हैं and pop-ups. I keep on training them how to do the filters and the key pop-ups are taken into consideration. So you need to invest your couple of years to make your long-term life happier. मतलब जैसे बोलते हैं sharpen your knife before you cut. So that is going to save the time in the long run. वही करते हैं, we spend time. It's not very difficult. So have a nice pop-up which is going to ease your journey. There is something called Dr. Anna. आप बात कर लो, पूरा history वो अपने आप खुद लिख देती है.
So is any platform which you suggest?
Dr. Anna is one thing.
Dr. Anna.
There are My3 is there, developed by AAG. Multiple are available.
Okay.
So 2 things I told, but I don't want to promote either of them. But I'm comfortable with them, sir. So there are 3-4 things are there, imaging and other things. Yes, sir.
Boss, you are a medical oncologist.
Yes, sir.
I want to ask you one question. Whether AI can decide the end of life decision or we have to make the opinion of both AI and consultant both.
Consultant is the only guy who can make this decision, sir. AI is going to, as I told you, predictions. जैसे बोलते हैं ज्योतिष के पास जाते हैं, so बोलेंगे भाई आपका 4 साल के बाद बहुत अच्छा होगा नहीं तो बहुत खराब होगा. Same thing, AI is not different from that astrologer, right? So thing is, it's having more scientific and more data points to do that. End of life is a very clinical decision based upon the performance status. So I don't think AI can do assessment other than the labs and other things. Physical assessment, we always will do that, sir.
Okay.
Sir.
Any comments, questions? Sir.
Yes, sir. I don't go for the black box at all. If at all AI engineer tells, I told, come on boss, go back, work out, come back with me sharply or something. I always want a explainable AI because we are not there yet, sir. We are clinicians, basic, पूरा एकदम evidence चाहिए हम कैसे आ गया करके.
And what do you do about the external temporal validation for your studies?
We do that, sir. We have, as I told you, we have 25 collaborators, all clinicians working across in combination with few of the technology leaders. And so there are a few things which we do internally, that is 80-20 rule and other things. Yeah. But externally also, we always do it before we just roll out those projects.
Okay.
Yes, sir.
Thank you. Boss, one more question. How can we make AI more acceptable and
कैल्शियम स्कोर है, वहां पे भी लिपिड देख रहा हूँ, यहाँ पे भी लिपिड देख रहा हूँ. At least you have a chance to hear to me and accept. So it has to be explainable to start with. Black box, next step, sir. I mean, we are not comfortable. I'm not telling it is wrong. Some black box is like a gut feeling. भाई ऐसे लगेगा करके seniors बताते हैं ना. Black box is like that. There is no reason, but it works sometimes.
So thank you, Suresh, for explaining the complicated things in a simple way.
Thank you, sir.
And over to organizer.
I extend my heartfelt thanks to the speaker for such a thought-provoking session. I would also like to thank our respected chairpersons. I would request them to kindly proceed to the selfie point for the felicitation of the speaker. I would request our speaker to move to the selfie point for the felicitation.
Moving on to the next session of the scientific program, I am deeply honored to invite our distinguished chairpersons for this session. I respectfully invite Professor R.B. Singh Sir, Professor, Department of Anesthesiology, IMS BHU, Professor Rajiv Kumar Dubey Sir, Professor, Department of Anesthesiology, IMS BHU, Professor Manasvi Chaube Ma'am, Professor, Department of General Medicine, IMS BHU, to kindly grace the dais. I request our chairpersons to commence this session and introduce our speakers.
The topic. This is the topic.
So, good evening to all of you. So now we are going to have our next talk, and that is on role of AI in the critical care. I think this is the most awaited talk which we all want to hear. And for this, I would request our speaker, Dr. Sandesh Kumar KJ. Sandesh Kumar KJ sir to be here. He's the head of the Smart ICU, lead clinical AI consultant intensivist, and is a Cloud Physician Healthcare Private Limited affiliated to. And his areas of interest is in AI in healthcare, healthcare technology, and the mechanical ventilation. Over to you, sir. Thank you.
Thank you. Thank you so much. Thanks for the warm introduction, and thanks the organizer for giving us an opportunity to present on this topic. So just a little bit of background on what I do every day and how we use AI in our day-to-day practice. So I come from an organization called Cloud Physician Healthcare. We manage ICUs remotely. We are currently working with nearly 200 ICUs across the country. We are present in more than 20 states, and we have built our own technology platform to do this. Since the last 2 years or so, ever since we heard the possibility of what technology can do, the AI, the so-called AI boom that happened, we also ventured a bit of whatever we do, including the technology, and that helped us a lot in managing our patients better. So some of the initial slides that I'm going to cover is based on our own experience. So all of us are familiar with this scenario. We have a 58-year-old patient who has just come from theaters. Patient is a case of CA head of pancreas, had undergone a long surgery, 6 hours long surgery. Patient has a background of diabetes and hypertension, and he's there. You have received, of course, longer duration of surgery means that the patient comes to the unit out of hours, and you don't have all the senior faculty or senior consultants who are supposed to be there, and most of them are or on the way of going out. So you receive the patient, you kind of stabilize the initial period, and then couple of hours later the patient starts to look a bit off. You exactly cannot pinpoint what actually is happening. So the breathing pattern looks a bit off. The resident starts to become concerned. What's actually happening, right? So, in this scenario, what typically happens is the resident is overwhelmed with data. There is so much data that is coming, hardly vital, parameters that are coming. There is availability of EBG, there is lab results that is coming. So what do you need to do? Now, if there was a consultant, probably they would have thought, okay, is this patient now hypovolemic? Is there a lot of blood loss? Is that the reason why patient is hypotensive? This is a Whipple surgery, long surgery. Is it sepsis, right? So patient could be in sepsis and it could be septic shock, right? Or patient has significant comorbid disease. Patient is diabetic, patient is hypertensive. So is there an MI, perioperative MI that has happened? So all of this would mean you have to come to a specific diagnosis of what is causing the problem. Because if you suspect that this patient is hypovolemic and rush him with 2 liters of fluid, if there is an MI, patient will go into hypoxia, right? So you need to make decisions faster. So you do not have a lot of time. And I often face this problem, right? So all of my hospitals, which are present in remote areas where they operate these complex surgeries, so they'll come with this. Unfortunately, I do not have a trained intensivist at bedside who can do a POCUS scan, right? So the day we are in today, so there are a lot of these equipments now which are capable of giving you exactly the information that you need. So if there was a consultant available at bedside, a trained intensivist, he would have just done a POCUS scan, point of care ultrasound scan, to assess the fluid status of the patient, to know the cardiac status, and also to know whether the lungs are already flooded or not. A very quick 5-minute simple scan would have given the information, but unfortunately we may not have the trained manpower at all of our intensive care units. Now, if you look at today, how does this happen? So that's where the AI point of care ultrasound comes into picture. So now today, AI can actually tell you how to even do the scan. Because as we all know, ultrasound is something which is completely operator dependent. And today I face this problem, even though I'm guiding them up, probe ko aise point karo, probe ko aise point karo, they're not able to, figure out where exactly to point out. What I'm saying, I'm not able to translate into an action that the people at bedside can follow. Now, the instructions can be given by the bedside. It can exactly tell you, go one rib below. Now do this point, this much degree angle. So the entire technology has come into a picture where this is a study that got published. Within just 2 hours of training, any non-ultrasound trained user can actually acquire a good image. And also the technology is going to help you interpret those images, not just acquisition of the images. It is also going to help you interpret that image from assessing whether a patient has more fluid, whether there are more A lines, whether there are more B lines, to making an assessment of what is the patient's velocity time integral. So what is the collapsibility of the IVC, right? So you can also look at the hepatic and Doppler waveforms to understand whether there is hepatic congestion. So will this patient tolerate more fluids? While the patient may respond to fluids, what happens if I give more fluids to this patient? Will he going to tolerate 3 hours later? So all of this information is available now for the same non-trained individual if you have right technology at bedside. And we are at stage now. So we can use computer vision, automated biometry, pattern recognition, and waveform analysis to make that critical decision of, should I give fluids? Should I start vasopressors? Should I give this patient antibiotics at the same time? So all of these critical decisions, which a resident would be struggling to make, can be made easily today with the help of ultrasonography, right? So now moving on to the next, computer vision. We often hear, about computer vision. So this is how human beings interpret data, right? So all of us know, in kids, when the kids are developing, they suddenly won't identify an apple as an apple, an orange as an apple, right? So they all of them are some round objects, but over a period of time, they learn, okay, this is apple. So there are distinct features of apple, oranges. So they'll be able to identify this. Similarly, similar to how human eye receives the data and how human brain interprets the data. So in computer vision, we also can look at the same thing. The cameras that we have, so we build a lot of our technology using computer vision because we are dependent on the camera. So we have hours of videos that we are using every single day, and we have built some of the technology tools based on this. So the camera is the eye, and the computer, the software that we build, is the interpreter of the data. So with that, we can do the same thing how human eye works. So some of the examples that we have, can you click? So we have autonomous patient safety in action now. So this is one of our models. You can see this patient, actually just by the look of it, you can say that this patient is in respiratory distress, right? So how does a human mind, identify that this patient is sick by just the look of it? So sometimes, when you enter the room, even without actually counting the respiratory rate, even without looking at the patient's respiratory, alley or additional respiratory muscles in action, you will be able to identify that this patient is in respiratory distress. The way you identify that is by pattern recognition. Over a period of time, you repeatedly look at the same thing over and over again, and that's how you recognize that this patient has respiratory distress. So if a human eye can do that, so we have built technology which can actually do that in the same pattern. So now we have this tool which actually can recognize that this patient has respiratory distress and can flag in a very busy unit that the patient has respiratory distress. You should go and look at that patient. So it can send alerts to you on your phone, on whichever system that you are, platform you are, and it can help manage patients better. So not just this. So let's imagine a scenario that routinely happens in the ICU. So we have very common stuff. We all know how important it is to have hand hygiene compliance in the unit, right? But how many times does it happen, right? Even if I make an infection control nurse sit in the unit in front of the who does the repetitive task, and a nurse might access a central or endotracheal tube 15, 20 times, and we don't know. And there are multiple people entering and doing the same thing. But the tool that we have will not get bored. The only task of that is to know whether are the team members following what they are supposed to do. So these are some of the things that happen routinely, repetitively, and this is monotonous. The second common example is pressure sores. It's so often that we see patients developing pressure sore, and it simply happens because the team did not think that it is important for us to change the position of the patient, right? So if I can identify the position of the patient, that this patient's position has not been changed for a couple of hours, I can flag that as an alert and say, okay, this is time for you to go back. Because oftentimes nurses are busy doing monitoring, doing hemodynamic adjustments or documenting. A lot of the times these mundane tasks taken out for a task, but that's the most important task for the patient. So we can automate that now, where even if you're not monitoring the patient continuously, we'll get to know exactly that this patient position, when was it turned, is the patient position turned appropriately or not. We can track that, and the technology is able to do that. It can sense, it can think, and it can act even by documenting that this patient's position was this at this point in time, and this is what the change has been. So that's the technology that we have, and all of this is possible because of the computer vision. So what would all of this mean? It means that we have proactive care to the patient, and we can also do this with integration of not just computer vision, we can also integrate with the electronic health record data. So for example, in the case of the same pressure sore, what was this patient's albumin levels, right? What was the story of the patient before he came? Was this patient on vasopressor? Which again predisposes these patients to develop pressure sores. So we can combine all of that data and flag these patients at highest risk of developing pressure sore, and maybe we need to monitor these patients for change in position more often than not. So this is some of the work that we do routinely, and there is a lot the healthcare AI, especially in critical care world, has moved. So what are those some of the examples? Some of the high impact use cases are early warning of sepsis. Again, going back to the scenario that I mentioned, there are tons of data that is coming from every way possible, right? So you need to interpret that data and make that impression of what actually is happening. So now we have validated scores which depend on AI, which interpret the data and actually tell you even several hours before the event actually happened. Before a human can predict that this patient has sepsis, the algorithms can give you early alerts so that you can initiate timely treatment like fluids and antibiotics so that the patient's outcomes are better. So University of California and San Diego has developed this deep ACE. So this is a algorithm that predicts the patient's onset of sepsis hours before. And so like our earlier speaker explained, often the fear for clinicians is, I don't know why the system flagged this as sepsis. As long as you do not explain the reason why the system is flagging as sepsis, you will not trust it. It should not be a black box. So now there is Shapley's index. There are various ways you can explain why the algorithm recommended this patients to have sepsis or not. So that the clinician's trust is also taken into consideration. So there are several others. Recently, one of the biggest electronic health record players in the US, they also released their own scoring system, Epic scoring system, to identify sepsis early. And these are not just research tools anymore. So back in the day, they were just research tools. They were not applicable in real world. But today, all of these tools are FDA approved. A lot of these tools are FDA approved. And gone are the days when we think about, okay, this is something that may not be applicable for us. So we actually need to be thinking all of this happening in the Western world. How can I do that in India? And that's where I think all of our big institutes, the AIMS, the BHUs, all of these institutes should have our own data, because we see tons of patients and much higher volume than what typical Western world sees. We should have our own scoring systems. We should have our own approval systems of what these scoring systems are. And that's where we should be heading. So some other data on ventilation and ERDS care, again, can predict extubation failure, or patients who can develop ERDS in future. And again, support ventilator lung supportive strategies. For example, very simple things. If you continuously monitor the data of the ventilator, all of this data is numerical. It's already sitting in the ventilator. All we need to do is build an algorithm that tells you that this patient's tidal volumes or the mechanical work that the patient is doing is going above. Now this patient is at risk of developing ERDS if you do not intervene, right? So if you take into account the goals of mechanical ventilation, if there is a patient who is at risk of developing ERDS, safety becomes a priority, and maybe this patient needs more paralysis and sedation, and not let the patient generate huge volumes which predispose the patient to develop volume trauma, right? So similarly, one of the most common things that we always ignore is about the physician and the nurse who is there at the bedside. And all of us can relate. Uh, in the name of quality, at least, a lot of us have moved nurses away from the patient. And what do the nurse do? They're reassure ourselves saying that, okay, this task will get done. And in turn, what they have done is they've moved all of the nurses away from patients, and they are busy documenting. They are either in front of paper or in front of a system. And the patient doesn't care. A patient who is coming to the ICU wants somebody at bedside to hear them, want them for emotional support. And that's what us as caregivers should be focusing more on, and not on documentation. So there are so many of these tools that we have now which can automate your documentation. So we have some of our own tools which can automate your daily notes, which can automate your daily discharge summary generation, because many of our residents probably can vouch for this. It takes an hour for sometimes for some of these long stay patients to generate a discharge summary. When the data already exists within the system, why do I need to go back and just do the summarization? So it's not what a resident should be trained for. The systems can do that better, way better than what I can do for, right? So we need to use those systems. And in turn, what all of this does is probably they can train better. So they should be focusing more on what really matters to them in the training. In the same way, if you move away all of this documentation time away from the computers and the papers to the patient, that's what the patients would want, right? So that would add more efficiency and more holistic approach for the patients and family. So there is a lot of evidence. All of the evidence says that there is significant evidence mounting saying that yes, it indeed helps save lives, mortality benefits. You can see for early success prediction, the area under receiver operative curve is 0.8 to 0.9, and some of these tools are FDA approved. And this is when it gets through FDA approval, they are treated in the same way as you treat medications. So if a drug needs to get FDA approval, it goes through a rigorous process. So for some of these algorithms, they go through the same rigorous process. So some of these are already available. And of course, all of this tool would not mean anything if you do not take into account the workflow integration. So how does this fit into my workflow today? How can I use this tool to the workflow that I have done today? Where should the alert go to? Who should the alert go to? If I make the alert go to somebody else who may not act on it, then it's of no use. So that's where the clinicians come into picture. So if you actually shy away from all of this and there is some engineer who will come and do all of this and do not take part in it, you won't know where the workflow integration will happen. And that's why more and more clinicians should take part in this, take part in the development of the tools, give active feedback for the engineers, and also make the tools better. Again, as I said, you should know right alarms should come to the right person, because today we already have alarms, monitor alarms, ventilator alarms, but you know what happens? Everybody will go and silence them. Everybody invariably, if you go to ICU, all alarms, either they are just blaring and everybody is ignoring, they have developed deafness to those alarms, or they'll invariably go and mute them. Or they set the thresholds to such an extent that the alarm will never come, right? So all of this should be, because otherwise tool will become again waste, right? So of course, these are all the good things. There should also be pitfalls or the safeguards that we need to look at. Bias is something that we all need to look at. Again, if the data is entirely tied on Western population, then it may not be applicable for our population. So if there is no specific, let's say all the algorithms were developed only on male patients, and then I have a female patient, the algorithm may not work. So all of these inherent biases exist in the system, and when we are building the models, you should look at it and you should know what these biases are. Alert fatigue, I already spoke about. Black box risk, again, the clinician should know exactly why the alarm triggered, what it triggered, and it should always be part of your workflow. If it's not fitting in your workflow, then the tool may be very good, maybe very expensive, you've invested crores in it, but it may become just some black box lying out there and nobody will use it. Of course, we also need to look into the ethics, data quality, privacy, and we all have so Ministry of Health and Family Welfare and the Government of India has done very good initiatives. The DPDP Act, all the healthcare frameworks that we have are there to take care of some of those governance as well. So if the same patient had access to AI tools, the patient would have been better, going out safely out of the ICU, and that's what we should all be looking forward to. So that's the end of my presentation. Thank you so much.
Thank you, Dr. Sandesh, for such an elaborative talk on role of AI in critical care. So the house is open for discussion. If there are any questions, we can ask Dr. Sandesh.
Hello, I am Dr. Uma Shankar Gupta, MBBS MD. I am working over here, Heritage Institute of Medical Sciences, Batwar, Varanasi. Cloud physician is a very new concept in India, you know? And I actually know this because I have done courses from ISB Hyderabad, and it's a case study kind of thing.
Yeah,
right. And please elaborate just a little bit about the radar and how your system actually works.
Okay. So maybe I think Dr. R.K. Singh sir is here. We are actually one of our platform is being used extensively at the tele ICU that yeah. So sir will elaborate about radar in his talk probably in the next session itself. So basically what we have is an electronic medical record. There are three basic components for how we work. The first basic component is the electronic medical record, where you actually have the same data as a clinician who walks into the unit. And the second is ability to see the patients. And we have high definition panel zoom capable cameras through which I can get actually better view than even a physician who's there inside the unit. So I can see the ventilator, I can see how the patient is. Is the patient restless? Is the patient irritable? Is the patient sedated? So whatever you would see at the foot end of the bed, making an assessment without touching the patient, I can do the same kind of assessment. And we have collaborative tools where I'll be in discussion with the bedside 24/7. So these can be Google Meet, it could be Zoom, it could be Google, Teams, any of the audiovisual tools that we have, we can work with them and we Yeah, so for the question, for the respiratory distress scenario that we said, so what we do is we collect data. So we collect data of patients. One, when the patient is in respiratory distress, and a physician will identify that as respiratory distress. They'll tag. And we also have the same patient when the patient does not have respiratory distress. And we'll tag again to say that this patient does not have respiratory distress. So we have hours and hours of data where a clinician is actually tagging, and a clinician is also tagging when the patient has no respiratory distress. Okay. And the model can learn. The model, just like how I showed, can identify oranges, apples, and bananas. The model can also identify that this patient has a respiratory distress and no respiratory distress. And actually, it's based on the heat map. Yes. So when you do that, what we actually do is we put a heat map on the patient's thorax, and it will actually identify the depth of breathing. So the heat map will tell you that this patient's breathing is faster, deeper, and that will be identified by the model. The model is actually getting trained on the heat map, identifying the movement of your diaphragm. So that's what the model is looking. So that's how we do the training.
So thank you, sir. So before moving to the next talk, it's just a small query. Where we stand medico-legally for this concept? For if someone dies off, then can we just justify that we have monitored it through this app and these tools, and it is going to stand in medico-legally for the patient and for the doctor?
The rule of the law is
Yeah.
Adverse event occurs.
Yeah.
The rule of the law is it's always the clinician who takes the ownership of the patient, and the tool is not telling you that you do this. The tool will tell you, highlight you that this patient most likely has respiratory distress because of these reasons. Okay, so it will not tell you what to do after respiratory distress got identified. So it will tell you that this patient has respiratory distress. The next action is based on the clinician identifying it. And also for some of the sepsis tools, the sepsis tools will tell you that this patient has highest probability of sepsis sooner than you would have done otherwise. Right. So for example, we can do the same thing today. What is the trust that we have that the monitor is saying the blood pressure reading that it says as accurate? We don't know that, right? We just trust what it is showing, and I act based on what information that I'm gleaning on. So it's the same way. The responsibility is still with the clinician. It's not going to take away the responsibility. You will make better decision than what you would have otherwise been. And that's the reason why before this tool gets implemented, you need to look at that. That's the reason why we said that the safeguards should be before you actually implement the tool. So you should know exactly what should I do, at what level should I intervene and take next course of action.
So thank you, sir. Thanks for this elusive talk. So I think we will have the next talk now.
Thank you so much.
So, so over to you.
So now I invite Professor Dr. R.K. Singh, sir. He is the professor and head of the Department of Emergency Medicine at SGPGI Lucknow. He has been the nodal officer of tele-ICU and during the COVID times also. He did his MBBS from internal medicine from this institute only, and he did his senior agency and postdoctoral certificate course in critical care from SGPGI IMS Lucknow. He has more than 125 publications nationally and internationally. He is a reviewer of many journals and member of many societies and a very eminent speaker of Indian Society of Critical Care Medicine. So I invite Professor R.K. Singh, sir, for his talk on SGPGI experience, SGPGI tele ICU experience. Over to you, sir.
Thank you. Thank you, Chair. Thank you, my alma mater, for the invite. And thank you, Bikram, for the kind words and the invitation that was sent to me. I'm here to share the experience of the tele ICU experience that we have been running since more than 1.5 years now. And I must thank Sandesh was there previously. Yes, Sandesh was there. So he's been partnering, or I've been partnering with him and his cloud physicians to roll out the program of tele-ICU service at my place at SGPGI. So I'm just sharing you my experience, how it is being built and how the next level where we want to go. So the need is there. Yes, the ICU doctors are very less and we need more of them. Unfortunately, we have more ICUs coming up. We don't have intensivists looking after these. And this was starkly felt during the COVID-19 period when there were more ICUs creeping up, but we had nobody to man these ICUs. And therefore, the need was obviously there. And tele-ICUs can help you bridge this gap faster, can help you provide and improve care in remoter ICUs, can help you prevent risky and unsafe ICU transfers, can help capacity building of these remote ICUs, which are manned by untrained or less trained people would be the right word. So you have two teams. One is an on-site team, one is an off-site team. They try and interact with each other with the help of audio-visual cloud internet. And this is how it plays out. So we were happy to be initiated this program with the help of Power Grid, who funded the entire project for 17 crore rupees. So this is a huge investment which has gone into building this setup, and therefore money is required. I can see my director, I can see the Honorable CM who was pushing the bandwagon, and we have a lot of support from the ministry for this program and the initiative. So I'm thankful to all of them. Now, this is a tele-ICU setup that we have done. We have done it for 6 medical colleges of Gorakhpur, Prayagraj, Jhansi, Kanpur, Meerut, and Agra. And we have connected ourselves to these 6 ICUs only to the intensive care units through this cloud facility of internet and connectivity. Plus, we have pulmonary ICU beds at my place and the emergency beds also connected into this setup. So we have created a 100 ICU pilot study for initiating this service just after the COVID-19 outbreak subsided. So this proposal was meted with a lot of excitement, and there was a lot of pressure on us to run it. So how it runs is that you have a hardware, you have softwares, and you have manpower. You need two people to tango. So the on-site team needs to tango with the off-site team. Unless and until these two teams interact cordially with each other, nobody is a big brother in this. Everybody is collaborating. I'm not dictating anything to you. I'm suggesting some things to you. You want to take it for the best of your patient, please take it. If you don't take it, I will put it on the advisory that I did suggest the local team did not take. The responsibility lies actually with the local team, because I advise, I'm only advising, but the team who is implementing is the local team. So all the onus of responsibility goes actually onto the local team. If I advise a dialysis and you don't do a dialysis, then the onus is on you. Okay. But somehow or the other, the facilities are not apt at many places. Like for instance, I want HIS. I have HIS at my place. Some of these places do not have HIS at a level which SGPGI has. So that's a stark reality. So there are certain deficiencies in the system. But yes, two people can still tango. You communicate on WhatsApp videos and whatnot. You can still communicate with high-end technology with each other. So this is the radar software that we were talking of. One of the persons from the audience was wanting to know what it is. So this is how the infrastructure is laid out. This is the IOMT structure of application layer of radar. It is built onto monitors giving information, ventilators giving information, infusion pumps giving information. There is an IoT device which is integrating all this information. And through this perceptual layer, there is another network layer by the Cisco and these are high-end network switches, very costly at the end of the day. And then there is an application layer applied by the radar. So all these layers, when they work together, then you have the tele-ICU setup. So this is the expertise that was brought on by the cloud physician team from Bangalore. They run almost like 2,500 ICU beds in the country and outside the country. And I'm very happy to be partnering with them because they have given their expertise to us to run the show. And we have been successfully running this for last 1.5 years. So these are the devices which I told you. They interact, they integrate. But if you have a great HIS, all the ICUs have HIS. And if you can connect all these HIS systems onto a unified platform, that will be fantastic. And that is where AI can come in, and AI can help you warn, can signal you alerts, can tell you even much ahead when the deterioration happens in a patient. It will be alert when your ICU people are sleeping. So the AI will be awake. It will sound you if not to the on-site team, it can sound to you the off-site team, and the off-site team can sound on to the on-site team. So it's a network. It can be, so AI into this picture with a great HIS and a unified platform can work for much larger number of patients and in a much better way. So that is where technology is going, and that is where telemedicine and tele-ICU setups are going for the future. So this is the service. So we have our own tele-ICU. I'll show you the real pictures. Yeah, this is the hub that we have at our place. So you can see the tele-ICU hub at SGPGI. So it's a huge setup and a huge screen with individual nurse desktops and nurses manning these stations round the clock. And these are the ICUs which are connected by audio visual connect. And so when you begin something like this, don't straight away go on to, because cloud physicians will push you for 24/7, but you can't do 24/7. You probably will have to start with one time round. Then when you are comfortable with that, then start with 2 time rounds. When you are even comfortable with that, then start 3 times round. But the cloud physicians will push you for 24/7. For a country like ours and a state like ours, where all the healthcare is so fragmented. So I have HIS, but my guys at Jhansi, Kanpur, Meerut do not have HIS of that capable nature. So the best bet is have morning rounds with them, have your team on the floors at the hub site and their teams on the spoke site, and the nurses and the residents. So the maximum advantage, it is not the consultants which take the advantage, it is the residents which take the advantage. So it is the residents who are on the floor, they try and interact maximally to us. Even to my residents, they will be interacting beyond those hours and discussing case what should be done when their on-site consultants are not available for them. So this is how it goes on. It keeps on going 24/7 like that. But yes, rounding is important. Ensure that some basic discipline and decorum is maintained during the rounds of how you interact. So there is a case snippet, how you describe, summarize, interact. So for an experienced person, I've been working in intensive care for 20 years. So for me, a sick patient round means 5 minutes, at best 10 minutes. But for somebody who is new into this, it will mean 1 hour. So for an astute clinician or an experienced clinician, what I will do in 5 minutes, that person will be able to do in 1 hour. So I'm sharing my experience and knowledge to that person who is very new on the floor, that kindly do these ABCD things only. That's enough, because from our experience of 20 years, we know what works and what doesn't. So that is how you transmit the knowledge, and you bridge down the gap between what SGPGI provides in terms of critical care to what Jhansi provides in terms of critical care. So you bridge down the gap, use technology, share your knowledge, get your friends and colleagues updated to the current, because at SGPGI we are currently updated to a very high level. We want you guys to be also updated at the same level. So this is what technology is bringing you. There is an audio, there is a video, there is cameras and everything installed, but at the end of the day, it is again two people to tango, the on-site team and the off-site team. You are sharing knowledge of the patient for better care. So this is how we are doing it. This is all data monitoring that you can do. You can have ventilation graphics, IV fluids, vital trends, everything is possible. So the more upgraded your systems is, everything is possible, and you just put AI into the system. Even when you are sleeping, AI will be awake and it will help you guide out. Okay. So this is all possible. You can have it on mobile. You can have mobile rounds. If you're not available on the floor, you can do this. This is all technology available. Okay. And the perspectives. So there are perspectives of patient, there are perspectives of the provider, then there are ICU telemedicine programs, there are healthcare network issues. So all these are ambits when, if you want to go towards tele ICU, these are the things and the realms where you will have to work on to. So don't just jump, study, read, learn from others who have done it, and then jump onto this field. Okay. Because somebody will have to take the onus and the responsibility of this program. What we have done at our place is that we are still in the process of accumulating all that data. And sometimes people don't want to give data, but still we try and get that data. And I can proudly say that we have been able to bring down the mortality. I will just quote one figure. Of all the 6 ICUs that we've been working on an average, we have been able to bring down the mortality in 1 year by 20%. That's a huge number. That's a huge number. You will publish it in Lancet or in any NEGM if you want to bring down a mortality by 20%. Now, by this simple technique, we can bring down the mortality for untrained. So you are sharing knowledge, getting onto antibiotic stewardship very fast on, telling them what fluid, how much to give, what not to give, how to manage. By just doing very simple things, you can bring down the mortality by 20%. Okay. This is just an immature data which I am sharing. It is yet to be published. We are accumulating all the remaining so that we can publish it. And another clinical impact I will tell, we have already published nearly 35 to 50 publications based on our experience and the connect. Now look, I was working only in the ED ICU, okay, emergency ICU. Now I'm working with 100 of ICU patients. So because I told you, you need 2 people to tango. So how do I, because the government doesn't give you the incentive. So for me and them, the incentive is publication. These guys don't publish. We are the guys who want to publish. So we share our authorship with those fellows and tell them this is a case worth publishing. You give us some of this data, you give us the images, we will draft it, we'll put your names, and we have been able, these are 30 index publications we have made in 1 year. There are another 15 which are in line, and I'm already on course to sending one to Lancet. Okay. So this is the incentive for a government institute. Private, Sandesh has an incentive of 2,500 rupees per consultation. For me, this is my incentive of publications. Okay. Confidential information. So where is the future? So the future is, because this was a pilot study, so we showcased it to the Honorable CM. We have already showcased it to the Honorable Health Minister of the country. We have already put it online with the Niti Aayog and to the think tanks who work on the healthcare dynamics of the next 2047 targets. And we have now created the Uttar Pradesh Medical College Network. This is a 500 plus crore project that we have initiated. It has already been approved by the government of Uttar Pradesh, where we try not only connect the ICU segments, we try and connect the OPDs, we try and connect our classes to their classes, our academics to their. So this is what we are doing. So starting with the pilot of just one ICU, we are migrating to the OPDs, to the wards, to the academics, to the research, and to the innovation in our field. So we are trying to share what PGI is growing. PGI is growing towards quaternary care. We had enough of tertiary now. We are moving towards quaternary, but we want to share the knowledge what we have with rest of the medical colleges through this Uttar Pradesh Medical College Network. I'm happy to say that it is already online and the first meetings are going to be organized for this. Thank you, gentlemen, for the kind hearing. If there are any questions, I'll be happy to answer. And these are some of the people who have already visited our places. Thank you. Thank you.
Thank you, Dr. Rakesh Singh. Any question from audience? Any clarification?
There are advancements in radar as well, which Sandesh is not trying to tell you. That when the camera rotates, it rotates every 1 hour. It targets the monitors, it will target the images, it will put the graphs and the data. That means it will convert those data into digital format onto the dashboards automatically, and it can align itself to what, as he was telling, the AI component, that the patient posture is changing, the patient is about to fall, the patient is in shock, something is not going right with the infusion pumps. So all this data can get integrated onto the AI camera, AI enabled camera. It can send you warnings and alerts. And this is how things are evolving with radar. And it is a proprietary matter. That is why he did not speak about it.
Sir, kindly elaborate about the medico-legal aspect of all these things. who finally, who will be responsible?
आज भी आपके
SGP
पास आज भी आपके पास कोई सलाह लेता है तो कोई जना सलाह ले रहा है तो आप सलाह ही देते हो ना। तो जो सलाह देने वाला होता है, मेन इम्पैक्ट जो है, जो ऑन साइट टीम है, उसका होता है रिस्पॉन्सिबिलिटी by the telemedicine rules government of India which has laid down. It is still the person on the floor who is responsible for delivering the care. You as a person advising care is still at the back end. Okay, so responsibility, but you have to be wise enough to be leading the show from the point. Okay, so responsibility lies with the on-site team, squarely with the on-site team. I advise you CPR, you are not doing CPR. I advise you change of tube, you did not change the tube. I advise you 7.5, you are trying to put a 9 size tube. So any accident, so you are diverging from what was advised. Some of the advices which I advise will be compatible with what PGI has. Maybe Jhansi does not have that. So I always give my advice, whatever is available at your place. But if you have these things available as are in PGI, you will be the best person to start it. So there is always an advice. Everything advice that we give is all digitally recorded. Again, voice enabled to text conversion. So voice, so that is already available in Radar. So I speak, it translates automatically and everything goes on to the notes that are available. So this is all available on Radar. Okay. Sandesh wants to chip in.
So, I mean, I just want to advise, because this is some of the common question that we get every single time we talk about tele-ICU. So this is as simple as this. Let's say a patient comes with MI. So I am in a tertiary setup. Then the standard of care means that the patient should go to cath lab, right? So I'm in a tertiary quaternary care center. So there is everything that you monitor, door to needle time, all of those things. And the patient will go to cath lab. That's the standard of care. And that's approved, well approved by everybody. Nobody contradicts that. But I'm in a PHC, let's say, or I'm in a very small center. So so medico legally, whatever, the court of law thinks is, where was the patient? Was the best thing that we could do for the patient at that time was available, and did we do it? So if I am in a PHC, the best care probably is just giving dual antiplatelets. So the question here is, did the team interpret the ECG correctly? So based on the ECG, did we advise things correctly subsequently? So what we are doing is well within the legal frameworks that the government of India has mandated. And today, in government of India, the liability is with the admitting consultant, because I am just an advisor. Just like sir elaborately said, I am just an advisor to what it is. I may say that this patient needs, anticoagulation and thrombolysis, but the facility does not have it. So just because I documented does not make you liable because you did not give it, right? So I think that's squarely it is. As long as you do the standard of care practice, I don't think anybody should be worried about medical legal aspects.
So what the government is doing is that they are trying to frame the guidelines for how an ICU should be. So an ICU in Chhapra, Bihar, Mau cannot be different from what an ICU in Delhi is. Okay. So there are certain norms laid down by the government of India to set the standard protocols for what an ICU should contain. Probably the ICU is the best place amongst the entire setup in the hospital. So that is the best place for keeping the sickest patients. So we expect certain standards of elements automatically there in terms of the training that the person has received. That is, the intensivist is trained, the monitors are of that level, the infusion pump, the nurses. So because we are talking of medical colleges, I believe that should be there. But unfortunately, there is still a lot of gradient between what we have at SGPGI and what the rest of the medical colleges in the state of UP will have. So there is still a lot of ways to go. Technology can help you give this knowledge, but infrastructurally, you still have to up your game, because you need to have, for instance, I say many of these places, one ICU bed should have 10 infusion pumps. So if there is a 10 bed ICU, so that means there should be 100 infusion pumps. But unfortunately, when I go and see these places, there is hardly only 10 infusion pumps. So how do I deliver an antibiotic and a vasopressor and a dobutamine at the same time to 3 different patients? So that is the dichotomy. So realistically speaking, the infrastructure of all these medical college ICUs should be upped. So this is what we are bringing in to the government's notice, that these are the elements which are starkly very, very poor. You need to beef up this in terms of the infrastructure. Many of these places don't even have the X-ray, the ultrasounds, not enough residents, not enough nurses. One nurse manning 6 patients. What is this? Is not even an ICU. So there is a stark difference between what is required and what is actually there. Yes, sir. Please.
One controversial question. Why, other than Sanjay SGPGI, bigger hospital PGI, JIPMER, AIMS have not come up to 1/10 level of SGP?
I would say SGPGI is just 40 years old. PGI Chandigarh is 75 years old. AIMS is even more than that. So I don't want to compare any institute. I am fifth in rank. AIMS is number 1. PGI Chandigarh is number 2. Third is JIPMER. Fourth is CMC Vellore. We are fifth. So for a 40-year institute reaching fifth in such a short span of time, and with the things that we are about to do in terms of quaternary care, we will be amongst the first 2 in the country very soon. So why only PGI is doing it? Because my government is very pro. My honorable CM is very, very active and proactive person. And therefore, when we try and give certain vision to do something like this, for instance, the quaternary care, nobody has imagined quaternary care in this country. Now, this is a 5,000 crore project. 5,000 crore. You know how many sittings we had with the honorable CM? Only one. It was okayed in the first only.
So it depends upon
So
the
it
initiative.
depends on the leadership. Your honorable CM will be important because these are huge money projects in that. So if you have a CM like Yogi ji, why not? Why not? We are very happy to have.
Just because of paucity of time, this will be the last question.
So what I can understand, this is a very good example that you have integrated artificial intelligence with your own experience and knowledge and help other those with your knowledge. I will like to understand that how much man hours have been saved. Just because you told that is a 5,000 crore project, I will just outline that. I am from AIMS Rajkot, and the whole budget to establish the AIMS Rajkot is 1185 crores only. So say I can say that within that much project, within that much which 4 AIMS can be established. But just I want to say, have you identified how many man hours you have saved, or you have just
I have not calculated that, but the real data that is required in terms of ICU, like mortality, ventilator days, ventilator free days, vasopressor free days, we are just counting some of these data so that we can publish it. Man hours, we have not calculated. My man hours are much more than.
Exactly, sir. Wow.
I'm not even counting because I'm working on the emergency. I'm working here. I'm working in AI. I'm working in the telemedicine. So I'm not even counting the hours that I put into this. So it's okay. No issues.
So thank you, sir. Thanks a lot for your talk. So now we will move to the last talk for today's session. So this is on this is by Dr. Bikram, Dr. Ambuj Roy. So he will be joining with us online.
He will be delivering his talk on digital health in cardiometabolic disorders.
So I think the team will be lining it up.
Hello, can I be heard?
Hello, sir.
Yeah,
We are welcoming you here.
thank you so
So
much.
over to you, sir.
Yeah. I wonder how I can share my slides, although I've mailed it also there to the
So
just now.
can you just share this slide?
शशि सर का स्लाइड शेयर कर दो शेयर यहाँ से ऑपरेट कर देना
सर ने मेल किया है, you can just see that.
I'll try to do it from here too, if I can.
Yeah.
Are you able to see my slides?
Yes.
Hello?
Hello.
Hello?
Yes, sir, we are hearing you.
Can you see my slides also?
Yeah, the slides are visible to us.
Yeah, so good afternoon, everybody. First of all, thanks to the organizers for inviting me for this extremely important session on AI. It comes at a time when there is All India AI Summit is being done, and very world leaders on the AI, in the field of AI, are here. And my apologies for not making it, especially on to the auspicious city, especially on the Maha Shivratri, but due to some other thing, I couldn't join. So I'll be speaking a little away from AI because I thought we will experience, I will share some of our experiences in digital health, how we have used to improve uh, care for cardiometabolic diseases. So I'll just begin with a snapshot of how unfortunately, the care continuum currently looks like for the two most important cardiovascular risk factors, which is diabetes and hypertension. And if you see, the prevalence is extremely high. There are over 100 million people with diabetes in this country, more than 100 million people, and more than 300 million or 30 crore people with hypertension. But if you see this um, figures here, and this is taken from the NFHS 5 data, the control rates for diabetes is very poor, just about 50%. And for hypertension, it's even worse. It's just about 10 to 12%. So only 1 in 12 people with hypertension have their blood pressure controlled to less than 140/90, which is the rather older definition. If you look at the newer definition of 130/80, it would be even worse. So the way we are managing our current risk factors, and these are two leading hypertension is the number one risk factor for any among all risk factors uh, in India for causing death and disability. And obviously, we're not doing a great job currently, and we need to think differently, and we need to use technology as far as possible, not to supplant or not to replace doctors, but to supplement the health system in some ways. Look at secondary prevention. Secondary prevention means treating people who already have cardiovascular disease. So there are some drugs like, aspirins, statins, beta blockers, ACE inhibitors, are drugs which must be given to these people for secondary prevention, most of these people for secondary prevention. And because these are the people with the highest risk of having recurrent cardiovascular event. But even here, if you see in the low income countries in this pure study, 83% of whom were from India, only 1 in 5 were receiving the mandatory secondary prevention. So a lot can be done to improve these kind of headlines, which we frequently see in our media nowadays, of people dying with young of cardiovascular diseases and heart attacks, brain attacks. And so controlling risk factors is extremely crucial. But when you look at non-communicable diseases or cardiometabolic diseases, these are lifestyle diseases and many a time lifetime diseases. And you need to have lifelong approach to this management. But also, more importantly, most of them are silent diseases, right? Most of the hypertension people living with high blood pressure or hypertension do not have symptoms. So you need a more general population approach, not what is usual for a health system, like a communicable diseases where people present with symptoms. You have to go into the community, do more of disease, or I would say risk factor screening, diagnose, initiate on treatment, but not only initiate people on treatment with, for example, with hypertension, but maintain them for probably for years together and sometimes lifelong on these treatments. So you need adequate ways to keep people in the health system for so as to prevent long-term complications of hypertension and diabetes and other cardiovascular risk factors. So we designed what is called a clinical decision support system. This basically it is a computer-based programs that analyzes data and provides output evidence-based guidelines for patient care. So the key features are that it looks at the patient's current status of diabetes, hypertension, hyperlipidemia. When then we input what his risk factors are, family risk history is, and based on that, it gives an output on what the treatment should be. So this is how typical what we've designed clinics with uh, the tool that we developed. This is basically an app it's a plug and play app, and it can be put into any phone or a tab. As you can see here from our initial experiences, it was being used uh, being used in a phone, but now we have it in a larger tab. And here basically the patient walks in. There is, most of the people, as I said, as asymptomatic, and people coming to peripheral health centers with several other conditions are opportunistically screened. So everybody above 30 years are screened for their hypertension, diabetes by the nurse care coordinator, who then takes a brief history and enters the blood pressure, the sugar of the patient, if available, the cholesterol levels. And then this app, or we call the Empower app, generates what we call, using the clinical decision support system, a patient specific individualized prescription, and which goes to the medical officer, who then obviously is the final authority, and who reviews it and vets it and says yes or no, accepts it or rewrites the inspection, the prescription. So basically, what this, in a very busy, as are most of the medical officers in peripheral health centers are, with so much of communicable and other diseases, these helped this nurse care coordinator, armed with the clinical decision support system, basically acts as an intern or a support staff to the medical officer. And then once the final prescription is vetted by him, it comes back to the nurse care coordinator, who enters in the system, does lifestyle counseling, and then the patient walks out with the treatment plan. But things don't end there. Since the patient is in the electronic health record, he can be followed up with repeated reminders for drug refill, for follow-up, for lifestyle advice. So I'll just present this initial study which we started long back as part of a PhD program 10 years ago. It was done in two peripheral health centers in Solan district of Himachal. And what we saw that um, we almost 50% of the people were first time detected to have diabetes or hypertension in the patient screen, and it led to a marked decrease in the blood pressure, systolic blood pressure, and a 50 milligram per deciliter reduction in the cohort who were diagnosed using the CDSS. So remarkable changes were seen at the 18 months of the study. After that, of course, we've done several such studies. We've done it at the primary healthcare level, where we did a MWellCare trial. Then we did it at a statewide level in state of Tripura, and then we did it as part of an NIH program in Punjab called the iTrek study. And now we have incorporated this CDSS has been incorporated in the National Health Portal, and we hope that it will be rolled out nationwide at some point of time. This is how the screenshots, how the Empower program looks like, where you have to go to the patient, you give the current status of the patient, give the blood pressure measurements, and it gives you an output on what blood pressure medicine should be prescribed. There are several features of the CDSS, and it generates a personalized, as I said, clinical management plan. It identifies risk factors. It helps strengthen the referral mechanism, because we have used in the iTrek the same platform to refer the patient as and when needed. Say, for example, with uncontrolled hypertension, or where the patient, the medical officer feels he needs a high level of care, the same system can be used to upgrade the patient to a higher center. It helps in follow-up prompts, as I said. It helps in secondary prevention, because if people with CVD are prescribed not only the hypertension medicine, but statin and aspirin are also prescribed. So it is kind of a comprehensive prescription for secondary prevention also. So this is how we are in the works, and this has been incorporated in the CPHC and NCD system, and we hope that it's rolled out systematically through the various peripheral health centers. And in fact, in the recent operational guidelines for NCDs, which was launched in May 2023, it also advocates for the users of our CDSS in the health system, calling it a good clinical practice. So the CGHS, CPHC, which there are two, the NCD portal, there are currently two portals. One is CDSS enabled, and this one helps you customize CDSS. It helps in task shifting. It helps modify the NCD clinic flow, and it gives personalized, as I said, diabetes and hypertension management advisories. And we are in close talks with the ministries to both at the central level and the state level, that its adoption may be improved. There were some initial technical glitches, but we are in the process of trying to iron this out. So as I said, this is our several mHealth programs we've done, and as I said, we started with Solon when we did a large clinical trial, which was published in the prestigious Circulation journal, and then the study in Punjab, and the whole state study, which is again published, called the NCD Tripura Initiative. These are some of our several publications coming out of the mHealth Empower app that I mentioned. And now we've also experimented with a very condition called heart failure, where we have very sick patients, and we've tried to incorporate. Again, if you see the guideline-directed medical therapy, or what is called GDMT in India, is prescribed only to 20-30% of patients with heart failure. So there are 4 pillars of GDMT, which is ACE inhibitors, beta blockers, MRAs, and SGLT2, but only about 20-30% patients are actually getting that, and the optimum dose is not reached in 10-20%. So we thought, especially outside tertiary care in clinics, can we implement a clinical decision support system for heart failure patients? This was the study protocol, and this is the study end, and it showed good fidelity, good adoption of the DSS by prompts in the range of 70-80% by physicians. And it was not only in heart failure, forgot to say, but also in patients with coronary artery disease. And there was, as you can see, good acceptability of this strategy we call the CQUIP strategy at the end of study by patients and providers. What it did, if you can see, is the intervention arm or the CQUIP strategy and the usual care arm. It led to improvement in the antiplatelet use. It led to better lipid lowering. It led to higher use of beta blockers. And again, the GDMT for CAD was significantly improved in this pilot study. So again, there is scope to go beyond using digital technology to go beyond just diabetes, hypertension in more serious illnesses like coronary artery disease and heart failure. There have been several contributors to this study. We at AIMS Delhi have been one part of it. We have partners in the CCDC or the Center for Chronic Disease Control. We've had partners with the international partners like Emory and PHFI and several institutions who have really helped us partner in this journey. I think I'll stop there and thank you all for your patiently listening.
Thank you, sir. Thank you for enriching us. Any question from audience? If no question, then it's over. We are going to close session.
I would like
Thank you, sir. Thank you.
Thank you very much.
I would like to sincerely thank all our esteemed speakers and our chairperson for their insightful session. I would request Mamta ma'am from Department of Obstetric and Gynecology for the thank you note.
So with this, we come to the conclusion of today's session of this AI conference. I sincerely thanks to all the esteemed chairpersons for their sharing their valuable insights and our respected chairpersons and our delegates for their active participation. The discussion today have highlighted how AI is shaping our present and future. So let us carry this learning forward in our work and innovation. Thank you all and have a wonderful day. On the behalf of organizing committee, I inviting you all for the dinner today around 7:30 to 8 p.m. at the same venue where we had lunch. Thank you all.
I would request Dr. Sandesh sir for the felicitation to reach the selfie point for felicitation. And Dr. R.K. Singh sir to reach the selfie point.